Hello.
Good morning, everyone. On behalf of Hepatitis Foundation of Tripura, I gladly welcome you all to the second day of LIVERCON 7. A journey of 1,000 miles starts with a single step. This quote of Chinese philosopher Lao Tzu astonishingly fits our situation as well. With its inception on 28th of July 2002, Hepatitis Foundation of Tripura started with a small step, and now, 22 years down the lane, we have come a long way. Starting with the modest aim of spreading awareness about a highly fatal but preventive organic disease, to getting one of the highest hepatitis vaccination rates in the country, HFT has tried to cover every nook and cranny through which liver disease can hit us. Theme being emergencies in hepatology, yesterday was quite an eventful day, starting from a splendid session on how to actually come to a diagnosis, moving through hardships of managing recurrent hepatitis, unruly ascites, to probably interpretation of liver function tests, and importance of lifestyle modification and proper nutrition as a preventive measure. So without any further delay, let us start the second day of HFT LIVERCON 7. The inaugural session of the day has been named as Liver Disease with Difference. To chair this session, I'd humbly request Dr. Shomen Chaudhary, Dr. Proshun Bhattacharjee, and Dr. Jagadish Namosar to grace the dais. May I also invite our first speaker of the session, Dr. Harshad Devarbabi, who would be speaking on acute fatty liver of pregnancy, diagnosis, and management. Sir, over to you.
Good morning. Welcome to the second session. It's day 2 of the second session. I welcome you, sir. I will be speaking on acute fatty liver of pregnancy, diagnosis and management. This is a very important topic because we have to differentiate between HELP and acute fatty liver pregnancy. Welcome you, sir. Please go.
Thank you very much for the kind introduction. And I'll start by acknowledging Dr. Pradeep for invitation for this wonderful place. This is the third or fourth time that I'm coming here, and I'm really astonished at the advances that this city has made. So my task today is on pregnancy-specific liver disease, is on acute fatty liver of pregnancy, AFLP, but I also will be talking about other diseases that can mimic acute fatty liver of pregnancy. So as usual, I usually start with a case, and this is a 29-year-old lady, primigravida, 35 weeks gestation, has this anorexia, nausea, epigastric pain for 3 days, jaundice, tachycardia, and blood pressure just about normal. She's pregnant, no hepatomegaly, splenomegaly, as well as no ascites. She's drowsy but oriented, and you notice that the total bilirubin is of 14, direct is 11, AST about 2-3 times elevated, ALT is about 3 or 4 times elevated, and alk phos is 922. Hemoglobin 11.4, WBC 17,000, platelets low 1.14 lakhs. The INR is elevated, 3.4. Glucose is a little lower, 68, and LDH is 473. Ultrasound shows the liver of 12 centimeter and coarse, mild ascites, and spleen is normal. So before we delve into what the diagnosis is, there are certain physiological changes that take place in pregnancy. On the left-hand side, you'll find that there's no change. The liver function variables remain the same. The bilirubin, the transaminases, the INR, bile acids, and liver and spleen size remain the same. But if you look at the right, what changes is that the blood volume increases, because of which the hemoglobin drops and the albumin drops. Because of the placental contribution of alkaline phosphatase gets elevated. And due to certain changes in the mitochondria in the pregnant lady, the triglycerides increase as well as the cholesterol increase. Now, when you have liver diseases of pregnancy, you can divide them into coincidental liver diseases, chronic liver diseases, as well as liver disease unique to pregnancy. Okay, they all can present about the same. So you need to distinguish which one of the many they are from. So in coincidental liver diseases, you have viral hepatitis. It's very common in this country. So viral hepatitis is common. Herpes simplex, again, very common in pregnancy. Gallstones, again, very common. Budd-Chiari syndrome, malaria typhoid. Malaria typhoid, leptospirosis are common, not in just men, but everywhere, also in women. And then you have chronic liver diseases. So patients can already have chronic liver disease like hepatitis B, C, Wilson's disease, autoimmune hepatitis. In a non-alcoholic fatty liver disease, again, increasing in prevalence because of the increasing incidence of obesity. But what is more important and unique to pregnancy are a few diseases. Starts from hyperemesis gravidarum, which in some instances of severity can increase AST and ALT. You have intrahepatic cholestasis of pregnancy, preeclampsia and preeclampsia-associated HELP syndrome, and acute fatty liver of pregnancy. Now, the other way of looking at things is to just divide them into which trimester of pregnancy does the liver disease occur. And that again gives you a clue as to what the diagnosis. And this slide will clearly tell you that if you divide them into 3 trimesters as well as pre-pregnancy state, chronic hepatitis, autoimmune hepatitis, genetic causes like Wilson, they can all be there right from the beginning and can go through pregnancy, different trimesters. Then you have hyperemesis gravidarum that invariably is in the first trimester, but if it's severe, can linger on in second as well as third trimester. And then you have intrahepatic cholestasis that comes in the second half of pregnancy, and until the delivery, it continues to persist. So if a disease comes in the second half with itching, then it's intrahepatic cholestasis of pregnancy. Preeclampsia and eclampsia associated HELP again comes in the second half of pregnancy, whereas acute fatty liver of pregnancy comes in the last trimester of pregnancy. And even though you deliver, the symptoms can linger on for a few days or a few weeks following pregnancy, after delivery. So in this patient who had liver disease in the third trimester of pregnancy, the 3 probable causes could be HELP syndrome, AFLP, herpes simplex, or Budd-Chiari syndrome. But there are distinguishing characteristics that tell you probably Budd-Chiari is out, herpes simplex is also out, although I'll give you a case of herpes simplex. The only differential diagnosis is between HELP as well as acute fatty liver of pregnancy. Now, what are the clinical and laboratory features between HELP and ALP? They are more or less the same, except that they vary in some severity. So you find that the altered sensorium is perhaps much more common in patients who have AFLP, but can also occur in patients who have HELP syndrome. Hypertension is common in HELP syndrome, but again, in some patients with AFLP, you still can have hypertension. And then with regard to laboratory tests, all these features, thrombocytopenia, coagulopathy, acidosis, kidney injury, and all the liver test abnormalities, including hyperbilirubinemia, again can be seen in varying intensity in patients with either HELP syndrome and AFib. It clearly does not help you differentiate one from the other, although one is at least in HELP syndrome, it's a little lesser variety. But hypoglycemia is again due to a mitochondrial disorder, and it's very, very common in patients with acute fatty liver of pregnancy. Now, how do you diagnose them? And this is one of the things known as the Swansea criteria. They have a set of 14 criteria and they use it. But I mark these things to tell you how soft these criteria are. Anybody with any disease can have abdominal pain, and you have elevated bilirubin is not even 1. 18 micromole is about 1. So even if you have a marginal, just a tinge rise of bilirubin, it is one of the features of AFLP. Leukocytosis, 11,000. If you run and just come to this venue, probably your total count can go up. So you can fit in one of the criteria. Elevated transaminases, which is the rising tide of non-alcoholic fatty liver disease and obesity. I think a lot of people have an AST, ALT more than 42. And then with regard to impaired creatinine, 1.5 again is one of the criteria, and coagulopathy mild. So they've used this mild criteria as one of those differentiating criteria for Swansea criteria. And I have a problem with this criteria. With regard to HELP syndrome, this was established several years ago. They used the they'll use the platelet count to divide them into complete HELP and incomplete HELP. And you'll notice that depending on the degree of decrease in AST platelets, they can divide them into complete HELP and incomplete HELP. Again, elevated AST is 40. 40 you see very commonly. So, and again, in most diseases in hepatology, the rise in AST, ALT doesn't really correlate with the severity of liver disease. Now, you should remember that when you say liver function test, it's not really a liver function test. It's liver biochemistry or liver biochemical test. This doesn't really check function. AST, ALT, alk phos, and GGT is not function. It's a marker of liver injury, so it's not function. The only function is acute viral hepatitis, because India is endemic in viral hepatitis. So that is the first distinction, whether you need to do this or that, because treatment differs. And this we published several years ago because it always bothered us. In healthcare settings, they say geography depends outcome. Where you live actually plays a big role in outcome. And that is because if you live in a bigger center where all the tests are available, you can get a test done fast and make a distinction. But if you are in a patient which is remote from centers, you don't really require an ICU bed to make a diagnosis. Just because even if you're far away from a big center in a remote village, you can make a distinction between specific diseases related to the liver and acute viral hepatitis. Diseases related to the liver, pregnancy, you need to expedite delivery. Viral hepatitis and as well as pregnancy, you need to conserve the pregnancy. So what does help between viral hepatitis as pregnancy-specific diseases? And this is what. If you find a lady has hypertension, encephalopathy, and ascites, it's perhaps more likely that they have pregnancy-specific liver diseases. Platelets low, again, likely to be HELP as well as AFLP. And look at AST and ALT. In pregnancy-specific disease, it's about 3, 4, or 5 times elevated. Whereas in viral hepatitis, it's generally 10 times elevated. You can always make a diagnosis of viral hepatitis by doing the serological test. But serological tests, the turnaround time, I don't know how much it varies here. At least in our institution now, it's about few hours to 1 day. But when we started the study, it used to be 3 days. People do it much more frequently now. So it's much easier to get a diagnosis rather than earlier. So in remote settings, you can use these subtle criteria to make a diagnosis of one or the other. Now the next thing is, if you have made a diagnosis, how do you assess the severity of the disease? Again, there is no clear-cut criteria. The only thing is challenging is that we have to make an early diagnosis in pregnancy-specific diseases. Pregnancy-specific diseases, if you don't make a diagnosis early on, there's increased morbidity as well as mortality, both in the mother as well as the baby. Now we tried to do this, the severity in this, which was published a few years ago. What predicted severity as well as mortality? Again, if a lady has encephalopathy, oliguria or AKI, ascites on ultrasound, hyperbilirubinemia, coagulopathy, and a MELD score. What MELD score will come to the next time? These are all factors that tell you that perhaps this lady is going to have a much severe disease rather than a mild disease. And this patient needs to be shifted or transferred to a bigger hospital. Now this is the thing, we looked at the MELD score. MELD, as some of you know, it's a combination of creatinine, bilirubin, and INR. You make a score. If you have anything more than 20, more than 20, then your mortality really climbs. So you try and assess the severity as quickly as possible and try and deliver the baby before, deliver the mother before complications set in. The same thing was, of course, done in UK, and they noticed that if a lactate level is more than 2.8, it suggests severe disease. And of course, encephalopathy. Once the liver fails much before encephalopathy, I think we attach too much importance to encephalopathy, but we should realize that the liver starts failing much before encephalopathy. So against all diseases, we need to pick up these patients before they develop encephalopathy. Once encephalopathy sets in, it's pretty too late. So important thing, pick up encephalopathy disease before encephalopathy. So how do you try and treat this disease? In AFLP, it's immediate delivery. If you made a diagnosis, you have no room for any other avenues except immediate delivery. At the same time, you have to give intensive supportive care. And nowadays, there's some reports which I'll talk on of a plasma exchange. All these things come after delivery. The patient comes, you stabilize the patient, deliver the patient for acute fatty liver of pregnancy. Whereas after delivery, you can try to do a plasma exchange. And some patients, I know you have heard this, the moment they are delivered, then they recover completely. False. Some patients don't really recover after you deliver them. A minority of patients go on to develop acute liver failure. They may require liver transplantation. And then I come to this again a little bit. Many patients with acute fatty liver of pregnancy have fatty acid oxidation disorder, and the commonest one is L-CHAD deficiency. So you need to screen the newborn for this particular exam and particular enzyme for acute fatty liver of pregnancy. What about HELP? HELP, at least you have some time, some window of opportunity to stabilize the patient. 1 day, 2 days, perhaps even 7 days. You try and give some injections to help in maturity of the baby's lung, but not with patients with acute fatty liver pregnancy. You can do an ultrasound or a CT, and then once you have stabilized the patient, you deliver them. The resolution is generally in less than 5 days, unlike this AFLP, where sometimes they may not resolve. Now, there's a report of, should we go ahead and do a cesarean section to minimize the risks of mortality as morbidity in patients? This is one systematic review. And in this systematic review of several patients, they noticed that maternal mortality rate decreases, perinatal mortality rate also decreases, although there was no association with multiple organ failure. This is a systemic disease, so there was no association. But then you should realize it's not just the mother's condition that triggers the decision to take for cesarean section. Sometimes it's the baby's decision. There's fetal distress, and that triggers. So there's a bimodal modal ways in which the decision are taken. So these are the several complications that can occur, and there are several participants. Basically, it improves maternal mortality, morbidity, but not organ failure. Now, there's a lot of talk about plasma exchange in patients who have acute liver injury as well as acute liver failure in hepatology. And similarly, there's a lot of treatment, a lot of reports of postpartum exchange in acute fatty liver pregnancy. These are all the several case reports that have been published from 2008 to 2013. And I all listed here, but I'll give you a summary of those results. And this is a summary. Out of 86 patients or reports, you find that survival was about 80, 5 died, and 1 had a liver transplantation. So again, goes to show that perhaps it can be useful, although it has not been tried in a randomized fashion. People just use it because of the sheer scale of severity of the disease. Now, these were till 2008, but this is a recent study published from China last year. Okay, assessment of patients with AFLP with plasma exchange. And you see they always have huge numbers, 290 patients, and 240 survived, 50 didn't. So in that patient, 79%, that's 27% of patients underwent plasmapheresis. And you notice that here, 0.39. Whether they underwent plasmapheresis or not, there was no real difference in patients who survived or not survived. But if you read the article, if you go a little deep, then they do sub-analysis. And I always have this thing, if you torque a data too much, it can confess to anything. So this is the basic thing, that if you do it very sincerely, simply, it doesn't really make a difference. But if you go on talking the data, you'll always find something to help you show that it is useful. Now then, I said some patients can have the need for liver transplantation. And again, these are the series that patients have undergone liver transplantation. Small numbers from different centers. I highlighted these two just to tell you that you have all heard that pregnancy-specific liver diseases, the moment they deliver, everything is hunky and dory, the mother is going back to be normal. No. You'll find that here, despite delivery, you find that transplant was done at 5 days, 8 days, 5 days, 10 days. So some of them don't really recover. So you need to keep a hawk-like eye on these patients till they really recover. And again, differentiation between HELP syndrome, you find that practically everybody here, except for one, had, you see this? Where if you look at the platelets, the second line, the platelets are all low. So again, in a patient who comes to you, it's very difficult to differentiate between acute fatty liver and HELP syndrome. So you have a combination of both, or overlap of both. And I mentioned to you, basically, we need to check these babies for fatty acid transport oxidation disorders, FATMO disorders for small chain fatty acid, medium chain, and large chain. Now, this is a very peculiar thing, and I'll show you what is peculiar about this. In most inborn errors of metabolism, most inborn, if the mother is a carrier and the fetus is affected, the mother protects the baby. The fetus is not affected. Whereas if many of these fetus who are affected go on to become mothers, and then it's called as a neutral, it doesn't really affect the pregnancy. But except for one disease, and that is maternal phenylketonuria. Because a mother is a carrier and is affected, and if you don't treat the mother with appropriate phenylketonuria diet, even if the fetus does not have a disease or only is a carrier, because the mother is affected, it still causes harm because of overwhelming amounts of phenylketonuria in the blood that crosses the placenta and impacts the baby's brain, giving rise to cognitive deficit. But in FATMO disorder, pregnancy-specific diseases, the thing is ulta. The mother is a carrier, it's just a heterozygote carrier, she just carries one gene. Whereas the fetus is affected, she's homozygous. But the sheer amount of fatty acids that are produced go across the placenta and overwhelm the maternal mitochondrial machinery. The poor mother actually doesn't carry this disease. But the number that is the acids that are produced just overwhelms the maternal mitochondrial system, and she develops acute liver failure. It's a very tragic situation. It's a ultitis. So then my final part of my talk, and I want to stress this, and even if you forget all that I have talked about, remember this one that I'm going to talk about, I think it will be fruitful. Now, pregnancy diseases, you sometimes can have what is known as unconventional viral hepatitis, which can present like acute liver failure in pregnancy, and I'll start with this case. A 27-year-old lady develops fever on the 32nd week of gestation, no medicines, 39 degrees Celsius, again drowsy, doubtful jaundice, ALT 3,600, ALT 5,000, so very high AST in ALT, and very, very minimal rise of bilirubin, 2.2. And again, coagulopathy, 1.9. Something is not well. She's not intensely icteric like a patient who has acute fatty liver of pregnancy, but you'll find that the transaminases are in thousands. The following day, she's still febrile, light fever, not the fevers that you see in malaria and typhoid fever, etc. ALT 3,800, ALT still 5,000, bilirubin climbs 2.4, ultrasound negative. So, nowadays at least we have biopsy facilities available, including transjugular biopsy. So this patient underwent a transjugular biopsy. And here you find the herpes nuclear inclusion in the body. You find a lot of necrosis in the lower end of the slide, a lot of cells. Plus you find intranuclear nucleation. So once you have a cytoplasmic intranuclear inclusion bodies, the diagnosis is confirmed. It's herpes. Okay. So the thing is, 23% of herpes, almost a quarter of all herpes hepatitis are reported in pregnancy. Often diagnosed when the condition does not improve following delivery. This is the tragic thing, that everybody thinks it is pregnancy-specific diseases. You deliver the baby, they don't improve, and then finally the patient dies, and then you realize patient had. So not only here and all over the world. But importantly, if you see the next patients here, if you see, there are certain clues, and I think we have to look at these clues. It's a young patient, females more in herpes simplex. The immune suppressed, but most patients need not be immune suppressed. Fever is the clue, and the slight fever that goes on. Herpetic lesion is seen about 50%, and women particularly, you can see the herpetic lesion in the vagina. So they will tell you that there are certain, you have to look at that lesion. Transaminases are in several thousands. Normal meal, no bilirubin. Encephalopathy, and then 50% unfortunately are diagnosed after death. So, you know, when you look at them, even if you find some skin lesions elsewhere, and particularly in the vaginal area, in the private area, you do a Zang smear. You don't have to do exotic DNA tests, which take about 3 days to come and cost about 6,000 rupees. No, you do this test and you'll find a multinucleate giant cell. Lo and behold, you have made a diagnosis. And I'll tell you why you have to make a diagnosis, because if you don't make a diagnosis, the mortality is, you know, here it is. If you don't make a diagnosis, you know, mortality is about 88%. It's very tragic. You lose the baby, you lose the mother. So this is one disease where once you have made a diagnosis, AST, ALT, several thousands, bilirubin little elevated, little fever, yes or no, or skin lesion, you have to treat this pregnant lady with acyclovir. Have to. It empirically. Acyclovir is so cheap. In fact, the entire duration of the cost of the entire duration of acyclovir is less than the cost of herpes simplex DNA. So it's so easy. So you have to treat empirically, and you see what happens. Once you treat empirically, you reduce the mortality by almost 50%. Whereas if you don't treat, it's almost 90%. Again, so this is one of the things that I really want you all to carry. That in a patient who has got sky-high astronomical AST, ALT with minimal rise in a pregnant lady, and even sometimes non-pregnant lady, please think about herpes simplex hepatitis and treat empirically. Send the blood test, do all kinds of tests, but treat empirically, because if you are delayed, then the mortality is high. So I tried to show you some slide where how you differentiate between herpes pregnancy-specific liver diseases versus viral hepatitis. So if somebody has little hypertension, some ascites on ultrasound, low platelets, likely to be pregnancy-specific liver diseases. Morbidity, mortality, despite so much of advance in medicine, still unfortunately high with regard to maternal mortality as well as mortality. So early delivery is the key in AFLP, and perhaps you can wait a few days for HELP syndrome. Then, and I told you we need to assess the easiest, and everybody knows this, a MELD model where you use 3 criteria, bilirubin, INR, and creatinine is a good prognostic model. And then I told you that these patients have fatty acid oxidation disorders. So you have to, nowadays these are available, especially in higher centers, you can do it. But again, if there's only one message that this talk can, if it is fulfilled, that is, please think about herpes simplex hepatitis in men as well as in women, particularly in women, both immune compressed and non-immune compressed. When the enzymes are astronomical, AST, ALT is elevated, as well as the bilirubin is mild coagulopathy, and treat them with acyclovir. Once the result at least comes back negative, you can always stop it. But if you don't, then the mortality is close to 80 to 90%. Thank you.
Thank you, Dr. Harsha, for nice deliberation. It is a real challenge for us clinicians like us to manage acute fatty liver of pregnancy in our practice, and I invite queries from the audience.
Very nice presentation, sir. Plasmapheresis in pregnancy. See, pregnancy is a hyperdynamic circulation. It's already hypercirculated. Whether the risks of cardiac and this trachea and other complications increased in plasmapheresis group?
You want to know whether the risks, all these risks are increased in plasmapheresis?
Yeah, those in pregnancy compared to this normal
non-pregnancy patient.
Yeah.
You know, the reports haven't looked at pregnancy specific versus non-pregnancy specific. This criteria that the Chinese study that I mentioned, about 79 odd patients, didn't say that the risks were much particularly more in these patients. You also should realize that many of these hyperdynamic changes that occur in these patients, the moment that they deliver, those changes revert quickly to normal. Right. They can revert quickly to normal. Whereas the changes due to hepatocellular dysfunction takes much longer. So you find the cardiac output decreases, all those things come on. So my gut feeling is perhaps if you are a little careful, you can obviate all of these problems.
Right. Thank you.
Thank you, sir. Thank you very much for your wonderful presentation, as usual. My first question is on, nowadays also, as you have said, that we do get a lot of patients who look like viral hepatitis but not really viral hepatitis, or something like non-viral hepatitis others. What is your comment about it, and how do we suspect and how do you should treat all these patients?
Yeah. So if you have certain things, then it's clearly likely to be viral rather than non-viral. You find that if you look at the AST and ALT, is one clue. Both acute fatty liver of pregnancy and to an extent HELP syndrome, these are mitochondrial disorders. You find that the AST ALT is generally about 200, 300, 400. You will not find AST ALT in thousands, not 1,000 or, except perhaps in rare patients with HELP syndrome because of ischemia, infarction, you may find it. The bilirubin can elevate it in both, but in patients who have viral hepatitis, the conventional viral hepatitis, and even the unconventional viral hepatitis, let's say it's CMV viral hepatitis, Epstein-Barr viral, you have a raise of AST and ALT, but you also have a tremendous rise, disproportionate rise in alkaline phosphatase and GGT. And again, if you look at all the other conventional viruses, for example, let's say dengue, okay, dengue. Now, dengue produces astronomical rise in, just like the way it is herpes simplex, dengue hepatitis also produces astronomical rise of AST, ALT with minimal rise in AST. So in that case, I think you just have to give supportive treatment in this patient. If you think that you have not made a diagnosis of, or if you're not clear of a diagnosis of pregnancy-specific liver diseases, then you just have to give them supportive treatment and hope that they come out. Because there has been no evidence whatsoever in mankind that if you have treated patients with supportive care in pregnancy-specific liver disease, they improve. They don't improve. All of them have more died, all of them. Whereas in patients who have non-pregnancy liver diseases, and due to viruses or whatever, many times supportive treatment is all that is required.
Sir, in that case, what is the role of or indication of liver transplantation during pregnancy, and what is your experience about it?
Yeah, if you find that in pregnancy-specific diseases, the numbers are increasing. And in one study that is in the maximum series is actually from US, about 38, 40 patients were sent for transplant after they made a diagnosis because they were really sick, acute liver failure. The beauty is, as I said earlier, that almost 50% of patients improved while they were waiting for transplantation. Because these patients, as I said, after they deliver, many of them improve, but some of them don't really improve. So if they don't improve, you can see them day by day. Sometimes within 12 hours, you can find that they are improving. But I've seen patients who are talking to you, walking, everything, but despite everything, they just slowly progress. You have a window of opportunity where you can transfer these patients to higher centers. But while you have that window of opportunity, you also have that window to see whether they're progressing or regressing or improving. And if you're improving, of course, you can always see them here. But if they're progressing, you can transfer them in about 1 or 2 days' time.
Okay. Thank you, sir.
Thank you.
Thank you, sir, for your wonderful session. I would like to take this opportunity to invite our esteemed chairpersons to present a token of appreciation to our speaker. Have a big round of applause for our speaker. Thank you so much, sir.
Now we move to second topic of session 6, current understanding of autoimmune hepatitis. And I request Dr. Amritanshu Bargatugui, please come on the stage and start your deliberation. Thank you.
Good morning, everyone. Thank you, Bhomik sir, and good to see Dr. Gurdas Sodri sir, my teacher. As our previous speaker has said, this acute presentation like viral hepatitis. So this is one condition which can mimic viral hepatitis, and then it's quite common in our society also. So previously it was thought that it is a mainly of disease of the Western, but the cases are coming. And so what is autoimmune diseases? Mainly it's like rheumatoid arthritis, where the joints are affected by our own body cells. So our bone immunity destroys some particular organs, like vitiligo, the skin is affected, like rheumatoid arthritis, where joints are affected. And here, the immune cells attacks our own liver cells. So we'll come up with a case who has a similar kind of viral hepatitis like picture with fever, jaundice, arthralgia, myalgia, and you can see icterus. And she was a normal, middle-aged female with history of hypothyroidism, and on clinically palpable liver and spleen. So on clinical palpation, we see there was icterus and hepatosplenomegaly. Then we looked up her previous liver reports, and you can see there were fluctuating levels of SGOT, SGPT over the last 1 and 2 years. So SGOT, SGOTPT like thousands, then again coming back to 200, then again 70, 80. So fluctuating levels of hepatic enzymes and sometimes bilirubin also. And she was treated in local hospitals with commonly used drugs like UDCAs and other supportive measures. And detailed evaluation was done, and finally we went ahead with liver biopsy. And then we see all the viral markers like hepatitis B, C, A, E, everything were negative. All the metabolic parameters like Wilson's and NAS, and obviously she was non-alcoholic, everything was negative. Then we went to have the autoimmune markers, and we found that ANA and the other autoimmune markers were positive, and her liver serum IgG levels were very high. We went to have the liver biopsy, and we showed there was significant inflammation, even there was significant fibrosis on the right upper side. You can see there is significant fibrosis and even cirrhotic nodules. So we made a diagnosis of compensated cirrhosis, which was related to autoimmune hepatitis with high titer of autoimmune markers, high IgG elevation, and suggestive features of liver inflammation on biopsy. So index patient with significant SGOT, SGOT elevation presenting as acute viral hepatitis, and on liver biopsy we have seen she was cirrhotic. So this is the quite common picture. Patient develops cirrhosis within a span of 1 to 2 years in patients with autoimmune hepatitis if we don't diagnose them early. So what is autoimmune hepatitis? It is an immune-mediated destruction of the liver cells in a genetically susceptible patient, which is characterized by autoantibodies, certain HLA phenotypes, high IgG titers, and there are some significant or clinical clues on liver biopsy. And the most important factor is response to immunosuppressants like steroids and other drugs, which are hallmark of the disease. The spectrum of autoimmune liver disease includes the level of destruction, where the actual target of the immune-mediated destruction. If it is the liver cells, it is called autoimmune hepatitis. It involves the smaller intrahepatic bile ducts, which is called primary biliary cirrhosis or primary biliary cholangitis. If it involves the larger ducts and the restriction and dilatation of the larger bile ducts, it is called primary sclerosing cholangitis. And there is considerable overlap between, since it is an intrahepatic or extrahepatic phenomena, so the destruction might have some overlap between the hepatocytes and the bile ducts. So we have some overlap syndromes of autoimmune hepatitis with PBC or autoimmune hepatitis with PSC and other variants. Coming to the epidemiology, initially thought to be a Western disease, and like all the autoimmune diseases, it is more common in females, affects both children and middle-aged adults. The peak of age of onset is between 10 to 30 years in children and between 40 to 60 years. We have multiple data from India, and it was seen that cirrhosis at presentation was up to 76% in our population. So we tend to have a late diagnosis in our patients, probably because our thought process is slightly slower, or initially it was not very well established. Dr. Gurdas Sordari sir is here. He also published some data regarding the clinical profile in India. And the presentation, most of the symptoms were like chronic hepatitis and cirrhosis in 50 to 80% of patient populations. But you can see some amount of acute hepatitis like pictures are also there. And the most common symptoms were jaundice and some non-specific symptoms like fatigue, malaise, and in advanced cases like hepatic encephalopathy and ascites also. Hepatosplenomegaly is a consistent feature in patients with autoimmune hepatitis, unlike in viral hepatitis where liver becomes shrunken. Data from a tertiary care center, PGI Chandigarh, also showed that it is quite common to have autoimmune hepatitis in OPD or indoor patients, in patients with liver disease, and there is considerable syndromes with overlaps also. They also present in our clinics. And the most common presentation is chronic, with either chronic hepatitis or cirrhosis. And the response to treatment in our population is also very good. If you treat them early, the response is very good with immunosuppressants. So my motto is to explain to you that in any patient with liver disease, whether acute or chronic or cirrhosis, decompensated or compensated, you should think of autoimmune hepatitis where the viral markers are negative. Just an overview of immunopathogenesis. It's a complex disease in a patient who are genetically susceptible, and there might be some trigger factors like viruses, or some drugs like minocycline or hormonal therapy, or some viral infections can break the barrier of immune tolerance and make these liver cells susceptible to this immune destruction. The level of destruction, if it involves the hepatocytes, it's autoimmune hepatitis. If it involves the bile ducts, it's biliary predominant primary biliary cirrhosis or PSC. Now, most of the patients have some symptoms, but also minor symptoms or asymptomatic presentation, just simple minor elevation of SGOT, SGOT in up to 25% patients is also seen. So chronic is more common, like chronic hepatitis or even decompensated or compensated cirrhosis. Then the spectrum of acute hepatitis like viral hepatitis, flu-like syndrome, jaundice, anorexia, nausea, vomiting, even mimicking acute liver failure with fulminant presentation is also not very uncommon. Then we have the syndrome of acute and chronic liver failure where the patient presents with acute decompensation on a background of chronic hepatitis. So asymptomatic presentation, just simple SGOT, SGPT elevation is also common in 20 to 25% patients of populations. But you should make a diagnosis with autoimmune markers. We'll come to later on that. Fulminant presentation, like acute liver failure, is rare, but when the viral markers are negative, you should think of this diagnosis. Because some of the patients, they improve with high-dose corticosteroids, and you can save the patient. Acute presentation with acute viral hepatitis, like pictures, is common, and then there is ACLF-like presentation also. So we have data to support that acute hepatitis, like viral hepatitis, like presentation is known to us, and when all the viral markers A, B, C, D, everything is negative, if you give them corticosteroids, then the patient improves. The one important factor is that when acute presentation patient, when they present like acutely, not everybody will have the autoimmune markers. So you might have to go for a liver biopsy also and then start with immunosuppressions. Patients who have background of chronic hepatitis can have a sudden flare, which is called acute on chronic liver failure. Again, you should exclude viral hepatitis, do a liver biopsy immediately, and start corticosteroids and other immunosuppressants, because early steroids or early intervention can improve survival in this kind of patients also. Now, there is no significant, no specific marker to diagnose these patients with acute hepatitis. So clinically, you should suspect whether the patient has an acute or chronic presentation. So any liver disease patient, you exclude the other causes like alcohol, fatty liver, viral causes, and other metabolic causes like hemochromatosis or Wilson's disease. Then you come to the laboratory parameters and you will have the autoantibodies positive. If the autoantibodies are positive, then you go for a liver biopsy. So you need everything, altogether to make a diagnosis of acute hepatitis. Now coming to the autoantibodies, there are a number of autoantibodies, but these are not very specific. These are sensitive markers. If they are positive, that means the patient might have autoimmune hepatitis. Most common is anti-nuclear antibody ANA, and the titer of ANA is also important. Anti-smooth muscle antibodies, and the combination of ANA and SMA is present up to 50 to 70% patients of population. But these are not specific marker of autoimmune hepatitis. Soluble liver antigen, SLA, is highly specific. If we found that this antibody is positive, that is highly specific. For type 2 autoimmune hepatitis, LKM, liver kidney microsomal antibody, is highly specific. So it is mostly seen in children, but also some patients with hepatitis C also have this kind of antibodies. So the type of LKM, whether LK1 or 2 or 3, depends. And the LKM1 is specific for autoimmune hepatitis in children. So coming to the types, whether type 1 and type 2. So there is considerable overlap, but it mainly depends on the types of autoantibody. ANA and SMA is more in autoimmune type 1 hepatitis. Type 2, more common in children. They will have an acute presentation rather than chronic presentation in type 1 hepatitis. They both will have some amount of other autoimmune diseases like the index patient. They will have autoimmune thyroiditis, IBD or rheumatoid arthritis. Type 1 is more common in adults and some children, but type 2 is mostly seen in children in less than 14 years of age. So what is the role of liver biopsy? So if you think of autoimmune hepatitis, if one day autoimmune marker is positive, then next step is liver biopsy. The biopsy findings are suggestive of autoimmune hepatitis. These are not specific. You will have these findings in other conditions like drug-induced liver injury also, but these are suggestive. And the most important thing is you can rule out some other diagnosis like fatty liver and other diseases, and you can prognosticate the patient. The amount of liver inflammation, the amount of fibrosis or cirrhosis. So histological findings are important for diagnosis as well as prognosticating the patient. The amount of inflammation and fibrosis, and then subsequently the response to treatment depends on the biopsy findings. And on biopsy, you will see plenty of infiltration, mainly in the hepatocytes, which is called interface hepatitis, destruction of the hepatocytes, and you will find some amount of necrosis and fibrosis, even findings of cirrhosis on liver biopsy. Now, since there is a definite marker, there is no definite marker of autoimmune hepatitis. So initial criteria was a broad, up to 14 markers they have collected, and they have had a original scoring system like sex, high SGOT, SGPT elevation, the amount of ANA positivity or anti-SMA positivity, absence of alcohol, absence of hepatitis B and C, and the biopsy findings, and the response to treatment. So they have compiled everything, and they have made a score, which is cumbersome, but it's very sensitive. It detects more number of cases. So they have come up with a newer simplified scoring system, which consists of the autoantibodies and their titers, ANA, SMA, and the titer, either it is 1+ or 2+, and then the higher level of IgG or immunoglobulin G, IgG level, the interface or suggestive biopsy findings, and the absence of viral markers. The simple parameters and the absence of viral markers. This scoring system is very specific. If this is not very sensitive, and it detects the cases specifically. Now coming to the differential diagnosis. So there are lots of differential diagnoses. Most important is like viral hepatitis. It can mimic viral hepatitis. It is an ALF mimicker. So you should exclude viral hepatitis in patients with autoimmune hepatitis. Obviously alcohol and non-alcoholic fatty liver disease. And the drugs. See, every jaundice patient will consume some amount of herbal medications. So drug-induced liver injury or DILI is quite common in our society. So it can mimic autoimmune hepatitis. Also, it can break the barrier. This sometimes after taking some amount of herbal medications, the autoimmune hepatitis gets flared up. So it can unmask the immune barrier in some patients also. And then genetic causes like hemochromatosis, Wilson's, and iron overload also should be considered. Now, whether to treat everybody? Yes. If you detect autoimmune hepatitis, since it is a very aggressive disease, like I have shown that index patient who already had cirrhosis at presentation. So the guidelines recommends that those who have active disease should be treated. All patients should be treated, except some burnt out cirrhosis, like already decompensated, very cachectic and burnt out cirrhosis with no high SGOT activity, but that means the liver enzymes are normal and the liver biopsy is also inactive, just cirrhosis, no inflammation. Only those patients you can avoid some treatment because that is not going to help. But otherwise, every active patients with high STLT elevations, high autoimmune markers, or histologically if you find there is inflammation, you should treat. Our apostle guidelines also recommends that all patients with high liver enzymes, high IgG levels, increased liver stiffness on fibroscan, or histologically there is inflammation, you should treat. So what are the drugs for autoimmune hepatitis? The first line drugs is steroids. There are two types of steroids used. One is budesonide, which is milder form of steroids. Then we have the conventional prednisolone, and then azathioprine. Now budesonide is acceptable in non-cirrhotic patients who doesn't have acute fulminant presentation because it works in a milder form, and in cirrhotics you cannot predict the enterohepatic circulation, and this metabolism is not very predictable. So budesonide in non-cirrhotic young patients where you want to avoid the long-term side effects of corticosteroids. But those who present with chronic hepatitis, cirrhosis, and acute presentation, prednisolone is the drug of choice, with or without azathioprine. Since these have many side effects, we have the second line of drugs who doesn't respond to corticosteroids or azathioprine, like CNIs, tacrolimus, mTOR inhibitors, or MMF. Now the European guidelines recommends you should start with a high dose of corticosteroids, and then after 2 weeks you add azathioprine. Why? Because AZA sometimes can cause some amount of cholestasis and liver dysfunction, so it is very difficult to ascertain whether it is the disease progression or whether it is related to AZA. So start with high dose corticosteroids, 1 mg per kg body weight, wait for 2 weeks, you monitor LFT, and then taper corticosteroids, and then you add azathioprine. Our apostle guidelines recommends a lower dose of corticosteroids. It was seen that it is equally effective. For initially, you start with a combination therapy of 20 plus 50 mg. Or if you start as monotherapy, you just have to add 40 mg of prednisolone for 2 weeks and gradually taper. This tapering should also be very gradual. It is not like very, every week you will taper, because again, it can flare up. So this is the most important slide. So severe acute, on the right side, you can say severe acute AIH, like fulminant presentation, acute liver failure, or acute and chronic liver failure. The drug of choice is high dose corticosteroids, prednisolone, whether IV or oral. You should not add budesonide immediately because it will not work in acute presentation. You monitor LFT every 2 to 3 days, every 12 to 48 hours, whether this patient is improving or deteriorating. If the acute patient deteriorates and develops like hepatic encephalopathy or goes into high INR and liver dysfunction and liver failure, then you have to refer them for liver transplant, because if it doesn't respond to corticosteroid, that means they will require liver transplant, otherwise they will die. AIH with cirrhosis, like the first patient, compensated or decompensated, the drug of choice is steroids again, which is prednisolone. In cirrhotics also, you should not start with budesonides. You start with prednisolone. Azathioprine you should avoid in decompensated cirrhosis. In compensated, which is compensated patient, no ascites, encephalopathy, or liver cancer, you should start with prednisolone. If there is decompensation, you avoid azathioprine. You monitor LFT every 1 to 2 weeks, and then gradually taper the corticosteroids, and then you maintain them on a low dose of corticosteroids with azathioprine for a longer duration. Those with cirrhosis and acute presentation, you will never stop this corticosteroids and azathioprine, because if they develop relapse, which is quite common in autoimmune hepatitis, they will die of acute and chronic liver failure. So cirrhotics and acute presentation, you will continue lifelong immunosuppression. But the stable patients, like asymptomatic patients or mild chronic hepatitis, those patients, you will start either with budesonides or prednisolone. Then subsequently we add azathioprine. If they maintain remission, that means if the liver enzymes are normal and histology is normal, then probably you will try to withdraw some amount of immunosuppression. But the relapse is again a rule in patients with autoimmune hepatitis. Since the antibodies are still there in your blood, so relapse is a rule. Up to 80% patient will relapse. So once a patient develops a relapse, again you will start like the baseline treatment with high-dose corticosteroids and azathioprine, you will never stop. But 20% of patient will maintain continuous remission after remission and stopping of immunosuppressions also. But you will try only those patients who are non-cirrhotic and not with like acute presentation. Stable patients with normal liver enzymes after treatment, you can try stopping of immunosuppressions. Then you monitor them every month if they are relapsing or not. If doesn't relapse, then they will be off immunosuppressions. If they relapse, you will continue immunosuppression. Now, since corticosteroids have a long list of side effects, azathioprine will cause bone marrow suppressions and other side effects, we have the second line of drugs, and the most useful is the CNIs and the MMF. And it is seen as if these drugs are not tolerated or not working, these drugs also works. But again, these have some side effects, and you have to individualize the treatment according to the drug's response and the side effects. To summarize, autoimmune hepatitis is not uncommon in our society, and the presentation is like acute presentation or like acute hepatitis or chronic hepatitis or even cirrhosis. So every patient of liver cirrhosis or liver disease where the viral markers are negative, where there is no alcohol, you should think of autoimmune hepatitis and then work subsequently. The presentation is variable like acute, subacute, chronic and even cirrhosis. So you should have a high index of suspicion. The most important, the clinical parameters. Viral markers are negative, then having jaundice and hepatitis, so you should think of autoimmune hepatitis. The most important thing is the presence of autoantibodies and the biopsy findings. One good thing about this disease is if you treat them early, they will respond like anything. So and then subsequently the mortality and morbidity related to liver dysfunction, cirrhosis can be prevented. And the individualized treatment, because the drugs are lifelong, then they will have significant side effects. So individualized treatment is important. Thank you.
Thank you very much. We are very much enriched with this enlightenment in the autoimmune hepatitis, which is very much a need of the hour. So it has been described very nicely, elaborately. We like to thank Dr. Amritanshu once again. And now we can hope that some question will come, and it is open to the spectators here.
Thank you, sir. Sir, I am having one query. As you know, if you diagnose early, we can prevent cirrhosis. Then, is there any screening test? Because all the autoimmune markers are very much costly. Then we can advise that it's less costly test. Any screening that?
Screening means?
No, all the markers are very much costly if we
yes,
advise.
Yes, these are costly, but these are important. If you think of rheumatoid arthritis, you will require anti-CCP or rheumatoid arthritis, right? So if you think of autoimmune hepatitis in a female who is non-alcoholic, who doesn't have the viral markers B and C, and viral markers are negative, she is not very obese also and have high and low liver enzymes, you will require the liver enzymes, autoantibodies. Biopsy, see, it is not it is required for diagnosis, but by performing biopsy is not available everywhere. It is also have some complications. But apart from biopsy, you will require autoimmune markers. Not all the autoimmune markers. You know, in younger patients, at least ANA, SMA, and less than 14 years of age, LK1 antibodies.
Thank you. Is there any question from that? Then we conclude the session. Thank you.
Thank you. Thank you, sir.
Thank you, sir, for your wonderful session. Before moving to the next segment, may we invite our chairperson to present a memento of our appreciation to our speaker. May I have a big round of applause for our speaker. May I have the honor to request Dr. N.L. Bhumik, President HFT, to come upon the dais to present a memento of our appreciation to the respected chairpersons. Thank you. Have a big round of applause for our chairpersons. There has been presented Health Adda by our author, Dr. Gauradas Chaudhary. Thank you, sir. Now we move to our next session, the HFT oration, a highlight in our event. We are honored to have with us a distinguished speaker, Dr. Gauradas Chaudhary, a renowned expert in the field of hepatology. Dr. Chaudhary will speak on the topic, Conquering Hepatitis from Lab to Street. To chair the session, I would humbly request Dr. N.L. Bhumik, Dr. Mamun Al-Mahatab, Dr. Pradeep Bhumik to grace the dais. Please join me in welcoming Dr. Gauradas Chaudhary to the dais with a big round of applause.
Good morning, everybody. I was thinking, before coming to the dais, what should I say and from where I should start. I thought number of times I should say that this is a prestigious oration, HFT oration, but I could never utter that way. You know why? The reason is, this oration only will be prestigious after the deliberation of Dr. Gauradas Chaudhary. Because before that it cannot be prestigious. The person like Gauradas Chaudhary, if speaks something in this auditorium and on a issue for which the Hepatitis Foundation of Tripura is working for last 22 years, there is a great occasion for all of us. And we will remember this event for a whole lifetime. This is something like a lifetime program for the Hepatitis Foundation of Tripura. And it is customary to say something about the person who is delivering the session, the oration. And I was thinking again, times and again, what to tell. Then I found, if I start telling about Sir, then the whole time of this oration will be over but my discussion will not be over. So I thought let us stop it here only. I will not take time because he is the person, he is a stalwart, he is a person of the country, he is not from Delhi or any other state or country or any other place. Rather, he represents India. This is something like Dr. Gurdas Chaudhary India, a letter will reach to him. And we are very fortunate that he is here. It is his own word. By default, now he is working in a corporate hospital, Fortis Memorial Hospital at Delhi, Gurugram now. But basically through and through, throughout his whole life from MBBS to HGPGI, when he retired from HGPGI as head of the department and mentor of the HGPGI Lucknow, he is one of the person who has built the department from very small issue pin to now the present shape. You, as you know, all know that where the HGPGI is. And he is the person who built it. It's a great occasion. And he is, again, not only a teacher, but he is a researcher. He is a philanthropist. And he has got many social activities in his credit to go. And we, the Hepatitis Foundation of Tripura, is not only associated in his academic life, but with his philanthropic and socialist activity. So, without taking much of your time, just and without going in a normal manner of introducing Dr. Gurdas Chaudhary, I choose to use these few words before starting the oration. Now, the foundation is really proud to offer him the first ever oration of the Hepatitis Foundation of Tripura LIVERCON and Padma Ganga Gomati, that HFT oration. I request our President, Dr. Anil Bhomik, our mentor and the Technical Director, Dr. Ajit Ranjan Chaudhary, our General Secretary Dibakar Devnath, and our Scientific Committee Chairman, Dr. Abhik Chakraborty, to please come to the dais and honor him with our our system of honoring our orator. Please, Avik, Dibakar, and Ujidda. Nanda, please. चलो तुम भी चलो
Good morning. This is nice to felicitate a great man. Dr. Gurdas Chaudhary is awarded HFT Oration 2024 as commendation of his brilliant lifetime achievement as an excellent clinician, orator, researcher, and social activities. We are proud that HFT could take a responsibility to have an opportunity to felicitate you, sir. Now I welcome Dr. Gurdas Chaudhary, sir, please. And it is customary not to ask any question in the oration session.
Thank you very much, Pradeep and Dr. Bhaumik and HFT for this big honor. You know, when the hype is created before the oration, the expectations go up. And I'm a little worried because, you know, I think let's talk as 1:1 individuals. Don't expect a very hi-fi oration, but I'll be talking to you as one of you and giving you certain perspectives about how to control or conquer hepatitis. I'm very fortunate to be invited here every now and then, and the warm relationship I enjoy with Agartala. So hepatitis, from lab to street, is the talk. So as you can understand, I don't see too many postgraduates here. So the lab part is not likely to be very exciting to many of you, probably. Are there any postgraduates here? Oh, good, yeah, you presented the case yesterday. What happened to your colleagues? They didn't come? No problem, just relax. Okay, so the lab part is very important because that is what paves the way for the rest of what we do, the street part. And the street part is what we are very good at doing in India. So Tripura or Agartala has led the way. We have tried to do in Lucknow. I'm sure Bangalore and South and West Bengal, everybody has done more or less in their own ways, looking at community activities because that is where the chunk of the problem is. So my 25 years was in Sanjay Gandhi Institute, where of course I got to be known as whatever I am. At the moment, post-retirement, I am at Fortis, which is a swanky hospital, but the only thing about the management is I tell them, don't interfere with my social activities. So they are also quite true to their promise. So I continue to do my teaching and social activities. With regard to the liver, this is just to get all of you warmed up. You know, the liver is actually a 1.5 kilogram weighing organ with a tremendous capacity for regeneration, you know, unlike the brain. So it's good for many of you who are in this hepatitis foundation to know a little bit of mythology. And the mythology is that one of the Greek characters, Prometheus to be precise, who stole the fire, was actually punished by being tied to the rocks on a hilltop, and the vultures would come and nibble and eat his liver. Very terrible way of killing people, but those were the harsh days of old times. I think nowadays, you know, the present method of hanging is probably much simpler than what it used to be that time. I mean, if I understand by way of comparison, there's of course a lot of debate on capital punishment. We'll discuss it later. But the funny part was that each day the vultures came and ate away half his liver. The next day when they came, the liver had regenerated. So that was the capacity for liver to generate, and this is in mythology. Okay? But when your insults on the liver are too huge and too ongoing, then the liver gives way, and that is the reason why there is something nowadays which is very much in vogue called liver transplant. With regard to hepatitis B, which has been the main virus which Dr. Bhaumik, the two Bhaumiks, and the rest of the team, Dr. Chaudhary, have been targeting for the last, I think, 2 decades. Incidentally, the virus is not a new virus. So it was detected in the mummies, which were about more than 1,000 years old, you know. So they dug the mummies out and they used DNA, molecular DNA techniques, and they found that some of them actually had the virus even then. So because we discovered it in 76, doesn't mean that it's a new disease. It was an old disease. Okay? I'll just make one exception to what Pradeep said. Please stop me and question me. If that's okay with you. So in earlier times, before 70s, when the virus was discovered, every local physician, so you can call it shamams and vaids and whatever you have, depending on which part of the world you are in. So they had their little potions. And if you had a liver problem, they would give a potion. If you got well, they thought the potion worked. If you didn't get well, it was fate. and we don't know how effective the potions was, but it was based to a large extent on faith and experience. And that time, even for those who were practicing medicine, I'm sure some of the seniors here, matters were very easy. You didn't have to do tests. In fact, one of the chairpersons was asking, autoimmune hepatitis, the markers are very costly. The problem is when something new comes, obviously it's costly, but that is how science moves, you know. But you have to make a more specific diagnosis. There is no getting around it. The problem is whether the patient pays or you develop some system to help him pay. But you can't escape from the fact that a specific diagnosis is the crux of modern science. So that time it was Live 52 and liver tonics. The whole thing changed in the 70s. And let me broadly say 70s. Why I'm saying it is because Dr. Bloomberg, all of you know, he got the Nobel Prize in 1976. But you know, the Nobel committee takes a lot of time to decide. So they're not very prompt. So his work actually started in the late 60s, early 70s, and he was not a virologist. If it was Pradeep Bhaumik, he would have right in the beginning said that this is causing liver damage. But he was basically a demographer. So he just found that there was an antigen in 2 wells where serum was kept of Australian aborigines. And that reacted with serum from another well in a Caucasian. So he called it the Australia antigen, meaning that it's probably a genetic marker for Australian aborigines. Okay. It so happened that those aborigines actually had hepatitis B. And then later on when they went deeper, they found that it was actually hepatitis B virus. And that's why he got the Nobel Prize in 1976. That's the time when I was doing my undergraduation. Now we all know that the simplest test that we do, I'm sure all of you do it, it's the ELISA test. There are so many methods. There is a strip, there is a dip, and there are so many methods. Is based on identifying that antigen. And then there have been improvements simultaneously in many aspects of science, including electron microscopy and so on and so forth, where they have been able to see and studied and make the virus look as colorful as you want. Okay? So these are some pictures on the electron microscope. But essentially, the first pictures that came looked somewhat like that. Tubules, circles, Dane particles, and so on and so forth. And people were wondering what is it all about, because the big circles are the Dane particles, the full particles of the virus. The rest of it is actually a whole lot of extra surface antigen tubules that the virus presented. But soon it was realized that people who seem to have this infection were more prone to develop liver cirrhosis, liver failure, and liver cancer. So that is where the whole story started. Now, once you realize that it was hepatitis B and you found out there was a way to test and detect it, then there were 2 approaches, obviously. How do you treat people who have the virus? And how do you prevent those who do not have the virus from catching the infection? Right? So there were only 2 approaches left. So this is the way that clinicians work. So if you have HBsAg positive, you look at whether the liver enzymes are high or if there is a liver disease, and if it is so and the DNA is present, then you have to try and block the multiplication of the virus, okay, or kill the virus. And the transmission routes became very well understood. Mother to child, injections, sharing of needles, blood transfusions, and all that. Quite a bit of that required social activity and, shall we say, reforms in the health sector. So not using reusable needles, if at all you use them, had to be well sterilized, blood transfusion, screening of blood, and so on and so forth. And the most recent which the government has undertaken is antenatal checkup, where if you have a HBsAg positive mother, then you think in terms of preventing the infection to the child by very early vaccination, both active and passive. Now, this is a picture, I've taken it, of course, with the permission of my patients. If you decide to do family screening, And I hope there are quite a few people here who are in the foundation, the Hepatitis Foundation of Tripura. So if you do family screening, you will be surprised that 40% of patients would actually have a family member, at least one, and maybe 5 or 6, who also have the hepatitis B infection. So one index case, but you find many others. And that all depends on how meticulous your screening is. And I was, yesterday, I think those boys were there, we were talking about family history. Was it with you or with the undergraduates? So, you know, the important thing is to look at SIBS and to look at mother, because that is how the transmission would probably have come. So if you are able to look at it, you would find that if there are about 5 SIBs, 2 or 3 might actually be positive, you know, because they contracted it somewhere around the same time when they were all young. Then came the development of medicines or antidotes. So there was, interferon was the first. We used it in the 80s. I was a DM student at that time. Effective, but you know, how long can you give it? And alternate day therapy is expensive, side effects. Then the oral tablets came, and I don't think I need to go into it. You all know that, you know, we have now come to the era where we are using either entecavir or tenofovir and possibly tenofovir alfenamide. So that is a part which I am not getting into. The problem with all these oral medicines is that it blocks the viral replication, but it doesn't guarantee that your HPSAG will become negative. So the major problem now is to try and motivate and convince the patient who needs it that you have to go on taking it. And that is sometimes not very well taken or followed by patients. But nevertheless, those who have got a prolonged viral suppression with medicines seem to have a slightly higher possibility of losing their surface antigen. But I must say it's still small. So every year in the World Hepatitis Day, I honor about 10 to 15 people who over the last 1 or 2 years have been able to turn HPSAG negative. And it's more a kind of a acknowledgement of their perseverance to stick with the therapy till they became negative. Because many other people give it up, and that's why the virus often comes back. Now, what happened to the prevention? So the first prevention trial, that was the vaccine trial, came out in December 1982. Okay? You people must be wondering, how do I remember dates? Because I'm not a historian. So 1982 December, I was giving my MD exam. And this paper came out in NEJM, and it was the first clinical trial of the plasma-derived vaccine, which was done in homosexuals in New York. A very key landmark article, okay? And it showed that it was very effective in preventing hepatitis B. And you know, they took a group which was very prone to developing hepatitis B because these were homosexuals, and homosexuality was one of the common methods of transmission at that point in time. It worked well. The WHO sanctioned the vaccine. It was affordable. But then the problem is, how can you get millions and millions of doses from plasma? Because this plasma has to be collected from infected patients, you know. And that became both a kind of a challenge for how to get so much plasma, and there was a lot of fear in the minds of people that you're after all giving a plasma from an infected person. You say that you have heated it a little bit so that the virus, if it was alive, has died. But how do you know there are no other infective agents in that plasma which you haven't killed? Because you have only looked at hepatitis B. What about HIV? What about hepatitis C? That time was not discovered, or any other infections. So it didn't have so well an acceptance. And therefore, there came the need for making a vaccine which was not derived from infected patients. Okay? And see how actually the laboratory, one aspect of the laboratory fits in with another. So then came the recombinant DNA vaccine. So what happened in the recombinant DNA vaccine, the postgraduates should know all that, okay? So can I ask you a question? What is the type of Pfizer vaccine used in COVID? Anybody who says it gets a reward from the one of the two bhaumiks. You read the newspaper, you'll know. Anybody? Moderna is the name of the company. So there is one Pfizer and there is one Moderna, but what's the technique or technology? RNA. Very good. Who said that? You're right. Who said that? Tum kahan ho yaar, tumko milne wala hai. So it's messenger RNA vaccine. Okay, it's called mRNA vaccine. This is a even newer technology, come into controversy, but let's go to the first basic one. This was called the DNA technique, recombinant DNA technique. So recombinant DNA technique used a particular part of the DNA of the virus and inserted into another multiplying cell. Okay, so it could be either Escherichia coli or it could be a yeast or whatever have you, which is multiplying in cell cultures. So you get very large amounts of protein. And one of them was hepatitis B surface antigen, which was used for the vaccine. Second question, Anil is not allowed to speak. Recombinant DNA now is used for producing several of the injections and therapies that we use today. Any idea, can you name 2 or 3 of them? Very commonly used. Chal, huh? Very good, very good. You've got a book? Copy of my book? Yeah, otherwise he deserves one. 1 or 2 others? Erythropoietin. Okay, so quite a few of the ones which we use, these are basically proteins where you are basically using a recombinant DNA technique. Okay, so there is a list of about 20 of them. But good, read it up. That would be a very good question for your MD. So once you had recombinant DNA technology, you could produce large amounts of vaccine and they were very safe. And that's the reason why, now this part up till now was the laboratory part. Now then when you have large amounts of vaccine and the prices come down, then you can have people like me and Dr. Pradeep Bhaumik and others now who have to use so much of the vaccine on poor people in what is known as mass vaccination programs. You can't use it if the vaccine is very costly. So the prices have to come down. Okay. So now you see Dr. Bhaumik's team and HFT having vaccinated 37% of the population of Tripura. Amazing. But you know, it couldn't have been possible until you have a safe vaccine and a cheap vaccine and an affordable vaccine. Okay? Now these are the 3 names. Again, I think 3 of you, or the few of you who are there who should remember. So Paul Berger, Herbert Boyer and Stanley Cohen, they were the people who discovered the recombinant DNA technique. And the interesting part of the lab is that this discovery occurred in 69-70, you know. And 76 he got the Nobel Prize. But you know, they had started using this technology in something else. And now they used it in hepatitis B virus vaccine production. So you see the 2 things coming together. So that's the beauty of lab, you know, if one lab cooperates with another. And this is a study which I hope Dr. Bhaumik will quote every now and then. When we were young, in 1982-83, doing our DM, you know, all the horrific papers of disease causation due to hepatitis B and hepatocellular carcinoma, most of them used to come from a small country called Taiwan. Anil, do you remember? Beasley from Taiwan. So that was a small country which is now in the controversy with China. But you know, that was a country which produced enormous number of publications because they had a very high prevalence of hepatitis B. It was one of the countries which started using a mass vaccination program in the very early days. So they brought their frequency down or prevalence down from a 12% or whatever in the general population down to 1.3% today just by vaccination of the population. Okay? So if Dr. Bhaumik, if you are using vaccination as a strategy, this would be a kind of a study to follow for the HFT because that is the role model which is already there for you. So we tried, as soon as we got all this done, we tried it in different places, no big surprise. I was at Sanjay Gandhi, so we said, let's make hepatitis, SGPGI, hepatitis B free. Then we went to the community, umpteen number of camps. So we had roughly about 10,000 people coming to our camps for testing and screening and so on and so forth. And I'll tell you, hepatitis B vaccine happens to be incidentally one of the safest vaccines. It's much safer than your Moderna vaccine or the Pfizer vaccine of corona, for instance. And we did a lot of campaigns with school students and everything. And one of the methods where we found it so difficult to go to the small places, which HFT people are able to do, we had a little limitation of numbers, so we made a movie. This movie is available on the net. And we used this movie to be screened in schools on World Hepatitis Day and maybe once or twice a year, to that time motivate children to go and tell their parents, Daddy, Mummy, there is a vaccine which the people are telling we should take. Because those days the government was not giving the vaccine. So the government vaccination program started in 2008 officially, but practically in 2010 to 12. So we are talking about the phase before that. You remember that phase. That's why we were so active at that time. Now, what has been the Tripura model? And Dr. Bhaumik and his team has been leading a huge campaign here in this small state. So up till now, we have now talked about what happened in the lab. Are you people following politics? Some of you should be. So, there's something called a north-south divide. So it's a metaphorical north and a metaphorical south. It means the developed countries and not too developed countries, okay? Now the cutting edge technology and the brains and the labs are actually with the north, the developed countries. But the major burden of disease is with the south, infectious diseases, okay? So there is always that little gap, but it's always when you have the technology being transferred, then we are able to use it for the population who need it most. So let's look at the Tripura model. It was started in 2002. In fact, it was 2 years before our HOPE was started. These were the figures from Tripura, 3.6% positivity. And then they focused on awareness, immunization, and detection, and diagnosis and treatment. So a comprehensive approach, not just vaccination. And one of the things I was just mentioning yesterday is that if any of the political parties want to get votes in Tripura or Agartala, they should hire Pradeep Bhaumik. because I'll tell you, his mobilization on the ground and his motivating power has been enormous. And I have seen it many times, especially in Udaipur when I was there. So you can see he was able to get huge number of people and talk to them and convince them. So talking, lot of people did. This time we saw in the elections, So huge rallies, but whether they converted into votes in some was another issue. But his was whether they got converted into taking vaccines. So he did a good job. And you see huge groups all over, some in uniform, some not in uniform, some employees, some general public, and so on. And they went every Sunday and went on vaccinating. And in our place, we had a lot of trouble convincing people to come for vaccination. In his place, there were huge queues out there in the hot sun waiting to get vaccinated. So that was the power of motivation. And then they went down to the neonates, for I think hepatitis B positive mothers. And this is the figure which I last have. This is 14 lakh people have been vaccinated, 37%. But this was till August 2019. I presume the figures must have increased after that, but that's up to you. No, it hasn't? Okay, so you need to rejuvenate yourselves a little bit. And there has been a slight decline in the positivity rate of voluntary blood donors, which is also an initial good positive trend. But as the minister mentioned yesterday in the evening, 1/3 covered, but 2/3 are still remaining. So it's a question of whether you look at it as an optimist or a pessimist, in the sense that, there is still job to be done. Now with hepatitis B, there isn't much more that we can do. There are only two things we can do. We can find a very effective medicine which would get rid of the CCC DNA, so your HBsAg becomes negative. We haven't yet come to that. There is one therapeutic drug which is in trial phase. We'll not discuss that and bore you, but that's one of the limitations. So it's a long-term therapy, and vaccination is very effective. Now the little brother was hepatitis C. So the hepatitis C was discovered later, and because they realized that there's something else, even if we are doing hepatitis B screening and all, but something is going through the blood and through injections, producing a similar problem, but this is not B. And the methods of transmission were almost the same. Blood, body fluids, unprotected sex, and so on. I'll just bring your attention to only one, this IVDU. And I'll tell you why it is so important towards the end of my talk. Yesterday I was talking to one of your Hepatitis Foundation persons. Where is he? Quite a fiery guy. Amitav, I think his name was. Okay, so I mean apparently now the hepatitis C problem in Agartala is related to a huge surge in IVDU. And Punjab actually, I think the elections are being fought on how much control they are getting on IVDU, which is becoming a major political issue as well. So just think about it. And it can cause liver cirrhosis and liver cancer, and this is the virus. It's a RNA virus, and it has got its presence all over, including in India. And one of the causes of hepatocellular carcinoma being still on the rise in India is because of a sequelae of hepatitis C. So the warehouse effect is that most of the people with active viruses have been treated by now, most of them. I don't see very many naive patients coming, but many of them who have been treated and have had fibrosis can later on go on to develop HCC, and that is one of the major causes for HCC in our clinic today. And yeah, this is just to liven you up. This girl's name is Pamela Anderson. How many of you have heard of Pamela Anderson? Well, the boys at least, I hope. At least somebody there. So she is a very famous Hollywood actress. She participated in a very famous serial called The Baywatch, and very controversial for many reasons I can't discuss on the dais. But she and her boyfriend went to a holiday, and they, in their, shall we say, expression of love, decided to get a tattoo done on their bodies using the same needle. And after a while, she found that she had got hepatitis C. And then she found that she actually had got it because her boyfriend at that time, I think they were not married, he had hepatitis C. And then she filed a court case against him that he hadn't disclosed it. And then those were the days of interferon. But luckily around 2014 when the oral medicines came, she got treated and he got treated. But I don't think they lived happily ever after, but whatever. But these interesting stories should make you relate to what you're reading in the textbooks, to what is happening in the real world. And anybody can identify him? Those of you who don't like watching girls, at least a boy? Yeah, it's from your place. Satyam Raju. So he's Mr. Raju. He was the first person who created this Satyam Infotech in India. It was one of the infotech companies of India, which was the first to be listed on NASDAQ. So it's a big achievement. Unfortunately, he had hepatitis C. And it was a terrible story because he was in jail for money frauds, laundering or whatever it is. And those days it was interferon injections, and somebody had to go and give interferon injections alternate day. You were also there giving the injections? No, you were not. Oh, yours in Hyderabad. So anyway, but sometimes, celebrities make you remember illnesses and their treatments very well. So that's Satyam Raju. Now, hepatitis C was a terrible challenge to treat. Interferon, peg interferon, ribavirin, side effects. Fortunately, 2014 and 15 changed all that. And now you have got very good drugs. So you have got soposbuvir and velpatasvir or any of the others that you prefer. And now it's gone like that. Oral tablet once a day, 3 to 6 months, and by and large 98% cure. So treating hepatitis C, if you catch it on time, nowadays is not a problem. It's much less of a problem than hepatitis B. What is the problem then? The problem is that, just 2 weeks or about a month back, I got a video consult call from a very anxious mother in Meghalaya. And her son was in the hostel in an engineering school somewhere. And she was frantic. They said that, he was, his LFT was abnormal. They got a test done and he was hepatitis C positive. So she was absolutely distraught. And she said, I have worked so hard, my husband and I, to put him to college. And, he obviously admitted that he had been in the company of peers taking drug use, drug use. So the problem was, okay, the treatment is simple. The problem is, how do you keep him away from getting back to it? So addiction is a major problem, and that is where we had a long discussion on the video. And this is IVDU, which is a major problem. So I just want to tell you this last part of my talk. We as doctors and healthcare workers, we all the time look at a biological model. Hepatitis B virus, DNA positive, entecavir, tenofovir. Okay. Look, it's beyond biology. There's something called biosocial model. That is how society plays a role. For example, if you have a very high prevalence of drug use in hostels, the poor boy is going to get sucked in under peer pressure. And the biopsychosocial model, that is, if you have been able to get him out, how do you motivate him or strengthen him not to fall back? So this is the model which is now considered to be a better medical model than a bio model alone. And this is the one which Western Europe and Scandinavian countries usually believe is a more effective model. So for those of you who have not read my book, Health Adda is the book for you. Very simple book. The last two parts, that is, deals with health in its entirety and the approaches to health and how we need to reorient ourselves. And the other book is, of course, a technical one, but bench to bedside. It basically tells you how the bench work has been translated into clinical work, and therefore we are today, if we think that we are successful doctors, our success actually comes from much that has gone on in the laboratory. So with that, I'll conclude. Thank you very much for your attention, and a big round of appreciation and thanks and indebtedness to the HFT for this huge honor. I'm in fact absolutely humbled by it, and it's a privilege to work with Agartala every time. Such a pleasure.
Thank you so much, sir, for your valuable words.
Thank you, sir, for your nice talk, and we are really pleased and happy that you will be rather with us in our coming days.
Thank you.
Thank you very much.
Now, we will proceed to our next session, the 8th session of this conference, today and tomorrow. For this session, our chairperson would be Dr. Atanu Ghosh, Dr. Amitabh Roy, and Dr. Debashish Nath. I would like to invite our speaker, Dr. Anil Arora. Our speaker, Dr. Anil Arora sir, would be talking on this topic, NASH or MASLD, the conceptual change in pathogenesis and management.
Good morning. On this academic session of HFT, we are going to listen from Dr. Anil Arora. He is gastroenterologist and hepatologist, chairman and director of GI endoscopy in a department of gastroenterology and hepatology with Sir Gangaram Hospital. Two topics are to be covered in this session. First one is your NAFLD, NASH, MASLD, non-alcoholic steatohepatitis or metabolic dysfunction associated steatotic liver disease. Now we are eager to listen the recent advancement regarding this, along with weight reduction, elafibranor, and recently coming in the picture that resmetirom. We would like to listen from sir. Over to you, sir.
Thanks a lot. At the outset, I'm extremely grateful to Dr. Pradeep for giving me this opportunity. After a tumultuous, exhilarating, stimulating talk by my mentor and guide, Professor Gaur Chaudhary, in which he discussed about not only the biological model, but also the biosocial and biopsychosocial models. Let's get back to the mundane academics. I'm sure I'll not bore you with whatever has been mentioned. Now, but this topic is something which is so important, and I'll urge all of you sitting over here, if you try to read the book which has been written so well compiled and articulated by Professor Chaudhary, I'm sure most of you or your patient will not end up with this disease called metabolism-associated steatotic liver disease. So just because we do not follow the basic norms of the day-to-day lifestyle, we end up having a large number of the diseases, which is unfortunately the commonest cause of admission all over the world in the hepatology clinics. Now, once you have a healthy liver, if there is a deposition of the fat, you tend to develop fat in the liver. In the absence of a substantial alcohol intake, with passage of time, part of the incipient fat in the liver tends to trigger an inflammation resulting in non-alcoholic steatohepatitis. And repeated bouts of inflammation by default will lead to scarring of the liver, resulting in fibrosis of the liver. The moment you have fibrosis of the liver, you are having an end-stage liver disease. Now, till the time of early NASH or fibrosis, you have a disease which is reversible. But once you have a fibrosis, this is an end-stage liver disease which by default is irreversible. And the fact that you have cirrhosis of the liver, even if you take care of the etiology, Dr. Chaudhary very elegantly showed large number of the cases of hepatitis C in which virus has been gotten rid of, but they continue to have substantial risk of development of hepatocellular carcinoma. So our aim when we want to treat fatty liver disease is to stem the rot at this point of time. In fact, the earlier the better. If we are able to prevent the deposition of the fat in the liver, that may best be the best solution in the management of NAFLD patients. Now, if you look at the population data from the US, let's say the US has a total population of 32 crore, of which 1/3 will have fatty liver disease, which is called now metabolism-associated steatotic liver disease or MASLD. Of those with MASLD, 20% will develop inflammation in the liver triggered by mere presence of the fat called MASH. And of those with MASH, about 20% will develop cirrhosis of the liver. If you go by the enormity of the total prevalence of the liver disease, in US alone, there will be 4 million new cirrhotics. If you go by the enormity of population in India, which hovers somewhere around 1.4 billion, we are likely to have about 10 million new cirrhotics every year with passage of time. In fact, if you look the data so well established from the US, that the menace of MASLD or metabolism-associated steatotic liver disease is increasing. MASH is increasing. That means the occurrence of the inflammation in the liver is increasing. You have increasing number of the liver cancer patients which are present in the US, and the deaths related to both liver cancer as well as the presence of the end-stage liver disease is rapidly increasing. Unfortunately, because of the dual unholy conspiracy between the diabetes and obesity, you have more and more advanced liver disease, which is tending to be a part of the armamentarium for hepatologists to handle. So what is the diagnostic approach when the patient comes to you with fatty liver disease? The reason he has been referred to you as a physician, as a gastroenterologist, a hepatologist, is that somebody in the ultrasound has reported him to be having fatty liver disease. In such patient, we should try to look at the liver biochemistry, try to assess the degree of the fat in the liver by a value called CAP, which is an important integral component of the FibroScan values. You tend to rule out other causes of the liver disease like hepatitis B, hepatitis C, as well as alcoholic liver disease. Look at the concomitant comorbidities like dyslipidemia, hypothyroidism, which may be contributing to presence of the fat in such situation, and assess whether the patient has an advanced cirrhosis. This is the basic thing you have to do. Look at alcohol composition of the and content of the alcohol patient is consuming. Look for the viral markers which are totally treatable today, and look for other uncommon but treatable causes of the liver disease. Why is it there has been so much of controversy when we try to rename NAFLD, that is non-alcoholic fatty liver disease, to metabolism associated steatotic liver disease? In fact, now I think there have been a lot of controversies, a lot of discussion, a lot of debates in our own hepatology meetings also, and we are glad that one of our colleagues, Professor S.P. Singh, was part of this committee which renamed the disease from NAFLD to MASLD. Now, the reason for mentioning this was people thought, oh, but because we don't drink alcohol, why unnecessarily give a social stigma that you are non-alcoholic fatty liver disease? And even in those patients who are drinking alcohol, if there are metabolic components, what do you call them? To overcome all these debates, controversies, and irrelevant literature, Dr. Renela's group has come up with this consensus nomenclature which we should be using routinely. It makes a lot of sense. Now you have a metabolic dysfunction associated steatotic liver disease. That means there is something wrong with the metabolism which is leading to the deposition of the fat in the liver. That is called MASLD. Now you may have alcohol which may be causing fatty liver disease. You would call it alcohol associated fatty liver disease. Then there could be specific etiologies like microvascular fatty liver disease. You will have drugs which will be contributing it. You can have monogenic diseases which may be contributing to occurrence of fatty liver disease, etc. There is a group of the disease in which the patient may be obese, he may be diabetic, he may be dyslipidemic, but he in addition has been consuming alcohol. So that is called MetALD. That means you have a metabolism associated with alcoholic liver disease as a cause of the problem. So why this change in the definition? Now it gives you an affirmative set of diagnostic criteria for MASLD. That means rather than saying, oh, he is non-alcoholic, but he has a fatty liver disease, so it was by default a NAFLD. Now you have a definitive criteria to label him as having MASLD. Now there is almost a universal agreement because of so much of the discussion, debate, and across the table and across the continent controversies, everything has settled for the time being. Moreover, it now tries to minimize the patient heterogeneity, and they are adaptable to future insights in terms of the management and treatment policies. In addition, they are simple, they are readily available and easily measurable parameters to say, oh, this is a MASLD, this is a alcohol-related liver disease, or this is a MetALD. And in fact, this criteria has been primarily set up for the adult population, and this subcommittee has also renamed 5 pediatric hepatologists which will try to come up with specific criteria applicable to the pediatric population. So what is MASLD as of today? So first and foremost is you need to have a steatotic liver disease as shown by ultrasonography. This may have its own caveats which we can discuss in the discussion or in the Q&A, but more important to realize is if you have a fat in the liver coupled with any of the following, these are all objective, these are measurable, these are all available at your desktop. So either you have diabetes or you have a central obesity in Asia of more than BMI of more than 23, hypertension, a BP of more than 135, or you have dyslipidemia. Dyslipidemia in this paper has been defined as anybody having a plasma triglyceride of more than 150 or a plasma HDL of less than 14 males and less than 15 females. So if you have any of these coupled with fat demonstration in the liver, then you have a MASLD. So what are the major updates since the last publication is that pediatric subgroup is trying to redefine if there are other different parameters for the pediatric age group. And there are now specific indications for screening patients who have advanced fibrosis. And now you may be able to use off-label new upcoming drugs, as our chairman said, that newer drugs like the recently approved drug called resmetirom may be useful in subgroup of the patients who are having advanced disease. In addition, it is important for all of us as practicing physicians, gastroenterologists, and hepatologists to remember is that aminotransferase levels are frequently normal in patients with advanced liver disease. So do not think that your patient has a liver disease and it cannot be advanced liver disease because the ALT is normal. ALT has a very poor sensitivity and specificity for diagnosis of the chronic liver disease. Normal values for ALT are reported differently in different labs, but in general, any abnormal ALT of more than 30 should be by default an abnormal ALT unless proved otherwise. Moreover, while ultrasound can detect hepatic steatosis, we should remember that ultrasonologists will tell you you have fat in the liver if the fat in the liver is more than 30%. So if fat in the liver is 20%, still you have a fatty liver disease, but that will not be picked up by ultrasonography. And hence in future, we may have to depend on objective parameters like CAP or MR-PDFF to tell us more objectively about the degree of the fat in the liver. What are the factors which make a fatty liver more prone to have advanced or a chaotic liver disease? So a patient who in addition has obesity, diabetes, dyslipidemia, or patient who have concomitant presence of polycystic ovarian disease is more likely to have problems associated with fatty liver disease. And mind you, this MASLD or metabolic fatty liver disease is just one window for us as physicians and hepatologists to see a spectrum of disease which is occurring throughout the body. These patients in addition have hypothyroidism, they are likely to have obstructive sleep apnea, hypopituitarism, and they are more likely to have psoriasis. And recently it has been shown by a group, there is a group called by Professor Matthew Cave in Virginia, which has been primarily working on this subgroup of the patient, and it has been shown that chemical exposure at some point of time may end up producing these deposition of the fat in the liver. So the modifiers of fat in the liver and the phenotypic presentation of advanced liver disease will be dependent on so many factors. You will have comorbidities, you will have genetic factors, you will have microbiome products within the intestinal tract, and the nutrition or the concomitant ingestion of the agent which tend to produce more fatty acid. If you look at the area, look at the figures which have been labeled as green figures, like exercise and coffee. These are the two ways by which you can protect your liver even if you are steatotic. This is what I think Dr. Gaur Chaudhary books also tells you. A regular exercise, change in the lifestyle is of fundamental importance in trying to tackle your liver disease. Consumption of the coffee, I'll come to you. But then most important factors which will cause deterioration of the fat in the liver in terms of occurrence of advanced disease are the concomitant presence of the obesity, diabetes, and the underlying abnormalities of the genes. So that is where the patient may come and tell you, that's how I don't eat much, my diabetes is controlled, still I am having an increasing fat in the liver and I am going from bad to worse. One of the reasons is that this is something which has recently been published and has been documented to be important for occurrence of the toxin-associated steatohepatitis. This is also called TASH. This subgroup of workers led by Professor Matthew Cave have shown in this rubber town factory by both objective assessment as well as the assessment of histopathological assessment of deposition of the toxins in the liver. They have been shown to have progression of the disease because of the deposition of the chemicals, primarily in the form of heterocyclic amines, which can cause significant hepatocytic death, antioxidant depletion, as well as the insulin resistance. In fact, it has also been shown that prenatal exposure to perfluoroalkyline substances associated with increased susceptibility to children in the liver. So you have pollutants which are contaminating the water which the mother consumes, and it is at the time of conception as well as the fetal growth within the mother's womb, then you tend to develop altered hepatic metabolism, and children tend to grow up with childhood obesity. In fact, it has been shown that 30% of the population in a city like Delhi, Dr. Chaudhary would remember that we have assessment of private schools in Delhi in which 30% of our children in the pediatric age group are obese. There is also a concept that if you tend to overheat your food, if you tend to have, you want to have chicken which is boiled and then you try to put it on the flame so that it becomes more baked or it becomes more fried. The more you try to fry it, the more you try to bake it, it's likely that some component of the material in the chicken in the form of proteins or other compound, they tend to produce a number of substances called heterocyclic amines or HCAs. And it has been shown that HCAs are important component for development of the insulin resistance. And mind you, whatever has been happening in the metabolic associated liver disease is related to the insulin resistance, which is the first event to occur and lead to a cascade of the events producing this problem. In fact, these pollutants which are impacting the body may be in the form of in the food and other areas, and these are called environmental degradation chemicals. So a number of the pollutants which are present in the air, in the water, in the food, in the chemicals, in the flavoring agents may be producing a lot of fat in the liver, which we still do not know. In fact, more than 50 agents have been diagnosed recently which could be causing obesogenic phenotype in an individual, and which is resulting in the epidemic of fat in the liver. There is also good experimental data to show that if you are having an underlying gene called NAD2 polymorphism, and if you continue to have the smoked meat, or if you are having like in Punjabi communities, we eat something called tandoori kebab or a Sikh kebab, in which you heat the chicken piece or the mutton bit onto a tandoor, which is a burning flame. So that lead to production of a lot of HCAs, or human heterocyclic amines. And then depending upon whether you are a rapid acetylator or a slow acetylator, I am sure you would remember from your anti-tubercular therapies days that a rapid acetylator of INH are more likely to produce hepatotoxicity. So if you have a rapid acetylator of HCAs, you are more likely to have insulin resistance. The higher the insulin resistance, more the fatty liver and more the cascades of the event. In addition, if you have a concomitant diabetes in presence of the fatty liver disease, you are more likely to have not only the development of cirrhosis, but also the development of the advanced liver disease. So cirrhosis per se, diabetes per se is an important risk factor for having adverse effects of the deposition of the fat in the liver. So what is the spectrum of fatty liver disease which we see across the population? If you see 100 patients with a fatty liver, this is the breakup. 20% of them will just have fat in the liver, whereas a substantial chunk of these patients will have advanced fibrosis without resulting in cirrhosis of the liver. This is the subgroup of the patient. If we handle them with current therapies, we may be able to drag them back towards F0 rather than letting them proceed to a more advanced liver disease. And this is how we try to assess our degree of damage to the liver by looking at the histology of the liver, whether there is a mere fat, or you have a periportal fibrosis, or else if you have a portal to portal fibrosis, or if there is a portal to central venous fibrosis or cirrhosis of the liver. Now the outcome is directly dependent on the degree of an injury to the liver, whether you have a no fibrosis or you have a early degree of fibrosis or advanced cirrhosis. How do we assess this? There are huge number of parameters. You have a large list of the parameters which tells us, even without doing a liver biopsy, as to what is the degree of damage of the liver which has already occurred. Why do we need to know the degree of the fibrosis? Because there is a direct linear relationship between the degree of the fibrosis and the development of the complication. The more the fibrosis, the more chances are that you are likely to die of the liver disease. It is also important to know that even if the fibrosis has not occurred, the fact you have a fatty liver disease, you are likely to die of diseases other than the liver. Early stages of fatty liver, you are likely to die of diseases like cardiovascular events, diabetes, and the coronary artery disease. Whereas once you have advanced cirrhosis, then your causes of mortality are more related to the liver disease. In fact, there is a direct correlation with the liver-related mortality by fibrosis score. The higher the fibrosis score, the more the mortality related to the liver. In fact, all-cause mortality is also directly related to the degree of the fibrosis. The crux of the matter is, the moment you have a patient with fibrosis, patient with fatty liver disease who pops up in your clinic, please look at the degree of the fibrosis by various means which I am going to tell you. Moreover, the overall survival as well as the complication related to both liver and the non-liver related mortality is still dependent completely on the fibrosis stage of the liver. So what has been the best way to diagnose the degree of fibrosis? We have been insisting so much that higher the fibrosis, the more the mortality. Is there a way to know what is the degree of the fibrosis? In fact, the best way is to do a liver biopsy. Now, the liver biopsy is the gold standard, but unfortunately, liver typically weighs around 1200 to about 1500 grams, that is 1.2 to 1.5 kg. And when we do a percutaneous liver biopsy, you pick up only 2 to 3 grams of the tissue. So that means you are just looking at 1/50,000th part of the liver when you are doing a liver biopsy. It is a costly procedure. 1 in 1,000 of the patient may have substantial bleeding resulting in mortality. So it is believed that if India has a population of 30% of those total population of, say, if we have a population of 1.4 billion, 30% is suffering from fatty liver disease. If we keep on doing liver biopsies for all fatty liver to see the degree of the fibrosis, and if there is a 1 in 1,000 chance of killing a patient because of the liver biopsy, then it has been calculated that we will end up killing more people than what Hitler has done during his Nazi era in 1942. So obviously that cannot be the answer. And moreover, patients are not willing to undergo a procedure like this. So there are other ways of looking at the degree of the fibrosis without touching the liver. So this is a group of the tests called NITs, or non-invasive test. The simplest test is to do a test called, these are simple bedside scores which can be available on a calculator when you are sitting on a desk examining the patient. So then you have a proprietary serum test. You draw a blood sample which tells you what is the degree of fibrosis in the liver. Mind you, you have not touched the liver in any of these. And there is a group of the tests in which you, like Dr. Chaudhary was my teacher, he would tell us how to percuss for this enlarged spleen and the liver. Percussion would mean that you can distinguish between a structure which is solid versus a structure which is air. The more solid the structure, the less will be the resonant note. So this percussion on the liver is today documented by these new imaging techniques called fibroscan. So the stiffer the liver, the more will be the value. The lesser the fibrosis and inflammation of the liver, lesser will be the value of the fibroscan. In fact, like liver biopsy, there has been excellent correlation of these non-invasive tests. There is a direct correlation between the mortality and the complication. If you do your non-invasive test like FIB4, or you do a transient elastography or a percussion of the liver using this technique called fibroscan, or you do a liver biopsy. That means as of today, non-invasive tests are going shoulder to shoulder with a liver biopsy, which is done only about 5% of the patient all over the world to diagnose NASH or the presence or absence of the advanced fibrosis. So what makes a good non-invasive test in your own clinic? What will be the best test? The best test should have two cutoff value. If cutoff value which should tell you that if the cutoff value is less than 1.3, say in FIB4 score, that means the patient does not have cirrhosis of the liver. You can send him confidently back. You don't need to send him to a celebrated hepatologist like Dr. Pradeep Bhaumik. Then you should have a cutoff value which is a higher value. That means let's say in FIB4 score, if you have a cutoff value of more than 2.6, there is a very high chance that this patient has cirrhosis of the liver. Do refer to him to a hepatologist because he will know how to follow up of that patient. Then there is a subgroup of the patient in the intermediate range. That is a group of the patient in which you can take more measures to diagnose what is the degree of fibrosis in the liver. Now, these are the various cutoffs which tells you what is the highest reading, what is the lowest reading. Like in FIB4, any reading of less than 1.3 tells you the patient has no cirrhosis, you can treat it on your own. Any reading which is more than 2.6, you should remember that this patient has a more than 90% chance of having cirrhosis of the liver. Similarly, you have a fibroscan value. Anything which is less than 7.9, it is very unlikely that the patient has an advanced liver disease. Fibroscan value of more than 12 is extremely likely to be cirrhosis of the liver. Do refer him to the hospital. So, ladies and gentlemen, the current non-invasive tests have stood the test of the time, and they are vying for their relative importance with cirrhosis of the liver. This is what you can do on day-to-day basis. This is called FIB4 score. You don't need to be worried about the complicated mathematical calculation. You have a calculator. Just put in 4 simple parameters. Patient will always come to you with these. Look at the age of the patient. Look at the AST value, ALT value, and platelet. Put it in this calculator, and you have an answer. A FIB4 of less than 1.3, absolutely no fibrosis. More than 2.6, more than 90% chance of having fibrosis. This data is relevant because the more the degree of the fibrosis, if you move from grade 1 to 2 to 3 to 4, there is a direct relationship between the death, between the between the mortality related to liver diseases events like cirrhosis and HCC, major cardiovascular event and HCC. That means the higher the degree of stiffness of the liver, stiffer the liver, the worse it is. So and this is what I was trying to say about the FibroScan. This is how a soft liver and the firm liver can be easily diagnosed by this technique called FibroScan. And now there is a new technique called shear wave elastography, in which an ultrasonologist only can put the probe onto the liver and tell you how stiff the liver is. Advantage of transient elastography is that it is a simple bedside tool, and I think as hepatologists we consider this as a stethoscope of a hepatologist. It is like an ECG tracing for a cardiologist. It is a very simple test which has some limitations, but the advantages are, as I said, you only look at 2 to 3 gram of the liver tissue of the 1500 gram in liver biopsy. In patient with FibroScan, the total assessment of the fibrosis in the liver is 100 times more than that of a liver biopsy. At times, if the patient has acute inflammation, like the patient is having acute hepatitis, or if there is a congestive heart failure, or if you have done the FibroScan value after eating, the readings may be fallacious. MR elastography is the current gold standard for documenting the degree of fat in the liver. The only problem with this technique is that it is still costly. Any reading of more than 3.1 would indicate a substantial fibrosis. The biggest advantage of FibroScan is just look at the colors. The more red the color, the more the fibrosis. Yellow will be intermediate, whereas blue will indicate that there is no fibrosis. Just by looking at the topographical, spatio-topographical graph, you can say what is the degree of fibrosis in the liver. In fact, second thing is important to remember is most of us do get fooled. Not only us, but patients also get fooled. Oh, I am drinking alcohol, my ALT is normal, I cannot have a liver disease. This myth has to go, and this has to begin from you. ALT has not much to do with degree of prediction of the cirrhosis of the liver. In fact, it has a 60 to 70% inaccuracy. That means it has a wrong predictive value of either presence of advanced liver disease or absence of advanced liver disease. So this is what you should, when the patient lands up to you in your clinic with fatty liver disease, identify whether the patient has risk factors in the form of metabolic factors like diabetes, hypertension, dyslipidemia, and obesity. If the patient has substantial risk factor, do a FIB score, very simple, age, ALT, AST, and platelet count. Do it on a calculator. If the FIB is less than 1.3, that means this patient does not have an advanced liver disease. Do not refer to a gastroenterologist or a hepatologist. Take him as a low-risk candidate. Do look at the lifestyle parameter. Give him a book by Dr. The Health published by Dr. Chaudhary. Let him improve his lifestyle so that he gets back to the normal health. If the patient has a FIB score of 2.6, that means this patient has landed up to you in an advanced disease. Let the hepatologist, the gastroenterologist handle this patient. Whereas if the patient's FIB4 is between 1.3 to 2.6, then try to look at the correctable factors like control his diabetes, look after his diet and exercise, and do other things. So this is a simple parameter which tells you how different parameters, of which FIB4 is easily available on the bedside. MRI is costly. The FibroScan values or vibration controlled transient elastography is easily available. I don't know how many machines, Dr. Pradeep, we have in Tripura. Now in Delhi, it is very easy to get a FibroScan done. And this is something which will request the company to make it cheaper, because I think it is a very useful modality, but at the moment a bit costly. So what does this new guideline on ACLF tell us about how we need to treat our patient with MASLD, published by Renella et al. Now these rational recommendations today are based on best available evidence. We have to bank upon non-invasive tests, which I have already stressed upon, and practical recommendation has to be modeled around the treatment of the metabolic factors like diabetes, hypertension, and obesity to take care of it. So basically the treatment revolves around the lifestyle recommendation for treating MASH or MASLD, you need to restrict your calories. The first thing you should do when the patient is obese and comes to you with fatty liver disease, you have to reduce his diet by at least 30%. Any reduction of more than 30% may not be good enough because patient may not be compliant. So if you're able to restrict your diet to about 1000 to 1200 calories, that should be good. Ask the patient to lose a weight. Any weight reduction in fatty liver disease does give you some benefit. The higher the weight loss, more the benefit. Exercise is something which is so important. Exercise is something which improves your metabolic profile. Exercise is something which may not make you lose weight, but to remain healthy, you have to exercise. Exercise will improve your diabetes, your hypertension, dyslipidemia. But if you think that you will lose weight by exercising, that means you are fooling yourself. Exercise will never make you lose weight. It will make you metabolically more healthy. Stop alcohol. In almost all cases of metabolic associated liver disease, it is important to stop alcohol. What are the therapies which are being used for treatment of MASLD, for diabetes and for dyslipidemia? As a physician, I'm sure you will be able to do a much better job in treating this subgroup of the patient than we can do as hepatologists. But we come into picture if the patient has a concomitant liver disease also. So there are two primary aims of treatment. One is to prevent the deposition of the fat. Second is, if the deposition has already occurred, try to arrest the rapidity of its growth. And once the cirrhosis has developed, try to do something to reverse the fibrosis of the liver. How do we do that? Let me explain to you. If the patient has a low risk group, that means FIB score is less, patient has only diabetes, hypertension, you as physicians are doing it, you will be able to do a much better job than we as hepatologists. Try to control their diabetes, make them lose weight, ask them to exercise, control their lipids, try to take care of the statins. If the patient has high risk group, then we have newer drugs, as our chairman said, that you have newer upcoming drugs for treatment of NASH, which I'll be coming to. In fact, it is important to remember that exercise has regularly been shown to have advantage in taking care of the metabolic factors. What is an exercise? You need to be walking for about 150 minutes per week. That means half an hour to 1 hour of standard walking is good enough to give you good health. If you want to lose weight, you have to step up your exercise. It has to be high intensity exercise. What is high intensity exercise? It is about 6 meta equivalents. If you want to do it on daily basis for a period of about at least 5 days a week. Which exercise should be aerobic? Should you be running, or you should be doing resisting exercise? I think both of them are important. Aerobic exercise give you correction of the metabolic factors, whereas resistance exercise, that means weightlifting, will give you improvement in your muscles. If you know the pathophysiology of the metabolic associated fatty liver disease, muscles are more important in maintaining a good homeostatic balance. The more muscles you have, the more you will be able to tolerate insulin resistance and the complications. Coffee is something which has been consistently shown to be useful. In fact, 2.25 billion of the cups of coffee are consumed worldwide daily. It has been credited in improving metabolic liver disease in patients with HCC, ethanol, HCV, and NFLD. Dr. Chaudhary would remember when we used to have discussion on treatment of hepatitis C, when this DA are not available. There used to be a session on coffee, whether that is important or not. We used to have pegylated interferon with ribavirin, dose of ribavirin, use of vitamin D or coffee in addition. So at that time also it was believed that coffee is something which is going to give you something. More important to know is that coffee will take care of the liver disease. It does not prevent the cardiovascular complications. So if you drink at least 2 cups of the coffee on daily basis, there is a 30% reduction in incidence of HCC as well as in reduction of your liver-related mortality. So if you are drinking tea, I think if you switch on to coffee, it will always give you an advantage. Weight loss is something which is now the talk of the town. In fact, there are new drugs which are coming up. You would have heard of drugs like Ozempic or Wegovy, and these are the drugs which have now, they have shot up the charts of the NASDAQ, and these are the hottest selling drugs. The drug called Rybelsus, which is available in the form of oral semaglutide, is so much in need these days and so much in demand that most of it is being smuggled from India and available at a much higher cost in Dubai. These are the wonder drugs which are trying to make you lose weight, and this weight loss can be as much as can be achieved by the bariatric surgery. Now, bariatric surgery is the best thing which you can get it done in patients who have a high BMI, any BMI of more than 35 or more than 40. If you do bariatric surgery, you get the best and the most consistent improvement in the fatty liver disease as well as in reversal of the cirrhosis. The newer drugs are important in treatment of NASH, and the drugs which have been approved earlier were pioglitazone, vitamin E, and GLP receptor antagonist. You would have heard of this study called PIVEN study, which was done by Professor Arun Sanyal, who incidentally was student of Dr. Chaudhary in AIMS while he was doing his DM, MD in General Medicine at All India Institute of Medical Sciences. His paper is still quoted as the most widely quoted paper called PIVENS, which was published in NEJM, in which showed the utility of pioglitazone in patients who are biopsy-proven non-diabetic NASH. But with the availability of newer drugs like GLP-1 receptor agonists like semaglutide, liraglutide, or the newer version like tirzepatide, these are the drugs which are more useful for treatment of diabetes and hypertension. And it is important to remember that if you have fatty liver disease and concomitant heart disease, then drugs like SGLT2 inhibitors are the drugs of the choice. So if you have patients who have fatty liver disease with heart disease, GLP receptors are the first line of the drug. I think even endocrinologists are realizing that with the advent of new drugs like GLP receptor antagonists like agonists like semaglutide and SGLT2 agonists like empagliflozin and dapagliflozin, these are the drugs which are going to be the future drugs for treatment of patients with NASH. So this is what had been shown in Dr. Sanyal's group, that in patients who are being given a combination of vitamin E with pioglitazone, the vitamin E at least had shown substantial improvement in the inflammation in patients who were non-diabetic and were biopsy proven. Statins are so important for maintaining the lipid level to decent levels. In fact, they are the drugs of choice in patients with coronary artery disease and the fatty liver disease. And I think in our recent memory, these are the drugs which have been outsmarted by almost all other medical armamentarium in treatment of coronary artery disease. They are integral part. There was earlier an apprehension that if you give statins, they will lead to increase in SGOT-PT and will harm the liver. That is no more true. Statins, if indicated for treatment of dyslipidemia, are absolutely safe, even in patients with advanced liver disease. New drugs have been coming as part of the treatment of deposition of the fat and fibrosis in the liver, but most of them have not seen the light of the day. The biggest disappointment was this drug called obeticholic acid, which was from Dr. Sanyal's and Rohit Lumba's group, was developed by this company called Intercept, but unfortunately FDA, because of its tendency to increase LDL, which is a bad cholesterol, as well as tend to decrease good cholesterol called HDL cholesterol, it has not been approved by US FDA for treatment. One drug which our chairman was referring to, this is the only and the first drug which has been approved for use in patients with the non-alcoholic fatty liver disease. This is by a company called Madrigal. This is a drug called resmetirom, which is a thyroid agonist. Most of you as physicians would realize that whenever the patient has hyperthyroidism, he'll become thin, he will lose weight, and he'll quickly tend to improve his diabetes status. So learning from that, there is a development of the new thyroid-specific agonist, which is hepatic-specific. Thyroid TSH receptors are present in two forms, alpha and beta. Alpha receptors are present in the heart as well as in the eye. That is the reason the moment you have Graves' disease or thyrotoxicosis, you have tachycardia, palpitation, and exophthalmosis. So this is a beta receptor which specifically acts at the level of the liver, but does the same thing again. It increases the oxidation of the fat from the liver. It increases the mitochondrial oxidation of the fat. So the fat gets mobilized from the liver. Insulin resistance decreases. But unfortunately, one tablet of resmetirom today cost 11,000 rupees. So rather than going into that stage, I think if you read Dr. Chaudhary's health adda repeatedly, you will be able to do a better job and save money. So this is the list of the drugs which are coming into market for treatment of the weight loss. As I said, 70% of the patient with fatty liver disease will have concomitant weight loss. And let's celebrate the discovery of this new drug called tirzepatide. This is a combination of two agents, but it is a GLP receptor and GIP receptor, that is glucagon inhibitory receptor. So two receptors are acting concurrently. And look at the results. Within a period of 48 weeks, you have a 23% reduction in the weight, as good as a bariatric surgery. So this drug, which is soon likely to be available in the market, look at the way it reduces fat in the liver. 93% of the fat is gone in the liver. So a combination of the GLP-1 receptor agonist coupled with GIP agonist is a drug called tirzepatide, which is available in the market in the Western world as a drug called Mozuo. And if you look at the results of this drug, this is the type of fibrosis and inflammation in the liver. Look at the red areas before the start of the therapy, and look after what happens after about 48 weeks. The whole of the red areas, that means advanced fibrosis, is gone. The green areas, that is F2 fibrosis, is gone, and almost the patient has no fat in the liver. So we have an objective proof of this dual GLP receptor antagonist doing a good job. And now, fortunately, we have another drug called retatrutide, in which you have a triple therapy, which includes a combination of the glucose, GLP-1 agonist, GIP agonist, as well as a glucagon agonist. So three things combined together. And now, within a period of 3 months, the studies which I have shown you with tirzepatide is over a result of 48 weeks. Now, within 3 months, you have a 24% weight loss. That is as good as bariatric surgery. Maybe with passage of time, we may not need bariatric surgery for the control of the weight. So a lot of drugs are started for treatment of NASH, but unfortunately they are not able to bypass the phase 1 and land up in the phase 2. And of those who land up in the phase 2, very few drugs tend to enter the phase 3. And finally, a very trickle ultimately lands up for us as clinicians to use. The only drug which has been approved is the resmetirom, but the cost is exorbitant at the moment, so it's not available by the generic companies. To sum up, ladies and gentlemen, whenever you have a normal fat, you will have a drivers of the fat which will try to put it to a stage of inflammation called non-alcoholic fatty liver disease. So diabeticity, high caloric diet, high fat diet, insulin resistance, coupled with underlying genetics will give you this problem. And then somewhere down the line, the bland fat gets converted into inflammatory fat called NASH, which is now called MASH, that is metabolism-associated steatohepatitis. What are those drivers? Why does the inflammation occur? Is because of the cellular components, metabolic derangement, presence of the reactive oxygen species, and underlying genetics which switch from simple fat to inflammation. And finally, as the inflammation keeps on occurring over a period of time, this inflamed liver becomes steatotic because of the activation of the hepatic steatase cells. So what is the current therapeutic armamentarium for management of MASLD or NAFLD or MASLD? In fact, it is important for primary care physician like most of us or endocrinologists to see that any patient who has a fat in the liver, it is just for us to look at the window of number of metabolic factors and abnormalities which can be occurring within that individual. You look at his weight management, look at the lifestyle changes, look at the way the nutrition has been advised to him, and as well as the lifestyle changes. In fact, most of the time you're able to stem the rot if you look at this various components of lifestyle management. It is only when the patient has advanced cirrhosis, that is F3 and F4, these patients are more likely to die of liver disease. That is where a hepatologist needs to step in to give experimental therapy on a day-to-day basis. So at the same time, because most of these patients have concomitant diabetes, hypertension, dyslipidemia, and obesity, unless you handle them, you will be doing a minuscule job. With that, I'll end up my talk and give it back to the podium.
Thanks for such a elaborate and knowledgeable talk. I think everybody is benefited. And now I shift the gear to from a milder disease perspective to a more severe disease perspective. That is to invite Dr. Agniva Datta to present the session. and we'll take the question at the end of the session. Sir, can you please come to the dais, please?
We would like to request our honorable chairpersons to please felicitate our speaker for today.
Take the opportunity to invite some of the questions from the whole audience for Dr. Anil Arora sir. Any question from the audience?
So thank you very much for a wonderful presentation. My one issue that what we have been taught earlier, that we should reduce the weight gradually. Now what we are seeing that with the newer molecule, the weight is being reduced very fast, even few kgs or more than this in a month. Do you think it can cause any adverse effect or any other problem?
Yeah, you see, I think that is a very relevant question. There have been some disadvantages of the rapid weight loss. One of them is the development of the gallstones and altered homeostatic milieu. But the reason why do we bring the drugs at the fag end of the management cycle is always you start with lifestyle management, always start with exercise and diet, restrict the calories, change the pattern of the diet. Because of the brevity of the time, I did not go into the details of what type of diet, but if you switch on to Mediterranean diet or intermittent fasting and avoid sugary stuffs including fructose, then you may be able to achieve a weight loss. So that weight loss is gradual, it cannot be rapid. With these newer drugs, what you are trying to achieve is a weight which is rapid, because the more GLP-1 agonists you keep on adding in the formulation, the more will be the stimuli to the brain to cause satiety, the lesser will be the outflow of the juices from the stomach down into the intestines, resulting in delayed gastric emptying. That will lead to weight loss. But the study which has been available to us, especially with semaglutide with weight reduction, up to a period of 7 years, there has been no adverse effect. Because what you are losing in excessive weight, so this is an extra weight which has been a burden on your body. It is causing harm to the body. The problem will occur if you tend to be less than your BMI, which is never needed, never achieved. In any case, these drugs are not to be given lifelong. If you are able to drag down your extra body weight to normalcy, so these drugs are safe. Don't be worried about that.
I want to ask from, after listening very nice academic discussion, I am inspired to ask one question. We are advocating weight loss. So we know that death in the non-alcoholic fatty liver disease is mostly from the cardiovascular disease. Whether weight reduction will help not only reducing the non-alcoholic fatty liver disease, or it will affect the cardiovascular disease death also. First thing. The second thing is, every time we are listening, you take coffee, but how much teaspoons of coffee to be added in the cup?
Yeah, both are relevant questions. The first question was weight reduction, how does it change the cardiovascular mortality? In fact, if you are overweight and if your liver is still not cirrhotic, the reason for death are primarily related to cardiovascular events. That means CVA or a coronary artery disease. So if you reduce weight, this will improve. If you already have developed cirrhosis of the liver, it's not that you will not die of heart disease, but then liver disease mortality also goes up. So reduction of fat, reduction of weight will help you in a dual manner if you are having fat as well as cirrhosis of the liver. So it is always a useful modality. It is never harmful. And what was the second question?
How much teaspoons of coffee to be added in?
In fact, the studies which have been studied, in fact, there has been a lot of debate. Dr. Chaudhary would remember every time there used to be, Shiva Prasad used to debate heavily whether it should be a decaffeinated coffee or a caffeinated coffee, 2 versus 4, 2 versus 4 cups daily, and whether it should be filtered or non-filtered coffee. But fact remains there have been no clear answers to that. What is recommended is the more the merrier. That means if you can do up to 4 cups of the coffee per day, that will be good. What we do, at least in North Indian Punjabi communities like tea and coffee, we take it as doodh patti wali chai. We hardly take any tea. The same thing happens with coffee. We put so much of sugar and so much of the milk that the taste of the baseline coffee goes away. So black coffee, at least 2 cups is good enough. Beyond that, the effects have not been shown, because it has been shown that it also causes, it is a phosphodiesterase inhibitor, and also as alteration. In patients with cirrhosis of the liver, there are baseline alteration in the genetic and epigenetics. So this drugs take care of that. So it is anything more than 2, irrespective of the type of coffee, is good enough. Beyond that, there are no randomized trials.
How much amount of coffee to be added in the cup?
In fact, that depends on how much you're able to consume. Most of the time, it should be milk-free, sugar-free coffee. 2 teaspoonfuls is good enough, okay, in at least 2 cups a day.
Okay, thank you, sir.
Yeah.
If I can add a little bit to the coffee enigma, that it is that always better that instant coffee is not meant for. It is the beans coffee which has to be crushed and put in a tablespoon, and the brewing is very important because you have to pour the hot water over the beans. The extract of the coffee, that is 80 ml, is beneficial for curtailing the fat load in the liver. I think if there is any question,
Dr.
we
Chaudhary
can.
had a comment.
Okay, thank you, sir.
Another thing is, earlier it was thought that all benefits of the coffee are related to a substance called caffeine. That is no more true. Even if you decaffeinate, the protective of the coffee still remains. We do not know the chemical which is causing the utility.
Sorry, but I think what you said is absolutely valid. I was just putting a spin to it. You see, how this whole story of coffee came about is because insurance companies in the western part of the world, particularly Scandinavia, they look at long-term data and they saw that, look, there are some people who seem to be living well, having low incidence of cardiac disease, low fatty liver. So then they usually have a long questionnaire that what do you do and what you don't do. And it turned out that people who seem to have good liver functions and less fat, they mark that they have more than 3 to 5 cups of coffee a day. So that is how the whole observation started. Now to convert it into therapy from an observation is always tricky business. And to be frank, the 2 things were, where is Pradeep Bhaumik? Pradeep Bhaumik is not here. Okay, yeah. You know, one of the areas where India has fallen behind is that, see, those fellows made an observation and they published it. And therefore, there has been a huge promotion of coffee as a therapy. Now, there hasn't been a similar study done with tea. Now, tea, for example, has got a lot of polyphenols, which is also supposed to be good. It's got one negative thing, that's called tannins, which could be harmful, but that's the reason why people put a bit of milk to neutralize tannins. Now, we actually haven't done a study, and by default, therefore, it stands out that coffee drinking is very useful, whereas tea drinking doesn't help. So it's more actually a lack of evidence than actually a positive evidence unequivocally proven, which has happened. So I was telling Pradeep and his team, you people should be able to produce data which is publishable data. I mean, the other area which has really happened a lot, I hope all of you are aware. Can I just digress for a minute, half a minute? Which is the most popular healthy oil that you people use? Ki tel badite use kocho?
Those who can afford olive oil.
Now you see, this olive oil does not occur in any part of the world except Mediterranean. Okay. Now look at those people, they are so bright. They did studies and they showed that olive oil is the most wonderful oil. It has been actually voted to be the best oil. How do we know? Do you know olive oil actually is not good for deep frying? It has got something called a smoky temperature which is quite low. Now, what is used in the Western world is actually olive oil as a dressing for salads and so on and so forth, but not for deep frying. Indian food is deep fried. We have been using saturated fats. Ghee, tel, in fact, Dokkina, it is coconut oil. So there was a huge amount of speculation that these are very harmful. So there came this era about polyunsaturated and monounsaturated fats. Are you all familiar? PUFAs and MUFAs. And the recent article by A.C. Anand in his book, Curbside Consultation, it deals with fantastic observations from a researcher in the United States who showed how faulty the data was, but it got published because the person who was the first author was a very important fellow. And that has made a mark all over the world. So, ekhane na mane jemni election er age je propaganda hoy na tar age সবাইকে একটু বুদ্ধি ব্যবহার করে দেখতে হবে যে ভাই কোনটার মধ্যে কতটা অ্যাকচুয়াল খাঁটি সত্যি আছে so that's I hope you don't mind I spoke in Bengali.
I have to translate. You have to translate me later.
So what I said is that it's just like the election where everybody almost promises the moon, but you have to actually see how much of real core value is there in whom. So similarly in this world of propaganda, the truth is actually an isolation. We have to be careful. But I agree with all the data that you people have shown.
So if there is no other question, we can move to the next session. Let's have a great round of applause. So we invite here the next speaker of the session, Dr. Agniva Datta. So there is a shift from the milder topic of MASLD, very useful topic, to severe form of the liver disease, that is acute on chronic liver disease. So here we pass the session to honor the speaker, Dr. Agniva Datta.
Thank you, chairpersons. Thank you, Dr. Bhomik, for this kind invite and HFT as a whole. So today, can I have my slides? So today I'll be discussing a very common topic. So since the postgraduates are there, how many have you managed an ACLF patient? Just a show of hands, simple. So I don't see any hands, but I think after my talk, you will raise your hand. So these are the main outline, the concept of ACLF. There has not been any other disease where so much controversy and so much difference of opinion, whether between East and West, and what is acute decompensation and how can we differentiate from ACLF, how to evaluate, and their management. So every term can be discussed upon. It is acute on chronic liver failure. So what constitutes an acute insult? Can it be a liver insult or can it be an insult outside the liver? What is the chronic state of the liver? Is the patient is cirrhotic, non-cirrhotic, compensated cirrhosis or decompensated cirrhosis? What constitutes the failure, a liver failure? How much of a liver failure we should tell it as a liver failure and how to assess them? And should extrahepatic failure be a part of the definition of acute on chronic liver failure? So all these are very controversial and there is a lot of difference of opinion. So back in 2014, the HFT definition, which was previously based on consensus, later turned on by a study. It is acute hepatic insult manifested as jaundice with serum bilirubin of more than 5 and coagulopathy with INR more than 1.5, complicated within 4 weeks by clinical ascites and or hepatic encephalopathy in a patient with previously diagnosed or undiagnosed chronic liver disease or cirrhosis. Now let us remind ourselves, chronic liver disease is not equivalent to cirrhosis. A patient who has a hepatitis B infection of more than 6 months is chronic hepatitis B, but he or she may not be cirrhotic. And it is associated with a high 28-day mortality. So this constitutes the entire HFT definition. What about the EASL definition? It comes from the canonic trial. It is an acute deterioration of pre-existing chronic liver disease, usually related to a precipitating event and associated with an increased mortality at 3 months due to multi-system organ failure. So the CLIF definition recognizes extrahepatic organ failure as a part and parcel of acute on chronic liver failure. Now, we end up grading ACLF by the CLIF ACLF definition. So what is no ACLF? That is no organ failure. The green portions are the no organ failure, the yellow ones are dysfunction, organ dysfunction, and red ones are failure. If there is no organ failure, if there is single non-kidney or organ failure or cerebral failure with creatinine of less than 1.5, it is no ACLF. ACLF1 is kidney failure or other failure with renal brain dysfunction or brain failure with renal dysfunction. These will constitute ACLF grade 1. ACLF grade 2 is 2 organ failure. ACLF grade 3 is 3 or more organ failure. So if we compare the East versus West, the East recognizes a bilirubin of 5 milligram or more as liver failure, but West recognizes it has to be 12 milligram. INR has to be 1.5, where in the Western definition it is 2.5. Hepatic encephalopathy, any grade can be taken, but only 3 and 4 will constitute failure. Duration of between ACLF and insult and ACLF is 4 weeks, but in the Western definition it is not defined. And East does not recognize acute sepsis as an acute enticing event for an acute or chronic liver failure, but West recognizes it. And variceal bleeding is again controversial, I'll come to it. And there is no scope of extrahepatic organ failure in APASL definition, but it is a part and parcel of the Western definition. And in the advanced decompensation also, the ACLF can occur as per the Western data, but not in the Eastern part. So these are two different populations. So multiple studies has been undertaken that are the definition picking up the same population or not. It is seen that there is, if we apply the same definition into different population, a group of patient may satisfy the Western definition, but that is not following the Eastern definition, and combined only 20% are inside the both the definition. So the prognosis and how the detection is variable if we are taking the Eastern and Western definition. So acute insult, definitely if we consider hepatic insult, like hepatitis B reactivation, hepatitis C reactivation, HIV infection, other bacterial and protozoal infection can be failure. Alcoholic hepatitis is a very well recognized cause of acute insult. Drug-induced liver injury, we can call it ACLF-D. Autoimmune hepatitis flare is important because 50% of autoimmune hepatitis flare may be autoantibody negative. So unless and until we have a clear open our mind, we will miss those autoimmune hepatitis patient. And acute variceal bleed. In the Eastern part, it is said the acute variceal bleed will cause hypotension, liver ischemia, producing infection that causes failure. Variceal bleed per se may not be etiology of failure, but there is controversy regarding that. And definitely hepatic venous outflow obstruction or portal vein thrombosis may cause failure. What about sepsis? Suppose we are dealing with a pneumonia patient. The patient is having elevated creatinine. We don't call it acute on chronic kidney failure. But if the patient is having a liver failure, why do we call them acute on chronic liver failure? That is the logic put forward by the Eastern authorities. But West recognizes that sepsis can cause damage to the liver that eventually gives rise to acute on chronic liver failure. So this is a very elegant study published just 1 month back by Professor Shalimar and group. The world is divided as per the WHO region, the American region, the European region, the Mediterranean region, the Western Pacific region, and the Southeast Asia. So if the studies that has followed the APASL definition, around 25%, the most of the patient, the etiology has been alcoholic hepatitis. The next comes the systemic infection. And in the Western Pacific, as Gurdas sir was discussing, there is a high prevalence of hepatitis B. So hepatitis B reactivation is a predominant cause in the Western Pacific region. But the studies where used the EASL definition, again the sepsis becomes the primary etiology. And all over the world, the sepsis become the more prominent. But if we go into the APASL definition, alcohol is the most common etiology. What about the chronic etiology? Again, alcohol remains very important in the Southeast Asia as well as Europe. However, in Western Pacific, hepatitis B becomes a prominent reason. And if we consider the EASL definition, again, alcohol becomes a very prominent, followed by hepatitis B. So now, if we compare the different definition, there is concordance between APASL and EASL definition around 14 to 80% as per the studies. The North American Consortium definition considers sepsis and 2 or more organ failure. The concordance of APASL and NACLD is 7%, and EASL and NACLD definition concordance is 13 to 25%. So if we use different definition, we'll pick up different population. So if we try to simplify the thing, if the patient is already having a normal liver, acute insult may produce acute liver failure, that is coagulopathy and encephalopathy. However, if the patient is having ascites, we have to think of acute on chronic liver failure. If the patient is having chronic liver disease, then this acute on chronic liver failure. That is the population picked up by ARC ACLF definition. But if the compensated cirrhosis with some events of decompensation, then it is the ACLF as per the CLIF definition. And in advanced decompensation also, the CLIF definition will hold. And Dr. Jalan's group has subclassified it. If it is the chronic liver disease with acute insult, it is ACLF A. With compensated cirrhosis, ACLF B. If it is decompensated cirrhosis, ACLF C. So how to differentiate the acute decompensation from acute and chronic liver failure? Suppose a patient with alcohol-related liver disease with an ascites kept on binging developed a jaundice with organ failure. As per our Eastern definition, that is an acute decompensation, but as per Western definition, that becomes an acute or chronic liver failure. So ACLF, there has to be hepatic insult, and that should be the index presentation or index decompensation. However, for acute decompensation, it may be index hepatic or non-hepatic case. 95% case in ACLF, we can find a precipitant, but in acute decompensation, it can be found in 70%. Timeline for ACLF is 4 weeks, but for decompensation, it is 12 weeks. Underlying cirrhosis, as per definition, ACLF may or may not be present, but for decompensation, its cirrhosis has to be there. And there should not be any prior decompensation in ACLF as per the Eastern definition. And the acute decompensation can occur in a previously decompensated patient. And definitely, very important thing is that ACLF has very more short-term mortality, but long-term it may be the patient may recover. But in acute decompensation, short-term mortality is less, but the patient have more long-term mortality. So again, this is a very important study, the PREDICT study. They try to classify a patient coming with an acute decompensation, how the patient will behave. The PREDICT study, they have found the person admitted with first decompensation may behave in 3 ways. It may be pre-ACLF, later on the patient may develop an acute and chronic liver failure. Again, the patient may be unstable decompensated cirrhosis. The patient may have multiple episodes of decompensation in the next 1 year, or the patient may be stable decompensated cirrhosis. There may be only one admission within the next 1 year. So, but the outcome is different. So the 2023 EASL guideline of ACLF, so whenever the patient is coming with an acute decompensation, there may be total 6 clinical phenotypes. That is the stable compensated, unstable decompensated, pre-ACLF, and there may be ACLF grade 1, grade 2 or grade 3. Why this is important? Because phenotypically they are different. Because ACLF acts just like sepsis. All the sepsis parameters, total WBC count, CRP, interleukin 8, TNF, all markers are elevated in ACLF group, then AD group, then the compensated cirrhosis group. So it behaves like a systemic inflammation. So why this is important? Because if a person who has a compensated cirrhosis or non-cirrhotic chronic liver disease, they have a good hepatic reserve. So whenever there an injury occurs, there may be loss of liver function, the patient may recover. However, for decompensated cirrhosis, once there is injury occurring, there may be progressive downhill course. Now, if we try to look at it closely, so if within the 0 to 7 days, when the liver function is deteriorating, the patient may recover. So this portion is called as the golden window, because early intervention, we can salvage those patients. So if the mild disease, the patient may recover. If the patient sequentially develops organ failure, then we have to discuss transplant. If there is very progression of failure, higher grade of ACLS, there may be a futility of care as well. So previously, cirrhosis thought to be a single entity. Now, if we look closer, even the metavir 4 fibrosis, which is known as cirrhosis, can be subdivided at 4A, 4B, or 4C. That is based on the thickness of the fibrous septa and the size of nodules. So if the earlier 4A stage, there may be minimal portal hypertension, hepatic venous pressure gradient of 5 to 10. As we go on higher along the spectrum, there may be clinically significant portal hypertension. And when their HVPG is more than 12, there is higher risk of major events. And in the earlier group, there is less amount of splanchnic arterial vasodilatation and cardiac output is normal. As the disease progresses, splanchnic arterial vasodilatation occurs. Initially, body tries to compensate by elevation of cardiac output, but later the mechanism fails and there is hemodynamic impairment. So as we go on, that all the persons will behave differently when an acute insult occurs. So the ACLF will also different whenever we are dealing with what previous stage the patient was in. So this is a very important paper. It is not ACLF, but it is showing it for the postgraduates. It's a DMICO study, how the disease progresses as 5 years. Initially, it was 2014 article, the stages of cirrhosis. If the patient with no varix, there is 1.5% chance of death. If the varix, there is 10% chance of death in 5 years. But if there is 2 decompensation, the risk goes to 88%. However, with all this concept of ACLF coming up, we progress to the states of cirrhosis. The state 0 is no minimal portal hypertension, and state 5 is further decompensating event. ACLF can occur at any phase, any state of cirrhosis. That is the Western concept, again I am highlighting. So why this is important? Because the mortality differs. If we look at the time of the day, the ACLF3, the ACLF2, and the ACLF1, if we look into the first 4 weeks, that is the higher mortality. But later, after the first 1 week, the mortality gradually stabilizes. However, the unstable decompensation, the mortality starts to increasing, say, from day 30. However, stable decompensated cirrhosis, the mortality is less. So that is why we should define our patients so we can prognosticate and manage accordingly. So how do we manage? So first, we have to determine the acute event. We should find the etiology of chronic illness, no-brainer. We should assess the risk, some general management, etiological management for antivirals or something else, and there are some specific therapy that I will try to discuss. So how do we stratify the risk? The child score and MELD score, that is used in stable compensated cirrhosis, but they do not hold very well in acute on chronic liver failure. Apache score and SOFA score are used in ITU care where there is related to the organ failure. Now, we will be discussing the ARC score and CLIF-ACLF score that is more relevant for acute and chronic liver failure. So the ARC score is very simple, just like a CTP score, considered bilirubin, HE, P-time, all three are component of CTP. Lactate, it is a marker of tissue perfusion, and creatinine, marker of renal function. By combining the score, if it is grade 1, it is 5 to 7, 28-day mortality is low, it is 13%. Grade 2 is 8 to 10, mortality is 45%. Grade 3 is 86%. Now, CLIF-ACLF score is a complicated score, but you need not worry. You just put in your search box, the CLIF-ACLF score, the calculator comes. You just put different values, and it will give you a value. And if you don't have internet, if you don't have smartphone, which is hardly believable, but if you just count the number of organ failure is also a marker of a 28-day mortality. If there is more than 3 organ failure, there is around 80% chance of mortality. If there is no organ failure, there is almost 5% mortality. So if I am just writing the advice of an ACLF patient, I will write ACLF, acute etiology this, chronic etiology that, number of organ failure this, R score this, and CLIF-ACLF score of that. So that will complete my diagnosis. Now, it has been compared, it has been seen the ARC score may be the better determinant to determine the mortality as compared to all the other scores as I just described. Now, since those are the static and dynamic model, then multiple scores are being used. There is just as an example, dynamic model to allocate the liver, because liver allocation is a very controversial topic. If the MELD NA is stable, but if the MELD NA is rapidly deteriorating, that may be more priority for a liver transplant than a patient with a stable MELD on an ACLF patient. So the standard management, it is very important. That is, we should assess the organ failures. We should search for excessive alcohol consumption. We should search for infections, search for external hemorrhage. The drugs that causing encephalopathy or AKI, very commonly aminoglycoside and NSAID, we should keep aware of those things, and we should monitor the vital signs. Now, what investigation we should send? Definitely CBC, KFT, LFT, P-time INR, CRP, and procalcitonin. HCV RNA, hepatitis B, hepatitis B DNA, and HEV is very recognized, and we have therapy for that as well. So we should screen for HEV as well. Diagnostic paracentesis to look for spontaneous bacterial peritonitis, chest radiography, urine analysis, culture of blood, ascites, urine, rectal and nasal swab for atypical infection, and abdominal including renal ultrasound should be done in all patients. Now, should we go for liver histology? It is again a controversial topic. A patient of ACLF will invariably have coagulopathy and ascites. So transabdominal biopsy is out of the question. Transjugular, it is not routinely recommended. It should only be done when it can change the management. Suppose we are thinking the patient may be having a acute severe autoimmune liver disease producing ACLF, we can do for transjugular liver biopsy. There are some markers that can help us to tell this is autoimmune hepatitis induced ACLF. And again, Rastogi described two patterns. Pattern 1 is ductular bilirubinostasis, extensive necrosis, advanced fibrosis. Those are poor prognosis. But only for prognosticating patient, a liver biopsy is not recommended. Nutritional support. Most of the time we give supportive therapy, we forget nutrition. Nutrition is very important. We should screen malnutrition by validated tools like Royal Free Hospital, NPT and all. Target energy should be 30 to 35 kilocalorie per kg per day. Target protein should be 1.2 to 1.5. This message should be very clear. Even in patient with encephalopathy, there is no role of protein restriction. Oral intake is preferred. If not, we should give enteral feeding by nasogastric feeding. Micronutrient supplementation to be done. Even because cirrhosis is a state of accelerated fasting, if the patient is fasting for 12 hours, IV glucose drip should be given. And if the patient is malnourished for a long time, we should keep mind for refeeding syndrome, because that can be a very menace in the ICU practice. So we end up mostly doing the organ supportive therapy. There are different axes I will be discussing one by one. Infection, we should work up diagnosis, all the cultures and blood tests. We should do high-dose broad-spectrum antibiotic, and we should assess antibiotic therapy, whether this is working or not, whether it should be up-titrate or down-titrate. And the antibiotic should not be delayed pending culture. If the patient gets admitted at night and culture bottle will be available tomorrow, it is advisable to give antibiotics. And also we have to keep in mind antifungals. I will be discussing it later as well. Kidney is important. Yesterday, I think a session on kidney failure was done in the cirrhosis. So previously the HRS1, HRS2 was used. Now the HRS AKI, HRS NAKI definition is used. So if the patient coming with AKI, again creatinine is very poor biomarker. A dynamic elevation of creatinine of 0.3 in 48 hours should be the guideline, as well as the urine output should be the guideline rather than an absolute creatinine value. And if the patient is having AKI, volume expansion with albumin, and the patient is not responding, that may be HRS1 or the HRS AKI, then we should give albumin with terlipressin. Again, we should not rush into hemodialysis. All the criteria for renal replacement therapy like acidosis, which is not clearly managed, refractory hypokalemia, uremic encephalopathy, those should be the indication of RRT. We should not, just by looking at the creatinine value, we should not subject the patient to the RRT. So for the lungs, endotracheal intubation is advocated for the patient with hepatitis encephalopathy grade 3 or grade 4. We should give a prone position ventilation is feasible, and if the patient is having tense ascites, we should give therapeutic paracentesis. Again, there may be misconception in somebody that hepatic encephalopathy or sepsis is not a contraindication for therapeutic paracentesis. So for gastrointestinal stress ulcer, prophylaxis may be done, and oral or enteral feeding, as I mentioned. For initial days, since we are thinking of chance of refeeding syndrome, target calorie should be 10 to 15 kilocalorie per kg per day by day 4. For hemodynamic, again, just like a surviving sepsis protocol, early goal-directed therapy with target map of more than 65. Again, crystalloid and 5% albumin may be better. Colloid should not be used. Again, albumin indication are spontaneous bacterial peritonitis, large volume paracentesis, and AKI. And norepinephrine is the preferred vasopressor compared to the other two. For coagulation, again, if the patient is having platelet of 50,000, we should not transfuse platelet. INR of 2, we should not be giving FFP, unless until we are planning some intervention. And we should not forget the prophylaxis for deep vein thrombosis, since INR is a very poor marker, thromboelastography is not available widely. So the patient even with elevated INR may be a candidate for DVT prophylaxis as well. And definitely for central nervous system, we should treat the underlying cause. Lactulose and enemas, those are standard things. We should use sedation protocol and avoid benzodiazepines. So antimicrobial, there are different Indian studies. Their MDR organism may be as high as 70% patient. So by just admitting a patient of cirrhosis with advanced decompensation, and if you're giving ceftriaxone, we may not be doing justice. So local sensitivity profile should be found, and we should tailor our antibiotic accordingly that. And common sources of infection are SBP, pneumonia, UTI, and soft tissue. We should actively search for that. And local sensitivity profile, we should choose antibiotics. And there are multiple risk factors for fungal infection, prolonged antibiotic exposure, multifocal colonized patient is having 2 or 3 tubes stuck in their body, indwelling catheter, total parenteral nutrition, diabetes, prolonged ICU stay, renal replacement therapy. Most of the time, echinocandins are preferred rather than our fluconazole or voriconazole. Now, another important thing is beta blocker. What should we do with the beta blockers? Now, the patient, it has been shown, the patient those are already on beta blockers, they have less severe ACLF and there are slower progression of ACLF. So, if the patient is already on beta blocker, unless there is hemodynamic compromise, we should continue beta blockers. And the patient who has discontinued after ACLF, there is higher mortality, and the cause of discontinuation, hypotension, respiratory distress, and as well as AKI, there we tend to stop the beta blockers. And again, there is a study on the alcoholic hepatitis group. Using carvedilol, there is improvement in mortality, development of spontaneous bacterial peritonitis, and development of AKI. So beta blockers may be beneficial in ACLF as well. Now, all these are general therapy. Now, I'll try to highlight one or two specific therapy. Like GCSF, there is a very controversy between the Eastern data and the Western data. Back in 2012, the Professor Sarin's group published this small study. At 23 patients got GCSF and 24 was in the placebo group. There was significant difference of mortality in the GCSF group as compared to the placebo. However, the same study could not be replicated in the Western study, so there was a Western world, so there was a lot of controversy. But since if we remember the figure, in the APASL definition, we are picking up the patient early, probably in the golden window. If we use GCSF in the golden period, then again, it may be beneficial. Again, if there is a systematic review, only one study is from Germany, rest from India and Bangladesh, and one from China. In the German study, there is no difference, but in all the Indian study, Bangladesh study, there is a significant favorable effect of GCSF. However, even in the 2019 guideline, APASL is not advocating GCSF. It is not a miracle. It should be only done in the selected population or in the trial setup. Once the stronger recommendation comes, it can be used. Now, what about albumin? Many a time people see the low albumin value and transfuse albumin, which is a wrong practice. Albumin is an active mediator. If the left side diagram is too jumbled, let me simplify it for you. Albumin has three domains. One domain is metal binding domains that remove toxic reactive metal species. Domain 2 binds a variety of substances like a long chain fatty acid, bilirubin, anion, bile acid, and domain 3 contains an thiol group that reduces the oxidative stress. So albumin is not a passive thing, it's an active thing. However, again, the recommendation still is not for everybody. Large volume paracentesis, dose is 8 gram per liter of fluid remove. AKI, dose is different, 1 gram per kg per day. SBP, it is 1.5 gram per kg on day 1 and 1 gram on 40 day for day 3. So it has been seen that the higher the ACLF grade, lower is the response of albumin. So if we give albumin early, there may be better response rather than the late in the stage. There are multiple extracorporeal liver support devices. The artificial dialysis membrane is one, is the plasma exchange. This is very commonly used. It has special benefit in autoimmune liver disease as well as Wilson's patient. It can be bridged to transplant as well as recovery. And most of the studies are in the viral hepatitis group. The MARS system, again, blood is circulated across the albumin. The high intensity therapy may improve the mortality, but more data is required. Again, Prometheus system is the two columns. One is the large pore filter and one is the absorptive column. The Helios study was conducted. There was no definite benefit found. The DIALIVE, Professor Jalan's group is supporting the DIALIVE group, artificial liver support and albumin infusion. There are small trials. Larger trials may be beneficial in the ACLF group. And ELAD, that is biological membrane, human hepatoblastoma cell line, but phase 3 trial was conducted. There was no survival benefit was found. So again, the study was conducted in 2010-11, but published this year only. It is a small study of 10 patients, plasma exchange with albumin done in day 1, 2, 4, 6, 8, and 10. Since a small trial, there is no comparative group, but it has been found to improve circulatory function, renal function, cerebral function, all the functions. So plasma exchange with albumin may be something for the future that may we use. What about fecal microbial transplant? There has been trials. I'm just quoting a trial in the severe alcoholic hepatitis ACLF, where the patient underwent a single session and the healthy family member was chosen as donor. There was significant improvement in the 28-day survival, 90-day survival, HE resolution, as well as ascites resolution in the FMT group. So just as an overview, the commonly things we are giving, the beta blockers, terlipressin, GCSF, the antibiotics, the rifaxiamines, everything that we are using in the ACLF group. What about transplant? Previously, it was thought that whether the candidate should be a transplant or not, because it is so high going and there is high mortality and there is high risk of secondary infection. Let us remind ourselves, systemic infection or massive sepsis is a contraindication for liver transplant. So we should select our patients judiciously. So the candidate should be baseline male more than 28, ART more than 10, advanced HE without overt sepsis or MODS. And there are multiple studies quoting multiple urgent listing criteria like male more than 30 with HE, bilirubin and INR, higher grade of HE, HBV reactivation with high bilirubin and low platelet, and steroid ineligible. Previously, it was thought the abstinence is required for the patient to qualify for liver transplant. Now, in the acute failure or acute and chronic liver failure group, although there is a chance of recidivism, we can select population for liver transplant as well. So, to summarize everything, if we use the ARC algorithm, so if the patient comes with ACLF, we should identify the acute and we should give that therapy. Like for severe alcoholic hepatitis, we can use steroid, GCSF or FMT. For HBV, nucleoside analogs. For AI, steroids. For DILI, plasmapheresis, and stop the therapy. Wilson, there may be plasmapheresis. And we calculate the ARC score. And with this conservative management, if the score is gradually improves, then we can go for the regenerative therapy and standard medical therapy. If the score is not improving, again organ support, bridge therapy like renal replacement or plasmapheresis, and we can prepare the patient for renal transplant. However, if the patient is a higher grade of failure, if there is no extrahepatic organ failure, again the patient becomes a candidate for transplant. If the response is not more than 2 or the patient is deteriorating, again we have to decide whether the patient should go for transplant, or if the higher ART score, the patient we should prognostic and give the supportive care. Now if you go by the Western guideline, whenever a patient comes with say jaundice and ascites, you do the CLIF-C ACLF score or the CLIF-C AD score. It will tell you whether the patient is having acute decomposition or ACLF. If the CLIF-C AD score is less than 45, we can prognosticate 3-month mortality is less than 2%. If it is high risk, we can prognosticate accordingly. Again, most of the time with ACLF, we tend to admit in the ICU for organ support and do medical management. And by the grading, no ACLF, ACLF 1, ACLF 2, we can prognosticate. If the patient is landing up with more than 4 organ failure or CLIF-C ACLF score of more than 65, then the 180 mortality survival chance is 0%. So we should prognosticate and we may withdraw care in this patient also. So now some advanced things that biomarkers is becoming very popular. So biomarkers can be 7 types of biomarkers as per WHO definition. For example, diagnostic biomarker phase angle is for to detect sarcopenia. There may be metabolomic signal to detect acute decompensation from ACLF. Plasma renin concentration may indicate the circulatory status and renal dysfunction. Monitoring biomarkers, as I discussed, CLIF-C ACLF score creatinine we are using to monitor our patient. We can check the response, suppose for if we are using beta blocker, whether this is causing HVPG reduction or not. Predictive biomarkers, a von Willebrand factor of more than 5% may predict a beta blocker response. For liver support therapy, a pulse score is proposed. Its components are sepsis, cirrhosis, bilirubin, HE and INR. It can predict the candidates for liver support therapy. CLIF-C met again a metabolic biomarker for prognosis. Safety markers, for example, in DIALIF study, the bilirubin ALT and AST was used to assess the safety and susceptibility, risk of progression. You can go through the PREDICT trial. There are multiple parameters like bilirubin, simple parameters, bilirubin, creatinine and total count. By that, they have made a predictive model to know if what is the probability of patient landing into ACLF in the next month. And there are multiple emerging therapy like toll-like receptor 4 inhibitor, recombinant alkaline phosphatase, those are animal trials, emricasan, mitofuscin 2, oxysterol, statins, and stem cell transplant. So I am just showing this slide not to describe everything, just to show a lot of exciting things going in the field of ACLF, and with time we may have multiple options in our armamentarium. So to summarize, ACLF is a distinct symptom in natural history of CLD and cirrhosis. There is significant difference between Eastern and Western approach. So that idea should be clear. If it is compensated cirrhosis or chronic liver disease, that comes into the Eastern definition. Even in the advanced decompensation, West recognizes as ACLF. Early detection is the T. Again, if I may say, the Eastern definition picks up ACLF early. Detection of acute and chronic component is necessary. We should stratify risk as per the validated score, R score and CLIF-C ACLF score. And the supportive therapy should be protocolized. The nutrition, the fluid, the albumin, the antibiotics. And we should monitor the response every day, and we can use some novel therapies in specific population. Thank you so much for your patient listening.
Thanks, Dr. Agniva, for such a elaborate and nice presentation. So here we open the session for some question answers from the audience.
So one more question for Dr. O'Neill. It is well established that if we reduce 10% of the body weight, there is the reversal of the fibrosis. But how long we have to maintain it, and we have to maintain the plateau, or some degree of increasing weight will, again, there will be accumulation of fat?
Yeah, I think this is important to understand. Of all the measures which I have told you in an effort to lose weight, only 10% of the people will be able to lose 10% of the weight. And it has been consistently shown that if you want to improve fibrosis, the least you need to do is to lose 10% of the body weight. And if you stop exercising, if you stop following the lifestyle changes which have made you lose weight, if you stop the medication which you have to take to reduce weight, there is a 50% chance that you will get back to your normal self. In fact, there is something called apostat. It is like a thermostat or a barostat which tends to maintain the temperature. So there is an apostat in the brain. If you start eating less, your BMR decreases. Because if your intake is less, by default your BMR decreases, and hence you do not lose weight. So that apostat has to be repeatedly reset. And in spite, and even after losing 10% of the weight, you have to continue lifestyle modification. That cannot be overemphasized. That is a baseline thing. Otherwise, your apostat will reduce your total BMR, and in any case, you will be getting back to your normal self. So that is a prerequisite. And old scale, yes. No, to your old body weight with which you had started. Yeah.
Normal is misleading. Normal means that, the liver becomes normal.
Yes.
So that's not.
So, and any weight loss is significant, but the body will try to drag you back to your overweight status if you do not follow. So this is just a prelude. It can tell you that you have a reversible disease. It can tell you that you can have a cardiometabolic protection with lifestyle changes, and it will stimulate you and rejuvenate you to do something which is active. Mind you, mortality is not all related to the liver. It is related to the cardiovascular events which can be fatal.
No, I entirely agree, Anil. So the word that I would have wanted you to use is attitude change.
Yes.
Because, basically you have to change your attitude that, look, this so-called new normal, which I am getting into, I will live with the new normal and accept it as, like boast of the fact that I have lost 15 kgs, boast of the fact that I am going trekking, boast of the fact that once in a week I can have my mutton curry with puri. But, you can't do it on a regular basis. So that you have to make an intentional attitude change. So that's the issue.
Yeah, I'll fully endorse that. Unless you have lifestyle changes which are consistent on long-term basis, these advantages of weight reduction of any degree may be minuscule, they may be temporary, they may not be rewarding. So you have to stick to the basics. Can I ask a question to Dr. Datta? See, whenever a patient has an acute insult in any chronic liver disease, say you have a poor cardiac functioning and suddenly you get a infection, myocarditis, you will have the same thing. Same thing occurs in acute and chronic kidney disease, acute and chronic COED. So what is so different in liver? Why do we talk so much about ACLF?
Because, sir, the baseline hemodynamic changes are different as we go on from the compensated to advanced decompensation of the liver disease. And so whenever there is some insult, as we are discussing, that the extrahepatic insult may produce liver failure in advanced decompensation, but it may not be adequate enough to cause failure in the compensated state or non-cirrhotic stage.
And take any disease, let's say in acute pancreatitis, you have 1 organ failure, 2 organ failure, 3 organ failure. The more the organ failure, more you are likely to die. So why these grades? Maybe Dr. Chaudhary would like to answer that. Why? See, you have any acute disease which has acute decompensation on a chronic liver disease, say acute and chronic kidney injury. If you have 3 organ failure in any disease, in acute pancreatitis, you are more likely to die. So what is sacrosanct about ACLF? Why is it different from, say, decompensation, and how will treatment be different? Treatment is the same. Tell me one thing which is different in ACLF in terms of mortality.
There are so many people waiting for lunch, but I'll be very brief and crypt. He's a young boy, so he has presented with a lot of enthusiasm, telling almost all the details that he could actually tell. Remember that if there is too much details in anything, that means your actual substance is a little weak. In the sense, if your food preparation at home is not very tasty, you tend to cover it with much more spices. It's common sense. So the fact that there is such a complicated issue on acute and chronic liver disease, it means that we are still not very sure about many things. The outcome is bad. We are struggling. So he has actually put out a point of view that how infinitesimally little that we know, and yet what are the areas in which we are trying to explore. But I think the end is still pretty far away. I hope I have summarized.
Definitely.
So otherwise, there wouldn't be so much debate about it. For example, I can see some people with a little graying of the hair, or some people without hair. So I'll tell you, long time back, 30 years ago or 40 years ago, textbooks of medicine had an 18-page long chapter on syphilis. So primary syphilis, secondary syphilis, tertiary syphilis. Nowadays you see it's a one-page chapter. Things have become so simple, both in terms of diagnosis as well as in terms of therapy. So simplicity comes when you have been able to actually unravel a complicated story. So in ACLF, we are still a far way off. Have I said that right? Anil, do you agree with me?
My impression is treatment will be the same.
Oh, I agree with you. In fact, ultimately, see, at this moment, there's only one thing. If you have a hammer in your hand, everything looks like a nail. So you have liver transplant. The results are not bad, but affordability and getting a donor is a problem. But if at an optimal time you can get it done, probably that gives the best chance of survival. The rest of it is, you will have some papers one day on albumin, some papers on GCSF, So it's a question of how you want to pursue which area. So that's in fact, you have done some very good work on ACLF, GCSF and all.
We have done not in ACLF, we did it in cirrhotic patients. And we have shown those given GCSF have better results. And somehow there has always been a dichotomy between the Eastern and the Western result. Is there any disease in which the definitions of a disease are different in the Eastern and the Western world? Disease is a disease. And let me give you the story of BMI also. Dr. Chaudhary told us about a swing in, you talked of coffee, how it came into being. Same thing happened with BMI. Now, BMI is not a parameter which was ever defined and adjudged for assessment of the health of the patients. It was a parameter which was developed by a fellow who was a insurance agent. Same thing. So he developed a protocol, and that was in 1932. He was asked by a company to tell us which particular group of the people try to suck out a lot of money from insurance company. So we analyzed all the data and came with this concept called body mass index. He's a Spaniard. He was a statistician, not a doctor. And those with a BMI of more than 35 at that time were consuming the maximum mileage from the insurance companies. So it is not still been validated as a health parameter. So most of us still dependent on that. That is a reverse swing to that.
So here we end the session with a presentation to the speaker itself from the chairman.
May I have the honor to request Dr. N.L. Bhomik to come upon the dais to present a memento of our appreciation to the respected chairpersons. Thank you, sir. Have a big round of applause for our chairpersons. Our next session will be Physician Dilemma. This session will be chaired by Dr. Ajit Chaudhuri and Dr. Arindam Datta. May I request our respected chairperson to kindly take their chair. In this session, our speaker is Dr. S.K. Seril. He will speak on the topic Fluid Management in Cirrhosis with Septic Shock. Thank you.
Please.
Good afternoon. Though it's not a very suitable time to make you wait, but this is a very nice lecture. A very reverend person. Actually, we were eagerly waiting for his presence here, but because of his unavoidable personal reason, he could not come. But he is kind enough to deliberation whatever he is supposed to give. He has sent us on the advanced technological process by video. So I shall request all of you to give due regards to this important chapter with such an reverend speaker, though he is not physically present. Thank you very much.
Good morning. Greetings from the Institute of Liver and Biliary Sciences, New Delhi. I am grateful to Dr. Preventive.
Today I would like to cover some new concepts and basics on fluid management in cirrhosis with septic shock. I have nothing to disclose. Blood volume is central or non-central. Central blood volume is in heart, lungs, and central arterial tree. Good morning. Greetings from the Institute of Liver and Biliary Sciences, New Delhi. I am grateful to Dr. Pradeep Bhaumik, a friend for years, for having invited me for this LiverCon Agartala 2024. I wish I was able to come in person, but maybe next time I would be able to join you. Today I would like to cover some new concepts and basics on fluid management in cirrhosis with septic shock. I have nothing to disclose. Blood volume is central or non-central. Central blood volume is in heart, lungs, and central arterial tree. And the cardiac output into central circulation time will determine the central blood volume. And non-central blood volume is total minus the central blood volume. Volume expansion in cirrhosis would have several facets. What is the volume distribution in cirrhosis, and how then you expand it? What would be the different fluids, water, saline, buffered solutions, albumin, or pure red cells? In the patients who come with shock, as is the main topic, and patients who have got AKI. So what is your patient? Compared to normal and a cirrhosis patient, how is the blood volume distributed? These are 99 technetium labeled albumin and RBC studies. You see carefully, in comparison to the normal in patients with cirrhosis, the blood volume in the abdomen is much more, and also in splanchnic circulation and in the spleen, it's almost 1.5 to 2 times more. So these are people who are differently dilated compared to normal people. And the circulation time in these patients, now this is your central blood volume and the remaining is non-central. So when you do the central blood volume, you will find out the circulation time in them is much shorter. The cardiac output and systemic vascular resistance, you will see in these patients controls compared to child's A, child's B, and child C. In these patients, you will see that the child's A and B and C patients have a much greater cardiac output. The systemic vascular resistance compared to controls is decreasing, as so more and more vasodilated are these patients. The effect of volume expansion on central blood volume and non-central blood volume. You remember this was the central blood volume. So the central blood volume, after volume expansion, you will see in patients with child's A, B, and C. While in child's A, when you give fluids, the central blood volume in the heart, in the lungs, in these areas it increases, but not in child's C. There is hardly any increase in the central blood volume in these. But most of this goes into the non-central blood volume. We assess the CVP, flow track. These are used normally for measuring, but they could be fallacious and lactate may be increased in cirrhosis. We'll go further into some of the basics in this. Now, in normal person, you will see that the expansion is the pliability in the compliance of these vessels is not as much. You can see very little compliance, the difference between the inner solid line and the outer solid line. But if you will see in child's B and C, the compliance is much more. Means if you will give fluid, there will be more and more acceptability, adaptability. The pressures may not rise. So the compliance in child's B and C is much more, and because of which when you give fluid, they will not be able to raise the pressure. Let's see in child's A and child C what happens to the arterial compliance. As I showed you earlier, the compliance in cirrhosis, this difference between these two is much more, and these vessels are therefore more able to have compliance. In child's A compared to child's C, here you will see the non-central blood volume is markedly increased in child C, 23%, and therefore the central blood volume in these patients Here you have central blood volume of 1.27. It hardly increases by 1%, but the non-central blood volume increases several folds in patients with cirrhosis, especially child C compared to child A. The volume expansion, therefore, compared to normal L in cirrhosis patients, when you will have in a normal person giving fluids, you will see that there is a decrease in arterial blood pressure increases, central blood volume increases, cardiac output increases, systemic vascular resistance increases, heart rate decreases. And the flow in the portal vein also increases. Now in patients with cirrhosis, you give more volume, you will see that the cardiac output does increase. You will have a fluid which is going to interstitial space, and the arterial blood pressure may not increase, central blood volume may or may not increase. The vascular compliance increases in these just by 1 to 1.5, but in cirrhosis 1.5 to 2.5 ml per millimeter kg. The red blood cell fractions in relation to plasma volume in cirrhosis. When you give the packed cells in patients compared to control, let's say the PCV was around 35 and the cardiac output should increase. Now in these childs A, B and C, when you give packed cells, there is a non-significant increase into the packed cell volume, and also there is a low oxygen carrying capacity in these patients. So I have now shown you how is a cirrhotic patient different than a normal person, and how child C differs from child C. Let's summarize. There is an increased plasma volume already, and it is more than the splanchnic circulation. There is an increase in cardiac output, there is low blood pressure, there are decreased packed red cells, more so in child C. There is a hyperdynamic circulation, short circulation time. They are still functionally hypovolemic. High sympathetic nervous system drive, renin-angiotensin system, and vasopressin. These patients, as I'll show you later, are hyporeactive to vasoconstrictors. There is increased vascular compliance and albumin clearance rate. The transcapillary escape rate is much faster, and therefore albumin is cleared and it goes into the interstitial space. Now let's come to a patient of cirrhosis who has got severe sepsis. I told you these patients already have increased heart rate, cardiac output, and venous capacitance, and the contractility in the arteriolar system is low. These patients have low systemic vascular resistance and decreased arterial vasodilation, central hypovolemia. Now, if this patient gets a shock, there is a sudden decrease or loss of blood in these patients, then you first have to have a hemodynamic homeostasis. You need to require organ perfusion, and you have to give an early goal-directed therapy. You might require oxygenation and ventilation. The normal sepsis bundle is of 3 hours. In a patient, normally you would like to raise the CVP, which may not be reliable, so therefore mean arterial pressure and lactate clearance are the main things which we need to work upon. Initial intervention, fluid resuscitation, and hypovolemia correction are the main goals. Let's look at the fluid choices with us. First, let's assess the volume status. We also need to know target map, choice of fluids, and outcomes. How do you assess the volume? Clinically, patient is dry, or you have other features which can look the dehydrated tongue evidence of SARS or sepsis. The mean arterial pressure at bedside in general practice is a very good sign. Central venous pressure, although many people do not accept it as the most reliable indicator in cirrhosis, but it can give you some idea. But a better idea is the IVC diameter. And IVC collapsibility index is a very common, very important indicator. So an IVC which is, let's say, 17, 16 is okay, 18. Remember, a CVP of 10 or 12 in a patient with cirrhosis is probably 14 or 16 in a normal person. Same is true for IVC. So a slightly smaller IVC is better. The IVC diameter, which is maximum, minus the IVC minimum diameter divided by the IVC maximum, and this will give you a percentage which is the collapsibility index. I'll show you some relevance of it. There are expensive methods which are non-invasive, a flow track or a volume view, and respiratory rate variability. Generally, they are placed when patient is intubated. So what are the methods of volume status assessment? Weight, BP, pulse, physical, urine output, chest X-ray, especially if there are B lines or so, blood lactate, central or mixed venous oxygen saturation, urinary biochemistry, sodium excretion, CVP, pulmonary artery measurements, but these are invasive, echo, passive leg raising, which is not so reliable if the patient already has ascites, and stroke volume, pulse pressure, pulmonary artery occlusive pressure, and vena cava diameter. And let's look at the IVC and its correlation with CVP. Now, generally, a person who has an IVC diameter maximum of 1.6 or a IVC minimum is 1, you will see that the CVP is less than 8. But in subjects who have got a very dilated IVC, the CVP is generally high. So you don't have to have an invasive test. A bedside ultrasound will give you the idea. The collapsibility index also, so more collapsible, more fluid you can give. But if the IVC collapsibility index is just about 15 or 20, be sure you don't overload the patient. The overly aggressive attempt to normalize physiology. Let's say a patient has lost a liter or liter and a half of blood. You don't have to pump in the same amount. Maybe give in half of that or 3/4 of that. So don't focus just that you have to replace everything which is lost rapidly. It may be harmful. Many people are in favor of having high MAP, but generally in cirrhosis a MAP above 65 or 70 is good. But what is important in shock is that you are able to maintain it for 3 hours or more, and it should result in some reduction in lactate levels. This is the beginning of our understanding of management of cirrhosis and shock. So this is to show you in the recent study which was published from ILBS, this is the target C study. So the aim was, should we keep the MAP at 60 to 65 or we try and keep the MAP at 80 to 85? And this will show you that there could be hyperperfusion when you have a high target MAP. The advantage or disadvantage of these two are shown in this Kaplan-Meier graph. The low target MAP versus high target MAP, the survival was not different. No difference in mortality at 28 days. The only advantage of high MAP was if you are putting the patient to renal replacement therapy, then you have a lower incidence of intradialytic hypotension. There were less adverse events during dialysis. But if you do not want to put your patient into dialysis, you don't have to keep a high MAP in these patients. So a patient with cirrhosis and septic shock, keep a MAP around 70 or 75 at the most. The fluids, plasma, saline, lactated ringer, plasma light, albumin, 5% or 25%. So compared to plasma, a plasma light is pretty much close. It is a balanced solution and mimics normal physiology and contains acetate. On the other hand, 5% albumin, it expands the blood volume to an amount approximately equal to volume infused. So if you have given 500 ml, it will add 500 ml more and sucking it in. When you give 20 to 25% albumin, it will give you 3 to 4 times more of the volume. So 100 ml might actually add 300 or 400 ml from it sucks inside into the intravascular compartment. And the benefit of this is that it can raise the pressures very fast. The problems are it has a high cost. So now let's look at a study which was done at ILBS, and the first of it is saline versus 5% albumin. And this study is based on the concept that albumin, if you use it as a drug, it can maintain the oncotic pressure based on the Stirling's laws and mean arterial pressure. It is helpful in severe septic shock, and of course it will also help into correction of hyponatremia. So a patient who has got already, as I showed you, cirrhosis, maybe child's B or C, and then this patient has sepsis and has shock. So this worsens. First cirrhosis, then patient has got hypotension due to bleed, and third is the sepsis. So our early goal-directed therapy is in 3 hours how to maintain the MAP and how to get the lactate clear, and of course there has to be homeostasis. So there are 2 types of solutions. One are colloids and one the crystalloids. Now colloids, the one like albumin, they are retained intravascularly, they have antioxidant property, the transcapillary flow is increased, and glycocalyx, you can see glycocalyx, the gray line, it is stabilized inside the vessels and it protects the leakage. The transcapillary escape rate increases in sepsis. The transcapillary, like you have given the albumin here, it will escape out here. So remember, although albumin is useful, but the escape rate can be much higher. So albumin is a good solution. It maintains the integrity of the vessels by managing the glycocalyx. It sucks the water from the neighboring extracellular compartments. Crystalloids, on the other hand, are easily available, low cost, but they also extravasate and can cause hyperchloremic acidosis. So this protocol called Frisk protocol, which is now a standard protocol for us and most part in the guidelines also. So this was done in patients, 396 of them. Finally, these were patients were randomized into 2 groups. One group received normal saline 0.9% and the other got 5% human albumin, 30 ml per kilogram over 15 to 30 minutes, generally not exceeding 1.5 liters, while human albumin was 250 ml bolus, and then after 3 hours the normal saline plasma light was given. At the end of 1 hour, patients who were receiving albumin compared to saline have much better mean arterial pressure, 25%, but at 3 hours only about 11.7% or 3% were able to maintain their pressures. The inotrope requirement in albumin group was lower compared to the saline group. The lactate clearance in albumin was better. There were lower lactate levels than in normal saline. The delta lactate clearance was also better, and therefore there was an advantage of using albumin 5%. The result of this study showed that compared to saline, the albumin had a better survival at the end of 7 days, and the mean survival here was 4.9 days. With albumin, it was 6.2 days. So I would summarize this part that in patient with cirrhosis, with hypotension and septic shock, a fluid of choice in emergency is 5% albumin. It reverses sepsis and the hypotension improves much better than 0.9% saline. But remember, it is still about 12% only. And the secondary advantage was the heart rate decreased, lactate decreased, and short-term survival for 7 days was better, but still too small. So we went on to compare now the balanced solution, that is plasma light, with 20% albumin. We thought it might be better as a fluid of choice. And this study, which was published 2 years ago in JHEP, shows that the reversal at 3 hours of shock was much better, 62%, and compared to plasma light, it's almost like 3 times better. The reversal of hypotension without initiation of vasopressors showed a significant difference in these patients. Further, the lactate levels, the clearance with albumin was much better. The lactate levels went down, mean arterial pressures went up, and the requirement for norepinephrine was lower. But this was at 3 and 6 hours, but not, you can see that not in 24 or 48 hours. So this is to show that the effect lasts for a short time, and then you have to treat the cause of sepsis or of shock. Very important to say that about 20% of the patients, 20% albumin could not be given because they had adverse events, as I will show you. The problem came up with worsening of oxygenation and fluid indices. Now here you can see that mean CVP was much higher, almost like 16 to 18. The IVC levels increased, and the PF ratios, the PaO2 to FiO2 ratios in the lungs worsened over time. Anything which is less than 300 is not good. So albumin worsened the lung situation and oxygenation. What about septic shock and ACLF? In these patients, what type of fluid management can be given and whether albumin is good or not? So I'm going to show you that albumin is dysfunctional and toxic in ACLF patients. Here you will see that like cell death, it causes change into the albumin. There is excessive bilirubin binding and there is a decreased albumin synthesis. The albumin is dysfunctional because of the oxidative stress. This is a modified albumin, and we call the albumin with nitric oxide as nitrosoalbumin, and the oxidized albumin is human non-mercaptan albumin 1 and 2. So all these albumin modifications are very toxic and they keep on circulating. So if you give extra albumin to these patients, it may not be very beneficial. So the best option therefore is to change the albumin rather than add albumin. So my last slide is to show you the choice of fluids and the management of volume expansion in septic shock. The first 180 minutes are important. The Frisk protocol, the fluid resuscitation in septic cirrhosis patients, use 5% albumin, keep a MAP around 70 and a heart rate of less than 100. and a lactate should remain stable or get reduced. We should monitor the fluid carefully but do not cause overload, assess the heart, prevent kidney dysfunction, and avoid 20% albumin in ICU settings. I hope you would be able to use some of these and let me know whether my preferences and choices are correct or not. I'll wait for your questions and maybe comments in the future meetings. Thank you for your kind attention.
So we end up here the pre-lunch session. Though it was an excellent talk, but probably many of us would have been very much happy to exchange with him with such a lecture. Thank you very much for patience hearing.
We thank the speaker and our wonderful chairman. I would like to request organizing chairman of HFT, Dr. Pradeep Bhomik, to please felicitate our chairperson. With this, we adjourn this session. We shall reconvene after lunch at 2:30.
Hello? Hello. Good afternoon, ladies and gentlemen. We will be starting our post-session lunch session within a few minutes.
Good afternoon, everyone, to the post-lunch session of our second day of 7th LIVERCON 2024. Now, after enjoying a delicious meal, we'll start with our interesting session. Emergency in Hepatology. This session will be chaired by Dr. Shopon Sorkar, Dr. Mrinal Debborma, and Dr. Atikul Islam. May I humbly request our respected chairperson to kindly take their chair on the dais. In this session, our speaker is Dr. Ashokananda Konar. Sir will speak on topic role of tips in refractory varices, bleeding in cirrhosis. May I humbly request Sir to join us on the podium.
Good afternoon, ladies and gentlemen. We are in-depth thankful to the organizers of this LIVERCON 7 and 5th International Conference of Padma, Ganga and Gumti Liver Disease Conference. We welcome you all in the 10th session of this conference, Emergencies in Pathology. All of us know that acute GI bleed is a life-threatening abdominal emergency which requires hospitalizations and mortality is quite high. This type of patients having the GI bleed, preferably the variceal bleed, the patient of cirrhosis at diagnosis may have 30% varices, and at 10 years they are likely to have 90% varices. This bleeding is sometimes torrential, and unless it is treated wholeheartedly, the mortality rate rises, may go up to 20%. To address this topic, today we are very much delighted to have our speaker, Dr. Ashokananda Konar, as gastroenterologist of international repute, working as director MRA Hospital, Salt Lake. Regarding the tips, he will discuss the transjugular portosystemic shunt in variceal bleed. I will request Dr. Konar to go ahead with his deliberations.
Thank you. I think I would start with my gratitude to Dr. Bhomik, our old friend. I have been visiting Tripura maybe first time 10, 15 years back and have very good memories of Tripura Hepatic Foundation. Before we even started our Liver Foundation West Bengal, they started working in the community. However, we have chosen a subject which is really one of the most important and emergencies that is faced by gastroenterologists all over the world. And to go to the session of acute variceal bleeding, just I would like to highlight with this, I'll start with this slide, which basically shows a mortality rate data in UK over 40 years. One can see here that the red line is the liver mortality, which is increasing over the last 40 years. Compared to the other common causes like stroke, cerebrovascular accidents, heart attacks, cancer, COPD and everything. So even in a country where the access to healthcare is quite better in the sense that they are advanced nation with National Health Service, the mortality from liver disease is increasing. So mortality from liver disease, we know that is, if we now come to the bleeding in cirrhosis and the variceal bleeding, we know this is an old classification. It's a clinical classification proposed by D'Amico and others. One can see that the first two is usually called decompensated, and the 3, 4 used to be called decompensated, but now there are many other definitions of decompensation. This slide has been shown just to see that the annual mortality, let us say the stage 4 is the variceal bleeding,
is supposed to be 57%, where the HVPG is thought to be about more than 12. So variceal bleeding causes mortality to the tune of 50% in a year, which was present, it's a kind of 10 years old data. So what has happened to this facet we discuss? We know, just for a recapitulation, that what is HVPG? I think most of the people who are not a gastroenterologist, is sometimes difficult to fathom. HVPG is basically a measurement of portal venous pressure. We calculate it from wedge hepatic venous pressure, and free hepatic venous pressure is when hepatic vein catheterization is carried out. And we know that if it is 10 or more, then there are development of varices, and more than 12 causes variceal bleed. Therapeutic target, that's why it's a very old publication by Grossman et al., but still holds true, that if you have a HVPG of less than 12, then there is usually no bleed in the sinusoidal portal hypertension. This is, of course, as Dr. Ognivo was dealing in the morning, that there is a new definitions of decompensation, and we know that the first decompensating event can be a bleed, and it can lead to series of events which can cause death in patients with cirrhosis of liver. But today, the first article that I would like to propose and to tell you about is this, one of these again by D'Amico and others, published in 2003, just to say that they looked at this around 20 years back, what is the mortality, say in the early 2000. And they found that the mortality from variceal bleeding has decreased from 50 to about 20 to 30%. And newer metrics were being used. Like before that, we didn't use these metrics, like what is the 5 days failure rate? That means there is uncontrolled bleeding, rebleeding, or death, and 6 weeks mortality, rebleeding, and 1 year survival. So D'Amico and others, they looked for 6 weeks, and they clearly shown that the proportion of patients on the left that shows that the variceal bleeding compared to the other causes of bleeding like mucosal bleeding is definitely has more chance of rebleeding and more chance of death. However, the first study which looked at the portal pressure during acute variceal bleeding, usually variceal portal pressure measurement is done in a cold setting. That means here these authors actually they investigated the portal hypertension, bleeding, and they looked for HVPG, and they showed that following acute variceal bleeding, they found there are some uneventful evolution and there are some poor evolution. Many patients were out of the poor evolution group, out of 20, 14 patients had rebleeding, and they found that the HVPG around 20 is the cutoff. If you have a HVPG of less than 20, then you probably have uneventful evolution. And they looked at this and they found that if the black box is where the HVPG is more than 20, that means it predicts that your patient may fail to control the acute variceal bleeding, there may be early rebleeding, and 1 year mortality is quite high, and all of them are statistically significant. So this is the first set of data which prompted people to reduce the HVPG, or even in the acute setting. And they also looked at the ROC curve. They have found that the HVPG is a better metric than child's Pew score, and HVPG around 20 is the cutoff. So that gives us an impression that any patient who has HVPG of 20 is liable to have different outcome than who do not have this. The first set of transjugular intrahepatic shunt was published in a New England Journal in 1994. This group of workers, Martin Russell and others, they did about 100 patients. Of these 100 patients, 22 had child spew C, 90 were done as a routine, as a planned, and 10 were done as emergency. But the main thing, you can see here, those who do not understand the tips, that this is a shunt placement between the hepatic veins and the branch of portal vein, thereby reducing the portal pressure and the portal decompensation. So one can see that by inserting a stent between the portal vein and the branch of hepatic vein, this is actually identical to a splenoportal venography, that is side-to-side portacable shunt. So these people have shown that the mortality following, they looked at it for 1.5 years. They could not say whether the TIPS is better than the conventional. They did not compare it, but they found that the death following the survival rate depends on the child's criteria. So, but they gave an idea that it is feasible, and 90% patients were actually those who were stented, they had less bleeding, and 85% had survival after 1 year. Following this, there are a series of articles published around 97, 95. This is from Dr. Rajiv Jalan and others. What they did is they looked at variceal, after doing an initial sclerotherapy, they did a TIPS shunt within 24 hours of controlled bleeding. And what they found is that TIPS has a better way of preventing relief bleeding. That is, after 40 months, one can see the TIPS is much better in preventing rebleeding following variceal bleed. However, they could not show any advantage in the survival. That means they had initially found that the survival is same. Similarly, Dr. Arun Shanal, also from across the Atlantic, they also, the same year, 1997, they compared TIPS with sclerotherapy. What they found, that the sclerotherapy and TIPS are probably same in the prevention of rebleeding over 4 years. But again, he thought, in their study showed, sclerotherapy had a better survival advantage. So TIPS were actually not taken up very enthusiastically, and it was kept for a salvage thing. The next article, this one was published by the Spanish group, 2002. There they found that in advanced cirrhosis, they have selected their patients. Both Dr. Jalan and Dr. Sanyal, they have they have included their patients across the board. That means child A, B, and C. In this study, 91 child spew class B and C patients were divided, randomized to have TIPS for 47, and drugs means sclerotherapy and EVL, plus propranolol and isosorbide mononitrate. And they looked at their data, and they found that TIPS is much better in prevention of rebleeding. However, they have shown that encephalopathy was obviously much worse with TIPS, and mortality, there is no difference. That means at the end, at around 2002, there was, no enthusiasm about doing TIPS unless you have a very refractory bleeding or uncontrolled bleeding that cannot be controlled by conventional methods. Then this study is the first one which looked at the placement of stent and outcome of variceal bleeding according to HVPG. That means this group of workers, they looked at it. If you have a HVPG of less than 20, then you are the highest, the low risk group, that is the top graph, and the high risk group, that is those who have a HVPG of 20. One was with TIPS, and the last one is non-TIPS. Here it shows that overall, the 6 weeks and 1 year mortality was 15% and 31%. But they showed that the survival of patient is much better with high-risk TIPS group. So there was more enthusiasm about cirrhotic patients who are advanced disease, and this was actually a study which was published in 2010 in New England Journal by Dr. Garcia Pagan and others, where the whole thing has been again rekindled. And they found that if you have a pharmacotherapy and band ligation group opposite to TIPS group, it was found that the treatment failure at 5 days, 5 days to 6 weeks, rebleeding, everything was higher in the pharmacotherapy and the variceal ligation group, and death was also more in the pharmacotherapy group. So therefore, this actually showed that these are all statistically significant. Rebleeding happened only in 1 patient with TIPS, whereas 14 patients out of 31 had rebleeding, of which 7 required salvage TIPS stent, of which again 4 died. So composite endpoint, that is measurement of rebleeding and death within 6 weeks and survival for 1 year, it shows the very clear benefits of doing TIPS in patients who have advanced disease. Basically, if you have child C and child B group of patients, where the composite endpoint is statistically significant, 97% versus routine treatment 50%. Death was also much less, and survival curve was better. And they also showed it, the probability of surviving 12 months, 24 months, and also the survival was also there, and there is rebleeding chances much less. So the enthusiasm got better, and of late, and that's why actually prompted me to present this, there was a study by International Variceal Bleeding Study and Baveno Cooperation Study Group, which looked at not only this Garcia Pagan study, but many other studies which they did a meta-analysis, where one can see they have collected around 1369 patients, of which 1,000 patients were allocated to endoscopy and drugs, and about 342. And they match, this is an example on how to do a meta-analysis and the studies. One can see they're matching in such a way there is no p-value difference between the groups, between the drug group and the TIPS group. And one can see that the MELD score at admission was 15. Child C is in both groups about 54 and 56%. And child B with active bleeding, that was also around the same. The results, now when they did the meta-analysis, they found that in all accounts, that failure to control bleed, new or worsening ascites at 1 year, and decompensation and development of hepatic encephalopathy was, of course, is more in TIPS group than the drugs group, but it did not attain statistical significance. But otherwise, mortality at 1 year, that is the last line, it shows that it is 34% versus 18%, so almost double. So this is a forest plot showing that this is all the studies, all the 8 studies. 4 of them was randomized control trial, and the rest is observational studies. They favor the P-TIPS means which a preemptive TIPS, which is done within the 72 hours. So this shows that in selected patients, definitely this offered a survival advantage, an advantage over for decompensation in next 1 year. And this is also for only for child C cirrhosis. So this child C cirrhosis also, if you do the what you call preemptive TIPS, which is done within the 72 hours. So they recommend International Variceal Bleeding Study Group and also the Baveno 7. Baveno 7 is also recommending that one should select patient for preemptive TIPS where you have child C or child B 8 and 9, not 7. So here I just describe one case that were treated under our care. This lady is around 73 now, is under our care for last for 10 to 15 years. And she had actually diabetes along with the MDS, for which the platelet count was always low. Initially, she was being looked after by the hematologist, and then the renowned hematologist said, it's nothing to do with you, you must go and find out a liver doctor. This you may have something to do with your liver. So she came to us. In fact, she had a transjugular liver biopsy, which showed that she had bridging fibrosis, and she had diabetes and all that. So she was diagnosed. She was poor, and then ultimately she developed grade 2 varices. She was started on propranolol. In spite of that, she had a failure of primary prophylaxis. In July 23, first variceal bleed, she had AVL, and then she had 1 or 2 more AVL, and she was put on, changed to carvedilol at that point of time. However, she rebled in October 23 in spite of that. Her hemoglobin on presentation was 6.5. You know, the results are there. It shows actually CTP B8, and MELD score was, MELD sodium was 18. USG showed mild hepatitis, mild ascites. There was no portal vein thrombosis or any SOL. This lady was resuscitated in ITU. She was actually started on as PRBC, and also given, it is not mentioned that terlipressin was started. In about 4 hours' time, she underwent an upper GI scopy after intubation, and it was found that there were partially obliterated varix, but there were clots in esophagus with oozing, and the stomach was full of blood. In fact, the endoscopist thought it's best thing to do a EST with polydocanol. She remained stable. She had fresh melena the following day. She had a check endoscopy. There was not much of a blood, but in view of her history of bleed in spite of drugs and endoscopy, it was decided to undergo a HBPG. We thought if the HBPG is more than 20, then tips may be offered. So HBPG was done on the 3rd day, and the patient's HBPG was actually more than 20, and patient received a PTFE covered stent, which is dilated up to 8 millimeter. We know that is the standard size. If it is more than 8, then there is a more chance of encephalopathy, and portal pressure gradient dropped from 25 to 7 millimeter post tips. And since then, she is doing well, and she is actually compensated, and otherwise not much in the form of medication for her chronic liver disease. So I would like to just focus on this editorial that also published in the same year of hepatology, where they seem to think that where is the place of tips? Obviously, they said if it is bleeding alone, whatever the child pew, first-line therapy has to be EVL and beta blocker. Rescue tips when there is a failure. However, if you have a patient who has child spew B with active bleeding and score is more than 7, or you have a child spew C where the score is less than 14, there is a place for first-line therapy with preemptive tips, which has a very good utility, and there is now survival advantage. For all other group of patients, the standard of care remains variceal ligation followed by beta blockers after 5 days. So I think I would stop here, and because the first deliberation was not there today, I would like to have any questions on variceal bleeding and the current management. Thank you.
Thank you, sir. For the new light of tips, in the classical teaching, we usually teach the students that indication of tips is refractory ascites or liver transplantation where the patient is unfit for the surgery interventions or the organ is not available. So you have treated a very senior citizen of West Bengal, 73 years old female with diabetes mellitus and having this portal venous pressure more than 20, that you have done the rescue tips. And also you have told us that there may be also the primary tips when it is indicated. So we have learned two indications. One is rescue tips, another is the primary first-line treatment of this acute variceal bleeding. So now the house is open for any questions, any query.
Normally, you see patients here with esophageal variceal bleed. Usually, they are taken care of by, obviously, by endoscopy. That is done commonly in Tripura, also in Agartala and other cities. That is available. But if they don't respond, say a 5-day failure rate, two things I think I would like to highlight even after finishing that. This 5-year failure rate is still around 15%. That is the standard data from all over the world. And so we'd like to reach that data in our countries, in all states, 15 to 20%. That means 1 in 5 will die. That probably cannot be prevented. And 1-year mortality. 1-year mortality is still around 30%. Even after all this, they said the 1-year mortality is around 30%, which may not be due to the bleed, but due to further decompensation. As Ognivo was telling in the morning, that first decompensation and further decompensation. TIPS actually addresses both. It addresses the bleeding risk in the first 6 weeks, and it also addresses the risk of having decompensation around 1 year, when other factors like encephalopathy, large ascites, as you told, that patient may decompensate and go into large ascites and refractory ascites and things like that. So those are taken care of, but still the mortality is around 30%. So if we move from those D-Amico's data of 2006, where they used to say the bleeding after 1 year is around 50% or more, I think this kind of therapy might give you a chance to improve on those statistics. The problem with TIPS is, number one, is the person who is doing it. You have to have a person who can deliver TIPS in the emergency situation, and second is the cost, because this is quite costly treatment, but it can be life-saving.
Sir, what about the stent thrombosis in the case of variceal bleed?
Actually, these are stent thrombosis. Stent dysfunction was common when those, when these covered stents were not used. But nowadays it is not so common. PTFE covered stents usually do not thrombose, but what may happen that it may not be very functional. That means the portal pressure gradient, if the patient has more bleed. So let us say if you the post-tips, if you have a bleed, then you have to recheck the portal pressure. Then you have to again dilate it further with a more risk of having, encephalopathy. Stent thrombosis is unusual, but the stent flow may be low.
Thank you, sir.
Sir, for now in Tripura, right now we don't have the option for TIPS. So I think the good thing that you have mentioned, the recently used term that we call preemptive TIPS, this is what we should be aware of. As a gastroenterologist or as we practice endoscopy, we go for bending, and we should be aware to diagnose and know which patient we should refer to centers where TIPS is available. So that is the importance where sir was speaking about preemptive TIPS. So I think once we do the endoscopy and with the CTP score, MEL score, as we have seen in the chart, I think it was a good thing that sir has brought up the recently used preemptive TIPS. So I think as endoscopists, when we do, we should be able to diagnose which one we should be able to refer to the center with expertise thing. So I think that is a good option. Nice talk, sir.
Thank you.
Any other questions?
Okay.
I think then we can conclude the session. Thank you so much, sir. Thank you for this wonderful delivery, sir. Thank you.
Thank you, sir, for your wonderful session. We'd like to take this opportunity to felicitate our speaker with our token of appreciation. May I humbly request our respected chairperson to felicitate our speaker. May I have a big round of applause for our speaker. May I humbly request our Dr. Ajit Chaudhary to kindly come up to the stage and felicitate our respected chairperson. May I have a big round of applause for our chairpersons. Thank you, sir. Now we'll start with our next session, that is the state of art session. This session will be chaired by Dr. Gautam Debbarma, Dr. Anirban Bhomik, and Dr. Devashish Pal. May I humbly request our respected chairperson to kindly take their chair on the podium. This session, our first speaker is Dr. Jatin Agarwala. He will speak on his topic, hepatic encephalopathy, current management. Thank you.
Good afternoon. So next topic is hepatic encephalopathy current management, and speaker is Dr. Jatin Agarwala. So sir will be presenting now on hepatic encephalopathy current management.
Good afternoon, everyone. Today we are going to, I'm going to discuss about hepatic encephalopathy. So before going to management, my talk, I would like to tell the outline. So we'll be discussing briefly about the axis of the classification and what is the role of impact of covert HE and what the clinicians need to know, role of ammonia and neuroimaging, and then we go to the management of overt HE. In addition, we'll also discuss about the HE prophylaxis and what are the emerging therapies. So what is hepatic encephalopathy? So brain dysfunction is not the term that is supposed to be used, and any patient who's having altered sensorium in patients with cirrhosis should be termed as acute encephalopathy. Hepatic encephalopathy could be labeled only if it is a causative and not an associated feature. So it is liver insufficiency and or portosystemic shunting which manifests as a wide spectrum of neuropsychiatric manifestations. One of the most common complications of cirrhosis that leads to recurrent hospitalization and increases the cost. So incidence of HE is almost 11 per 100 years, and prevalence of HE varies from 10 to 14% in patients with cirrhosis and 16 to 20% in decompensated cirrhosis. Prevalence of minimal HE is variable, but it is also seen to the tune of up to 80% in some of the studies. So it's very important that we classify hepatic encephalopathy. It is very important from treatment and prognosis point of view. So what are the classifications? First, it is based on the underlying etiology. Next, on the basis of severity. And third will be based on the triggering factors. So this is a very important table, and type A encephalopathy means that it is secondary to acute liver failure, and it has a completely different pathophysiology and management. It is associated with increased intracranial tension and cerebral herniation. Type B is because of a portosystemic shunt in the absence of cirrhosis. Type C would be cirrhosis with or without a portosystemic shunt, that is manifesting as hepatic encephalopathy. When we come to the severity of hepatic encephalopathy, we have majorly four grades, grade 1 to 4, and in addition there is minimal HE. So what is the difference between minimal HE and grade 1 hepatic encephalopathy? Minimal HE, the patient does not have any sort of psychiatric or neuropsychiatric manifestations, but he fails to perform adequately when we administer the tests. And both minimal HE and grade 1 HE are considered as covert, and from grade 2, the HE is considered as overt HE. So what is recurrent HE? The definition is that if the hepatic encephalopathy episodes occur more than 2 times within the span of 6 months, then it is called as recurrent. If the patient remains normal in the intervening period, it is called as recurrent. However, if the patient does not return to the baseline performance, it is considered as persistent. Very important is to identify the triggering factor. That is the most important factor once we see the patient. So we have to try to identify what has triggered the hepatic encephalopathy, and the most common precipitating factors are infections, GI bleeding, diuretic overdoses, dehydration, dyselectrolytemia like hyponatremia, constipation, and despite ruling out all the causes, sometimes it can be unidentified. So how do we grade HE? So we discussed about the covert and overt HE. Clinically, if the patient has absolutely no symptoms, we have to screen the patients for minimal HE with psychosomatic tests. And if the tests are abnormal, then the patient is considered as minimal hepatic encephalopathy. And if the patient has subtle abnormalities, for example, a lack of awareness, impairment of addition or subtraction, altered sleep rhythm, then we call it as grade 1 hepatic encephalopathy. If the patient is disoriented to time, then he comes into the category of grade 2 hepatic encephalopathy, and now the patient starts to have asterixis. If the patient is also disoriented to place in addition to time, and he's responsive to stimulus, then it is called grade 3. If he is unresponsive even to deep stimulus, it is called as grade 4. So this is the difference between recurrent and persistent. The patient returns to the normal in the intervening period between the 2 episodes in episodic. In case of persistent, he remains to be abnormal. So what is the implication of covert HE? Is it really significant? It has been shown that the covert HE is responsible for a lot of falls, driving impairment, cognitive impairment, and also higher mortality, in addition to cognitive decline, decreased quality of life, and reduced work productivity. And a recent study from PGI, multi-center study done recently, showed the prevalence of minimal HE to the tune of 60% when tested by PHES. And the prevalence in alcohol-related cirrhosis was almost 40%. However, only a quarter of patients with minimal HE were already on prophylaxis. So this is the study that is shown that almost 35% of patients had MHE, and it was associated with increased risk of falls. So it is very important to identify MHE and counsel the patients to be careful, especially regarding the driving. So this study shows that the patient's car handling adaptation and maneuvering is significantly lower who have minimal HE compared to those without. And if the patient has covert HE, obviously the patient is going to develop overt HE in the matter of time. And there are certain predictors, albumin less than 3 and creatinine more than 1.3 are predictors of development of overt hepatic encephalopathy in the future. So covert HE is also associated with higher incidence of ascites and portal vein thrombosis, and covert HE can also reduce the survival rate. There are a lot of psychometric tests that are available which we can use to screen. However, animal naming test is one of the simplest tests. In addition, psychometric hepatic encephalopathy score, FES score, is the gold standard. So in animal naming test, we ask the patient to name as many number of animals as possible in less than 60 seconds, and we depending on the number of animals, we grade as label the patient as having minimal covert HE or not. And this test is shown to be well established, and it correlates with PHES and electroencephalogram. FES score is the gold standard for confirmation, and it predicts the development of overt HE and mortality. It consists of a numerous paper pencil tests like number connection test and figure connection test, digital symbol test, and line tracing test, and serial dotting. It may be cumbersome in clinics, but at least the animal number test is very simple and it can be done. What is the impact? So this is the guideline that is shown that we are supposed to screen the patients with cirrhosis even without any symptoms with psychometric test, and if any of the scores are abnormal, we have to initiate them on lactulose. This is the systematic review and network meta-analysis showing the treatment options, and rifaximin and lactulose were most effective in reversal of minimal HE. However, even lactulose as a single agent was also effective in reversing minimal HE and preventing overt HE, improving the quality of life. So what does EASL say? Screen all the patients without history of overt hepatic encephalopathy with animal naming test or other scores depending upon the local expertise. In patients with covert HE, anti-HE treatment with non-absorbable disaccharide should be initiated to prevent overt HE. So what is the role of ammonia? So ammonia has got a very good negative predictive value. In a patient who has altered sensorium, if the ammonia value is normal, then the diagnosis of hepatic encephalopathy is in question. However, the levels can remain positive even after the hepatic encephalopathy resolves, and it can also be elevated in many other conditions. Recent study from AIMS has shown that plasma ammonia has good correlation with severity of hepatic encephalopathy and was an independent predictor of 28-day mortality. It was associated with higher frequency of organ failures and predicted 28-day mortality. Lack of improvement of baseline ammonia at day 5 was associated with higher mortality in patients with ACLF. So in patients with delirium, plasma ammonia should be measured at the baseline, and a normal value we have to think about other causes of encephalopathy. Coming to the management, any patient with poor sensorium, we have to follow the ABCs of resuscitation and protect the airway in case the GCS is less than 8 and admit the patient to ICU. And get a neuroimaging can be done to rule out other causes, especially if the patient has any focal neurological deficits or a history of fall, headache, or seizures. And we have to identify the precipitating factors as I've mentioned previously, and we have to initiate treatment to address those. Nutrition is an important aspect which should not be neglected. And any patient who's suspected to have vitamin or micronutrient deficiencies should be treated, and patients with end-stage disease and recurrent or persistent HE should be given an option of liver transplantation and has to be referred to a center where the transplant facility is available. Previously, protein restriction was advised, but however, many studies have proven that there is no need for restricting the protein, and almost 1.2 to 1.5 grams of protein is recommended per day in patients with hepatic encephalopathy. And because of recent studies, even a late evening snack is also recommended. So the first line of therapy that we start for hepatic encephalopathy is lactulose, non-absorbable disaccharides. These are the first line of treatment for hepatic encephalopathy. The mechanism of action is primarily laxative effect. It works by decreasing the intestinal transit time and increasing the acidification of the biliary bowel milieu. It decreases the ammonia production and absorption in the gut with increased fecal extraction. So what is the role of lactitol? Lactitol has been shown to be either equally efficacious or if not, in one of the study it was superior to lactulose, and it increases the palatability of the patient. So it has similar efficacy, and it can be used in place of lactulose. Starting dose is 15 to 20 ml every 12 hourly, but it has to be titrated by the patient relative or the ICU nursing staff to target and reach 2 to 3 soft stools in a day. So EASL guidelines recommend lactulose as the first line agent in covert HE and overt HE, and also in secondary prophylaxis following the first episode of overt HE. The HELP study has shown that giving a patient with treating the patient with polyethylene glycol, 4 liters of polyethylene glycol solution on day 1 significantly reduces the hospitalization duration and time to recovery. Rifaximin is a semisynthetic non-aminoglycoside, and it is mostly restricted to the bowel, and it is minimally absorbed, and that hence low risk of bacterial resistance. It is possibly beneficial effects on the functionality with negligible impact on microbial production. So multiple studies have shown that rifaximin is equally efficacious to lactulose or lactitol, or if not, sometimes superior. So this is the randomized control trial where they compared combination of rifaximin and lactulose versus lactulose alone. And they have shown that a combination of rifaximin and lactulose has had higher rate of reversal of HE and reduced mortality, and also reduced hospital stay. Hence, rifaximin and lactulose as a combination is recommended. So this is also the randomized control trial showing the superiority of combination therapy. So what is the role of L-ornithine L-aspartate? It's a mixture of 2 amino acid. It activates glutamine synthetase, thus augmenting the glutamine production in skeletal muscles, and it can also increase urea production by activating the rate limiting enzyme of urea cycle. It reduces blood ammonia concentrations and severity of HE. However, the effect of mortality is unclear. So this is a Indian study that is published in Hepatology that showed that intravenous infusion of LOLA versus placebo, and it has shown that it significantly improved the grade of overt HE over days 1 to 4, but not on day 5. However, there was no impact on interleukins or mortality. This is a more recent study from the GB Pant group, and they've involved 140 patients, and they've shown that significant improvement of hepatic encephalopathy and lower time to recovery and lower 28-day mortality, and significantly higher reductions in ammonia and interleukins in the LOLA group. However, the guidelines are yet to be updated, and EASL or ASLD guidelines do not recommend. Even the EASL 2022 do not mention the use of L-ornithine L-aspartate, but however, in clinical practice, we are using in patients who are not responding, and we have ruled out all other causes of encephalopathy. Branch chain amino acids have been studied a lot, and this is a Cochrane systematic review which showed that it had some beneficial effect on overt HE. However, additional RCTs were required to evaluate the outcomes and to have head-to-head trials between branch chain amino acids and the standard of care, which is rifaximin and lactulose. So this study from PGI shows that intravenous infusion of branch chain amino acid does not lead to sustained recovery from overt HE in patients with acute and chronic liver failure, and there was only median change in HESA score at 24 hours was greater in VCI arm, but which was not sustained subsequently on day 3 or day 7. Most importantly, no significant difference in the survival, 28-day survival. Hence, branch chain amino acids are not recommended currently. What is the role of albumin in treating hepatic encephalopathy? Albumin as an antioxidant has a scavenger action, and it also corrects the circulatory dysfunction which can contribute to hepatic encephalopathy. So recently multiple studies have shown that intravenous albumin in patients with cirrhosis and overt HE can reduce the severity of HE and faster recovery with also survival benefit. This is the Indian study that has been published, shows that albumin in combination with IV albumin in combination with lactulose is superior to lactulose alone, and it is also significantly reducing the bacterial translocation. This is the HEAL study from Jasmohan Bajaj group, which showed that minimal HE reversal is also possible by giving IV albumin, and increase in the quality of life, psychosocial quality of life, decrease in the endothelial dysfunction and inflammation. So EASL guidelines recommend that in patients with overt hepatic encephalopathy, albumin dialysis ameliorates HE and can be considered. However, the effect on mortality is still uncertain. So in patients who have persistent HE or recurrent HE, we have to actively look for shunts that can be responsible for recurrent HE, and especially the ones which have more than 8 millimeters on CT photography should be subjected to shunt closure, provided the patient has a good MELD score which is less than 11. Recently, PGI group have also shown that the shunt obliteration can be done through endoscopic ultrasound guidance for patients with recurrent hepatic encephalopathy. This was only in a small group of patients, but it's a giant leap because we can do all in one stop with endoscopic endotherapy. To summarize, if the hepatic encephalopathy is confirmed, if the patient has grade 3 or 4, we have to calculate the GCS and admit to ICU, and try to identify and treat the precipitating factor, and specific treatment would be rifaximin and lactulose, and large portosystemic shunt, if identified on CT, have to be subjected to closure if the MELD score is less than 11, and the role of branch chain amino acids is still questionable. However, the role of IV LOLA seems to be encouraging, and albumin seems to reduce the severity of hepatic encephalopathy. PEG also can be used on day 1, and that can lead to lower duration of stay. What about prophylaxis? Any patient who has an episode of overt HE has a 40% risk of recurrence in 1 year, and that is the reason why any patient with single episode, we are supposed to give them secondary prophylaxis, and multiple RCTs have established the same, and this has become standard of care now. Rifaximin, lactulose is something that we give as a first line therapy in the prophylaxis, second line prophylaxis. However, in patients who continue to have additional episode even on lactulose therapy, should be started on rifaximin as an adjunct therapy. So what are the EASL guidelines on hepatic encephalopathy? Lactulose is recommended as a secondary prophylaxis, first line agent of choice, and after the first episode of overt HE. Rifaximin can be added as an adjunct to lactulose as secondary prophylaxis following 1 or more episodes of overt HE within 6 months of the first episode. In patients with history of overt HE and in whom liver function is fairly preserved and nutritional status is good, we can consider discontinuing anti-HE therapy on an individual basis. And portosystemic shunt obliteration is very important in patients with recurrent or persistent HE. Patients with these subgroup of patients should be considered for liver transplantation, and a first episode of HE should prompt referral to a center with a transplant facility. Fecal microbiota transplantation in patients with recurrent and persistent hepatic encephalopathy. A small group of patients were randomized, 10 in each group, and it has shown that it has significantly reduced hospitalization, improved cognition, and better gut dysbiosis. To summarize, hepatic encephalopathy is a diagnosis of exclusion and represents a spectrum of neuropsychiatric abnormalities. Covert HE is associated with falls, driving difficulties, poor quality of life, and independently associated with breakthrough overt HE and mortality and decompensation. It has to be identified, it has to be screened bedside for all patients with cirrhosis, and ammonia is central to the pathogenesis and has a high negative predictive value, and hepatic encephalopathy, when it is multiple and recurrent, can lead to poor neurological outcomes even after liver transplantation, and portosystemic shunt has to be identified and closed. Precipitating factor has to be actively sought for and has to be treated. Mainstay of treatment is lactulose and rifaximin, and nutrition is very important. Thank you.
Thank you, Dr. Jatin, for such a elaborate yet lucid presentation of hepatic encephalopathy is made very easily understandable. I think since we are a little bit short of time, you can please take a seat along with us, and we'll open the session for questions later on.
Okay.
Thank you, sir, for your wonderful session. We'll take this opportunity to felicitate you. May I humbly request our respected chairperson to felicitate our speaker with our token of love and honor. May I have a big round of applause for our speaker. Thank you, sir. Our next speaker is Dr. Shondeep Pal. He will speak on his topic, alcoholic liver disease, spectrum and management options. Thank you.
Good afternoon, everyone. So first of all, I would like to thank the organizing committee and Dr. Pradeep Bhomik for this invitation and opportunity. So my topic is, I will discuss a little bit about the alcoholic liver disease, the spectrum and the various management options. So to start with, see the name itself, alcoholic liver disease, is stigmatizing. So we don't want to use a term like alcoholic liver disease. So there is a little bit change in the nomenclature. So these terms are preferable now, like alcohol-related liver disease or alcohol-associated liver disease. Just like NAFLD, now you don't have the term NAFLD because we don't want to associate the term alcohol with the disease. So these are the new terms which has been proposed, like for alcoholic, we don't say alcoholic, we say alcohol use disorder, or alcoholic liver disease, we can say alcohol-related liver disease. These are from EASL guidelines. Now, what is harmful alcohol and how do you want to define alcohol, definitions of drink and drinking? So one standard drink is usually 10 grams of alcohol, and likewise there is definition of harmful drinking where alcohol use is causing damage to either physical or mental health. Who is a heavy drinker? Like heavy episodic drinking is defined as consumption of more than 60 grams of pure alcohol on one occasion. And what constitutes binge drinking is consumption within about 2 hours of 4 or more drinks for women and 5 or more drinks for men. So these terms are important, though we use the terms very loosely, but these are the definitions. So this is earlier, there was DSM-4 criteria, now we use the DSM-5 criteria. So there are 10, 11 points by which we classify this disorder, alcoholic use disorder. So the severity of alcoholic use disorder can be graded as mild, moderate, and severe according to the presence of this criteria. I'm not going to the details of this. Now, 35% of patients with alcohol use disorder develop alcohol-related liver disease. So this is a group which is a relatively large group. 35% of patients with this develop liver disease. Now, there are various ways to identify patients with harmful alcohol intake. So one of them is audit, questionnaire. So there are a series of questions, around 10 questions, of which the first 3 questions deals with consumption, then the dependent symptoms and the alcohol-associated problems. And if the score is more than 8, it's harmful. And if the score is more than 20, then it is alcohol dependence. This is another way to quantify harmful alcohol intake. So we have all heard about the CAGE questionnaire. So rather than CAGE questionnaire, this is another better screening test or screening criteria, you can say Audit C. So this Audit C is more efficient to screen for problem alcohol use, and it has been said to be better than CAGE to identify alcohol misuse. So one standard drink is 10 grams of alcohol as per WHO standard, whereas some guidelines say that one standard drink also constitutes 12 to 14 grams of alcohol. Why this is important? Because we need to know like what is the amount of alcohol the patient is consuming that can cause liver disease. So coming to alcohol metabolism, now we all know ethanol is metabolized by alcohol dehydrogenase into acetaldehyde, and when ADH pathway is overwhelmed, when more alcohol intake is there, this path is bypassed and then ethanol is metabolized by the cytochrome pathway and it produces acetaldehyde. When alcohol is metabolized by the CYP pathway, there is generation of reactive oxygen species and free radicals, which leads to hepatocyte injury. So on intake of alcohol, there is oxidative stress and there is endoplasmic reticulum stress. This causes injury to the hepatocytes, and when the hepatocytes are injured, there are various productions of DAMs, like which are damage-associated molecular proteins, and these DAMs, they attack the Kupffer cells, they attack the TLR4 receptors in Kupffer cells, and the Kupffer cells in turn produce the various inflammatory cytokines. Now what are the inflammatory cytokines? There's a TNF-alpha, interleukin-1, beta, and interleukin-6. And these recruit the various immune cells. And also alcohol damages the intestine, there is leaky gut, and there is release of lipopolysaccharides, which are called PAMs, and all this stimulates the Kupffer cells in return and produce the inflammatory cytokines. Now this alcohol can cause injury by direct injury as well as through immunological mechanism. And these inflammatory cytokines like TNF-alpha, interleukin-1 and interleukin-6, they cause an auto-amplification of inflammatory response, and there is an ongoing injury to the hepatocytes. So this is the pathogenesis of alcohol-associated liver disease. Now the pattern of use of alcohol in alcohol-related cirrhosis in Indian patients, this is a study by Mithun from AIG. So in this study, he has said that of 950 patients with heavy drinking for 2 years, 38% had cirrhosis. Whiskey was the most commonest drink consumed, and median alcohol drinks per week similar to those in with and without cirrhosis, and more patients with cirrhosis took indigenous alcohol because we don't know the amount of alcohol that is present in indigenous ones. So these are the various indigenous and these are the various local terminology that is used like peg, Patiala peg, large peg, adha, khamba. So how much amount of drink is there? This is very easy to know because most of our patients, they come and they say we used to take adha per day. So we don't know what is adha, it's 375 ml. So thereafter you can calculate the amount of alcohol by knowing this percentage. Like a pint of beer will have 3 to 10% of alcohol. Like let me take this Bangla drink in West Bengal. It has around 38% of alcohol. So these are good to know, just to calculate and tell the patient the prognosis. Now coming to the spectrum of alcoholic liver disease. Now if you go through this, first day itself, if the patient drinks, they don't develop cirrhosis. So initially there is a normal liver, and if the patient continues to drink, of course initially there is steatosis. This steatosis, if still the patient continues to drink, in 20 to 40% of cases they will develop alcoholic steatohepatitis, which is also called alcoholic hepatitis, or fibrosis might develop. Of this alcoholic steatohepatitis, around 8 to 20% will develop cirrhosis, and the cirrhosis, around 3 to 10% of the cirrhotic patients might develop hepatocellular carcinoma, around 20% may decompensate. So these are the various spectrum of alcoholic liver disease. There can be fatty liver, there can be ASH, there can be cirrhosis, HCC. So these are the various spectrum, and of course the decompensated. So what do we find in steatosis? In steatosis, usually LFT is normal, only ultrasound will show a fatty liver. Whereas if there is alcoholic hepatitis, there is a definition of alcoholic hepatitis, like the bilirubin has to be increased, INR is increased, there can be features of SIRS, and AST-AL2 ratio will be more than 1.5. This was earlier 2. And if the patient develops a cirrhosis, then there will be, of course, again, rearranged LFT, albumin will be low, AG reversal will be there, INR will be high, CLD will tell us about, in ultrasonography, CLD features will be there, and in endoscopy, of course, varices will be there. And of course, in HCC, there will be increased alpha fetoprotein, and there can be focal liver lesions on MRI or CT. So what is the treatment? So in steatosis, no need, there is no specific treatment that the patient has to abstain. Abstinence is of prime importance. If there is cirrhosis, we treat it like any other cirrhosis of any other etiology. Alcoholic hepatitis management we'll discuss. And if there is HCC also, that we won't discuss, but that is the standard treatment for HCC of any cause. Now, diagnostic test, like, do you need to do some tests to diagnose alcoholic liver disease? Of course, history is the main. Sometimes in female patients, very difficult to document, because if they don't tell us the history of alcohol, it's difficult. Like once we had a patient who didn't tell us the history of alcohol intake, and she had cirrhosis. We ended up doing biopsy in her, that also TJLV, because the patient had ascites and ultimately came out alcoholic hepatitis. So that biopsy would have been avoided if we had got the history. Then when we asked retrospectively, she said she used to accompany her husband always. So, and she developed CLD. So that history is very important to diagnose cirrhosis of liver. So the documentation of regular alcohol consumption, more than 20 grams in females and more than 30 grams in males. And of course, the presence of clinical and biological abnormalities suggestive of liver injury. So these are the various tests you can do: LFT, fibroscan, ultrasonography. Of course, we need to rule out other causes still, because there can be 2 or 3 causes. The patient's serology needs to be checked, or whether there is some other cause like autoimmune disease or copper-related. All these tests should be done if clinically relevant. If it is very clinically relevant that the patient has only alcohol, we need not do other tests also. So these are the various non-invasive tests that are available to us. These are all as per ESL guidelines, but this we do more in case of non-alcoholic fatty liver disease. In alcoholic fatty liver disease, this can be done, but clinically we generally don't do this. So we all know about fibroscan. It's very widely available. All patients get a fibroscan done nowadays. So fibroscan, if liver stiffness, we can measure the liver stiffness, like if it is more than 7, less than 6 is normal, 6 to 8 gray zone, F2 to F3 fibrosis if it is more than 8, and F4 fibrosis if it is more than 12, we can say. And do you need a liver biopsy? Like already we said, like, do you need to do a liver biopsy to diagnose alcoholic liver disease? No, we usually don't require liver biopsy to diagnose alcoholic liver disease, but sometimes if the history is not clear or there are confounding factors, there are other, suppose ANA comes positive in that patient, and if there is a possibility of other causes, then we sometimes do liver biopsy. And if we do liver biopsy, then there are certain features which are very pathognomonic of alcoholic steatohepatitis, like neutrophilic infiltration, and then of course various degrees of macrovascular steatosis, lobular inflammation, ballooning, then Mallory Dank bodies. These things are there which can tell us about a diagnosis of alcoholic hepatitis. So this is the definition given by the National Institute of Alcohol Abuse and Alcoholism. Like alcoholic hepatitis definition is the onset of jaundice in the previous 8 weeks with 6 months of alcohol intake, more than 40 in women and 50 in male gram per day. And the bilirubin should be more than 3 with the AST of more than 50 but less than 400, and AST-ALT ratio of more than 1.5, and of course we need to rule out other causes of liver injury. Now little bit about alcohol-related ACLF. Are these the same, alcoholic hepatitis and alcohol-related ACLF? No, these are not same, these are different entities, but sometimes it is very difficult to differentiate between the two, but we can differentiate. Like the definition of alcoholic hepatitis we have already known. Now, if you see the ACLF definition, there are 2 definitions. One is by the APASL group, another by the EASL. So we generally follow the APASL group, which says that the acute onset of jaundice with a bilirubin more than 5 and INR more than 1.5, along with ascites with or without hepatic encephalopathy in 4 weeks, with prior diagnosed or undiagnosed cirrhosis, which has got a high 28-day mortality. This is the definition given by APASL. So this can help us in differentiating from alcoholic hepatitis, but sometimes it becomes very difficult because alcoholic hepatitis also patients might have these features. They might have INR more than 1.5. So a easy way to distinguish between this is get a CT scan done. So if in alcoholic hepatitis, a CT abdomen, if the liver is enlarged, large liver, usually this is alcoholic hepatitis. The liver is large and mild ascites might be there, but usually there are no signs, much signs of portal hypertension, but you get a very big liver. In ACLF, the liver is shrunken, nodular, and all features of portal hypertension you get. This is one simple test. You can do a NCCT abdomen also if we cannot do a contrast CT. But this is one important way to diagnose, differentiate between the two. Now ACLF, we all know this. These are various grades of ACLF. ACLF grade 1, grade 2, grade 3. The mortality depends on the grade. And how do you differentiate? It depends on the number of organ failure. If it is more than 3 organ failure, it's ACLF grade 3. And we need to know this. This is important because if it's ACLF grade 3 with 3 organ failure, the mortality is very high. The mortality is up to 80%. 90-day mortality is up to 80%. So this is the Inaugural consortium of around 1,000 patients. We said that the mortality depends on the number of organ failure. With 5 organ failure, our own Indian data says that with 5 organ failure, the mortality rate is around more than 80%. Now when we discuss about the management of alcoholic liver disease or alcoholic hepatitis, we need to know how to evaluate the severity. So there are various parameters to evaluate the severity, of which one, all of us that we do clinically, that is a MADRS discriminant function. Then of course there is a MELD score, Glasgow hepatitis score, and Glasgow alcohol hepatitis score, and ABIC score, and the Lilly score. Of these, the most 3 important that we use clinically in our day-to-day practice is MADRS, MELD, and Lilly score. Now, MADRS score, we use bilirubin and INR. It is a very easy test to do. Bedside, you can do in seconds. You can do it. There is the that uses bilirubin and INR. MELD, of course, we know MELD score. Then Glasgow, this we don't use very frequently. ABIC score also we don't use frequently. And Lilly score is important when we start the patient on steroids. I will come to that. So stepwise discriminant analysis of prognostic factors with baseline prothrombin and serum bilirubin. This is a very good test, and MELD accurately predicts mortality in alcoholic hepatitis, and MELD score is a better prognostic model than child or DF scores in alcoholic hepatitis. You can categorize alcoholic hepatitis also. This is also important because if the alcoholic hepatitis is very severe, like if the DF score is more than 60, usually the prognosis is poor, and these patients, they don't do well with steroids also. These patients need to go for transplant. So this is another classification of alcoholic hepatitis. So definite alcoholic hepatitis, we can say if it is clinically diagnosed and biopsy proven, probable clinically diagnosed without confounding factors, and if there are confounding factors, you need to take help of biopsy. Now coming to the management proper, first we can manage the alcoholism to abstinence, because abstinence is the main treatment. And these are the various drugs like naltrexone, nalmefene, disulfiram. Unfortunately, I don't have the experience of using these drugs. We send our patients to psychiatrists. What we generally use is baclofen. Baclofen, all alcoholic patients we prescribe, so that because studies have shown that baclofen reduces the desire or the urge to take alcohol. So the general principles of management of alcoholic hepatitis remains the same. Again, alcohol abstinence. Then, of course, these patients, everyone should be in thiamine because of the risk of Wernicke's encephalopathy. Then if the patient is on encephalopathy, we have to treat encephalopathy. We just heard Jatin's lecture on hepatic encephalopathy. Then treatment of ascites, all we know, and treatment of renal failure. This I am not going in details, but these are the general measures of in treatment of any liver disease. Now, nutrition, this is one of the most important aspect of treating alcoholic hepatitis, because studies have shown that malnutrition is one of bad prognostic factors. So nutrition we have to maintain, and the EASL guideline says that the energy intake should be more than 35 to 40 kilocalories per kg body weight with 1.2 to 1.5 gram per kg of protein. Now there was a concept that you have to restrict protein in liver disease. Those are very old. Please don't restrict protein in liver disease. the protein should be high after the tune of 1.2 to 1.5 gram per kg of body weight. So intensive enteral nutrition is ineffective for severe alcoholic hepatitis treated with corticosteroids. But when there was a study which compared nutrition with steroids, there it was shown that enteral feeding does not seem to be worse than steroids, although death occurs earlier with enteral nutrition. So there was almost comparative efficacy, though there was mortality benefit with steroids as reported in this study. So of course, infection is an important aspect. All these patients are usually, they have some infection. Up to the 90% of these patients can have bacterial infections, some invasive aspergillosis, and all these infections can be there. So this patient should be screened for infection before initiating steroids. Now coming to steroids, now I have seen like physicians treating all jaundice with steroids, even if the patient is not responding to the usual management, steroids are being given, but there is not very much literature to support that. Even in alcoholic liver disease, if you see the results varies very widely. If you see these are all meta-analysis, and 5 meta-analysis showed, 2 meta-analysis showed no benefit of giving steroids, whereas another 3 meta-analysis showed there was some survival advantage. So this is the meta-analysis by Mathurin et al. They showed that patients treated in corticosteroid group had a survival benefit when compared with the patients treated in the non-corticosteroid group. So we can give steroids to this group of patients, to a select group of patients who don't have sepsis. So but those patients who develop who generally respond to steroids are in the range of MELD of 25 to 39. So these patients who have MELD score in the range of 25 to 39, they usually respond to steroids. And survival benefit, but there is no survival benefit after 90 days or 180 days. So there is short-term benefit, you can say. So what is important is the early change in the bilirubin level. So we start steroids in this group of patients, say 40 milligram per day, and you repeat the bilirubin at 7 days. If you see the bilirubin is improving, then this patient is going to improve. If the bilirubin is not improving, then you can stop steroids. This is what the Lilly score says. And this was the study by Mathurin P. et al. Published in Hepatology. So glucocorticoids to treat severe alcoholic hepatitis have transient beneficial effect, better 1 month survival, but increased risk of infections, but there is no change in survival at 60 to 190 days. So this is the Lilly model, already you have described this. If the Lilly score is less than 0.45, then these patients will respond to steroids and you can continue steroids. So the Lilly score is a composite score. We cannot calculate it. It's available in Google. Whenever you start any patient of alcoholic hepatitis on steroids, you can do this scoring system. And if the Lilly score comes less than 0.45, then only the steroid should be continued for a month. Now coming to the STOPA trial. The STOPA trial is regarding, this was a trial which had 4 arms, compared placebo, prednisolone, placebo, pentoxifylline placebo, and prednisolone and pentoxifylline. So this study showed there is no difference. There is no benefit with either prednisolone pentoxifylline combination or pentoxifylline alone or prednisolone alone. Although the conclusion was that, but there was some mortality benefit in the group which had prednisolone. So prednisolone plus placebo, and if you can see prednisolone plus pentoxifylline had some mortality benefit, 28 days mortality benefit. But still, after this trial, pentoxifylline went out of favor. So after that, we don't use pentoxifylline anymore in these patients of alcoholic hepatitis. So this was the trial with pentoxifylline. This is a randomized, this is a meta-analysis of 5 trials which showed that there was not much benefit, no benefit in trial sequential analysis. There was increase in adverse events, and there was a lot of bias in these studies. So pentoxifylline does not have any advantage in patients with alcoholic hepatitis. So this has gone out of favor, and currently we don't use this. Now coming to, if the patients if we cannot give steroids, then what? So what we can do, this was a landmark study published in NEGM by Mathurin P. et al. In 2011, where he showed that those group of patients where steroids cannot be given, that group of patients, though this was a small study, He had done early liver transplantation for these patients and had shown a significant survival benefit. If you see both the Kaplan-Meier curve, the upper curve has got almost 70% survival, and at 24 months when compared to 23% only in the patients which did not undergo transplant. So, but before transplanting these patients, a lot of things have to be done, the medical assessments, psychological assessments, because these patients tend to drink again. They have a high recidivism rate. They tend to drink again. So this thing has to be taken into account. But still, these things have to be explained to the relatives, like, because there are studies which have shown that these patients have gone back to drinking. Now, if we do liver transplantation for this patient, again, studies have shown that only those patients who have advanced liver disease, those patients only respond to transplant. There is some benefit of transplant. Now, if you see the leftmost Kaplan-Meier analysis, these patients, they were such child puge but had alcoholic hepatitis. But these patients, there had no difference, no mortality benefit between transplanted and non-transplanted. Whereas the group which have child pug C, that is the advanced liver disease, they have got a survival advantage when liver transplantation is done for these patients. So because post follow-up management is important, because relapse rate is very high. If you see the Kaplan-Meier curve, no alcohol. If the patient can remain without alcohol, then they have a survival benefit. But if the patient keeps on drinking alcohol, even after transplant, they have a bad outcome. So now, the main management is either steroid or liver transplantation in severe alcoholic hepatitis or alcohol-related ACLF. Now, there are certain other treatments also which have been tried, and there are literature, there are papers, like one was GCSF in severe alcoholic hepatitis. This was a study. The initial study was from ILBS. Then this study by Singh V et al. Was from PGI Chandigarh, where they have shown that the patients who are given GCSF in the dose of 5 microgram per kg twice daily for 5 days, they have increased mobilization of CD34 cells in the liver, and that leads to hepatocyte regeneration. But these studies, the results could not be replicated elsewhere. The other multicenter studies or the studies conducted elsewhere did not show such outcomes. So at present, this is not recommended. Then also fecal macrobiota transplantation, healthy donor. This was the initial study by Syriac Philip, and he reported that though this was a small group of patients, some 8 patients, he had done this study and showed that there was a mortality benefit in this group of patients. But again, we should remember that fecal macrobiota transplantation has got its hazards, and there are mortality reported with fecal macrobiota transplantation, and some more trials are required before this can be recommended. So to conclude, this is my last slide. So when we diagnose a patient of alcoholic hepatitis, the treatment has to be multifaceted, like multiple arms should be there, like treatment of alcohol dependence should be there. Then the accurate diagnosis, if required, liver biopsy should be done, screening for infection, nutrition, all this should be assessed. Then the disease severity should be calculated. The most important disease severity tools that we use are the MADRS discriminant function score. And if it is more than 32, steroids can be started, plus minus NAC and acetyl-16. Now, when you use steroids, infection should be ruled out. Now, once the patients are started on steroids, the treatment should be assessed at 7 days with Lilly score. If the Lilly score is less than 0.45, the steroids can be continued for 28 days. If the Lilly score does not respond with steroids and the Lilly score remains high, then this patient should be subjected to liver transplantation. And if the patient's discriminant function score is less than 32, no specific therapy is required, but conservative management and supportive therapy should be given to these patients. Thank you for your patient hearing. Thank you.
Thank you, Sandeep sir, for such a wonderful deliberation about one of the most commonly encountered situations in our inpatients medicine departments. Although some mysteries which are not yet to be resolved, and you have very nicely enlightened all the spectrums. Now I would like to open the session for questions.
Sir, how strong is the genetic factors in development of alcoholic liver disease? Or is there any overlap syndrome, like we cannot isolate only responsible factor as alcohol? Maybe some metabolic factors also interplay. So how strong is the genetic? Because we have seen that people drinking heavily, not developing any alcoholic liver disease in some cases are there.
So genetic predisposition is always there. So this is not only one pathophysiology, like the pathogenesis that I have described, or the metabolism of alcohol, if you see. Like few people are poor metabolizers. If they cannot metabolize alcohol, suppose alcohol is metabolized through the alcohol dehydrogenase pathway, then acetaldehyde is produced. In that pathway, this free radical injury and free radical production, lipid peroxidation, this does not happen. But if the alcohol is metabolized by the other pathway, like the CYP to CYP pathway, cytochrome pathway, then this free radical are generated, which causes damage to the liver. And of course, genetic predisposition are there. And overlap, usually these patients who drink, they are also obese. If the patients are obese, they also have some ASH and NASH. They always stay together. So yes, multiple factors are there, not a single factor. And the type of alcohol to drink, like there is the study by my friend Mithun from AIG, he had shown that most of the patients who develop alcoholic liver cirrhosis are illiterate people, and those who drink country liquor, because we don't know the percentage of alcohol in those patients. And in that study, they have shown that the literate group who even drink heavily, they don't develop liver disease. So of course, nutrition is a factor, then genetic predisposition is a factor, metabolism of alcohol is a factor, presence of other comorbidities or other metabolic parameters are also important.
So in our country, like what is the volume of evidence? It's theoretical aspect we understand.
Volume of?
Volume of evidence, like more the genetic factors playing stronger role. Or
I don't have any data. I can't tell you any data like what percentage in our country have. But if you see the pathogenesis and you read about the etopathogenesis or alcoholic liver disease, genetics does have a role. Like for example, in NASH genetics, like there is a pleomorphism of genetic things. So PNLP4 gene pleomorphism is there. In alcohol, I am not aware of any genetic term like that. In NAFLD, there is, of course.
Thank you, sir.
Hello, you told about the country liquor, no? What I want to ask is a percentage of alcohol is problematic, or the impurities, any other impurities that...
Of course, impurities are definitely important, like methanol is more toxic than ethanol. So that is one factor always there, but what we don't know is the percentage of alcohol. Like if you see that table which I showed, that study by Mithun, he has shown that first of all, we cannot quantify the amount of alcohol that they are drinking. That's difficult to quantify. And the percentage of alcohol is still higher in that country liquor. So that is important. Impurities are there. That is definitely there. But apart from impurities, if you see this, like if you see, like they say adha means 375 ml. And if you see Bangla drink, this is 38% alcohol. So 38% alcohol, that is a huge amount. So you don't know, impurities are of course there, but the amount of alcohol is also more.
Thank you.
Thank you, Dr. Paul, for a wonderful presentation.
Thanks.
Just one issue that when we do use prednisolone, should we use prophylactic antibiotic in these patients?
Yes, in my practice, any patient of alcoholic hepatitis, we take for granted that the patient has got some infection. I usually always start antibiotic. Always start antibiotics. Any patient of alcoholic hepatitis or alcoholic who has got and if we give steroids, of course, I start antibiotics.
Sir, do you advise any special tests for before starting steroids in alcoholic hepatitis?
Yeah, it's very important to rule out active infection. Now, how to rule out active infection? This is a very good question, because these patients will have leukocytosis. All alcoholic hepatitis patients, if you see the TC count will be high, their CRP also may be high. So sometimes it's very difficult to distinguish whether the patient is infected or not. For that, clinically we have to go if the patient has got fever and all. And also Procal can help you, procalcitonin can help you. And before starting steroids, it's our routine practice to send cultures. We send blood cultures. We take blood cultures, one urine culture. If there is ascites, ascitic culture. Before starting steroids, like after starting steroids, if the patient develops some infection, we know what to do. But it's a very important question. Is sometimes very difficult to differentiate alcoholic hepatitis from sepsis. because TC will be high, CRP will be high. But clinically and procal, these two things can help you.
Is there any role for MANTO test or IGRA-based tests, ASIS?
No, and I'm not thinking of tuberculosis in these patients. Of course, tuberculosis can be there because these patients are immunocompromised, lean and thin. So maybe they have tuberculosis, but in that, usually in my practice, I don't test for tuberculosis unless I have some reasons to think tuberculosis, like the ultrasound shows necrotic lymph nodes in the abdomen. Unless I have some reasons like that, I won't do that.
So thank you, speakers, for your wonderful deliberation.
Thank you very much.
I'd like to felicitate on behalf of the chairpersons. And I conclude the session here.
Thank you, speakers. I would like to request our chairpersons to kindly stay on the stage. And I would also like to request our organizing secretary, Dr. Major Pranav Kanti Datta sir, to kindly felicitate our chairperson. Our organizing chairman, Dr. Pradeep Bhomik, would be felicitating our chairperson. And thereby we will proceed to our next session, Preventive Hepatology, that is session number 12. In this session, the chairperson or moderator would be Dr. Dimbeshwar Das, Dr. Debopriya Shaha, Dr. Mohammad Abdur Rahim. In this session, the first speaker would be Dr. Sanjay Banerjee. He would be speaking on the topic Preventive Hepatology, what it means for non-hepatologists. May I humbly request our speaker to the dais.
Good afternoon, everyone. As it has been a very well-structured and well-designed program, part of that, today's, now the discussion will be on this preventive hepatology. And the speaker is from my own group of hospital, Dr. Sanjay Banerjee from ILS Hospital, Kolkata. So, floor is yours, sir.
At the outset, I must thank Professor Bhomik and his team for inviting me here and providing all this beautiful hospitality. Respected chairperson, distinguished guests, and other learned members in the audience. My topic is preventive hepatology and what it means for non-hepatologists. We all are doctors. We practice medicine. Medicine is our profession. We treat disease, we cure disease. At the same time, it is an important duty for all of us to prevent disease. This is a very good amalgamation of mortality data of liver-related disease in India that has shown a consistent increase in the number of deaths per lakh population from 2000 to 2016 in spite of advancement in diagnostics and critical care. That is the real cause for concern because this country has a serious lack of hepatologists. and there is no shortcut way to become a hepatologist, whatever this BMJ career fair says. Liver disease has diverse etiologies and all culminate in a common end stage we call cirrhosis. Let us start with the preventive aspect of hepatology in hepatitis B infection. Hepatitis B affects 3.5% of world population who are chronic carriers, and functional cure, that is E loss, DNA loss, S loss, 12 months after stopping therapy, is a distant dream for most of the patient. And risk of cirrhosis is significantly high for untreated patients, those with HBE positive compared to negative, those with DNA positive compared to negative, those at a younger age of acquisition, and neonates born to positive mothers are particularly at the risk of progression. And delving on this last point, we had a beautiful prevention strategy in the form of infant vaccination started by WHO in 1991, incorporated in my country since February 2004. This is the most effective strategy, and we in India and perhaps in all South Asian states outperform the global coverage of 95% target set up by WHO, and probably based on this single initiative, we'll be able to a large extent eliminate hepatitis B by 2030, which is WHO's goal. And studies have shown that in countries like Taiwan, infant vaccination has significantly decreased not only the carrier rate, but also hepatocellular cancer. So logically speaking, a population level HBV vaccination is expected to have huge impact. So the message for the physicians, vaccinate everyone who is not vaccinated, irrespective of it is an infant, it's in pregnancy, or it's in liver disease. But for those unfortunate people who are already affected by virus, we had a very good secondary prevention in the form of antiviral agents. And main benefit of antiviral agents that they have significantly decreased HCC incidence, and in this perspective, tenofovir as an antiviral drug outperforms all its companion drugs like entecavir or tenofovir alafenamide. And tenofovir treatment in pregnancy also, in those who are indicated, decrease the transmission from mother to infant as shown by many studies. So the liver cancer prevention in hepatitis B infection revolves around 3 points. One is primary prevention by universal vaccination. This is not infant, this is primary prevention by universal vaccination. Secondary prevention by antiviral, and tertiary prevention, those who have undergone HCC, is also by antiviral to prevent HCC recurrence. In addition, in hepatitis B, we need to look beyond the virus. Patients should stop consuming aflatoxin, which is common in some parts of central India, manage metabolic syndrome, practice blood injection safety procedures, and manage other comorbidities because they might accentuate the magnitude of liver disease. Now, what preventive hepatology means for hepatitis C infection? Responsible for nearly 50% of all hepatocellular cancer in worldwide. Maybe in future it will be replaced by NFLD as the predominant cause. In India, we are fortunate that our prevalence of hepatitis C is much less, nearly 1/4 to that of hepatitis B, but still 20% can progress, and most important part is that they remain asymptomatic for several years unless they land up in cirrhosis and its attendant consequences. There is no vaccine, unfortunately, for hepatitis C, but we have very good drugs called directly acting antivirals, abbreviated as DAA, combination of either 2 or 3 in some treatment failure cases, of which sofosbuvir and velpatasvir is cheap, easily available, highly efficacious. They achieve an overall SVR of sometimes up to 98 to 99%, irrespective of patient's virus's genotypes, patient fibrosis stage, and contributing factor like IV drug use or psychiatric comorbidities. And this SVR has a pivotal role. This SVR is sustained virological response, which usually assess 12 weeks after end of treatment response, is very important factor in decreasing HCC. So target for hepatologists, target for physician dealing with a patient of HCV should be to achieve SVR. And what are the clinical pointers that the patient is likely to achieve SVR? If the patient has splenomegaly, this is a negative predictor. Higher platelet during treatment is a positive predictor. And once you achieve an SBR, the job is not complete. Post-SBR surveillance for liver cancer is also recommended for patients who already have sustained some form of liver injury or who are co-infected with hepatitis B virus. And now we have a very beautiful and well-organized national viral hepatitis control program with its excellent outreach to the farthest corner of this country. Here you get all the necessary informations. Here there is a portal where, at least in West Bengal, there are 38 hospitals of different tier where this program is currently undergoing. Their patients undergo free of cost investigations as well as treatment. The healthcare personnel is expected to upload their data, and even they have a separate portal for registering by the private healthcare facilities where patients often go unreported and unnoticed. Now, what preventive hepatology means for one of the rapidly rising liver disease called metabolic dysfunction associated steatotic liver disease. Recent prevalence study by Dr. Yunus's group has shown it's nearly 30%, and in India it's similar to that. But they progress to cirrhosis, and we all know, and more dangerous to that, some cases of NFLD, it's now known that may progress to directly to liver cancer without recourse to cirrhosis. And in addition, they also have several extra hepatic comorbidities like cardiovascular, diabetes, cerebrovascular accident, chronic kidney disease, and many extrahepatic malignancies, particularly cholangio and colonic and breast carcinoma. So prevention of fatty liver disease should start with weight loss. 10% is for fibrosis, though 3% weight loss may alleviate steatosis to some extent. Weight loss has a beneficial effect not only on liver fibrosis or steatosis. It also manages metabolic parameters, blood pressure, diabetes to some extent, as well as it improves muscle strength. But there is a study which has shown that most of the people cannot maintain or rather regain weight after 5 years of starting this therapeutic lifestyle modification. So weight loss has its limitations. Most of the people regain. Do we have any scope for drugs? Therapy of NFLD or MASLD is challenging because there is no approved drugs. Most of the current society guidelines say lots about its risk and impending epidemic. In the same publication, in the next page, next paragraph, they say, yes, your risk is high, but we don't have any drug. Resmetirom is only US FDA approved, not available in Southeast Asia. Obeticholic acid is available, but is not approved, in spite of one very encouraging phase 3 trial of small number of patients. So we have a dilemma, and to clear out of this, we have 3 group of drugs which are recommended by INSL. They are vitamin E, pioglitazone, and saroglitazone. Recently, there is a renewed interest in an anti-obesity drug called semaglutide. Vitamin E, pioglitazone, and saroglitazone has been approved by Indian National Association by Study of Liver since December 2022, and they are recently we have also performed one meta-analysis on saroglitazone, and this is mostly based on Indian data with 2 RCTs from overseas countries, and we have shown that in this compilation of 10 studies, saroglitazone was found to be useful. It decreased fibroscan by on an average 2.2 kilopascal and ALT by 26 points. So any drug which improves fibroscan by 2 points, 2 kilopascal points, and any drug that improves ALT by 17 units is going to impact the natural course of the disease, because we have separate papers saying that. So in that aspect, saroglitazone may be a game changer, but we need more data, more RCTs, and more pan-world data. We also have done recent meta-analysis on semaglutide treatment in non-alcoholic fatty liver disease, and have shown that it not only improves steatosis, it also improves necroinflammation to some extent. Though recently there is a paper by Dr. Rohit Lumba's group in Lancet that has shown that semaglutide has no role in compensated cirrhosis. So your lifestyle modifications has limitation. Drugs are not going to be that useful, but bariatric surgery offers effective weight loss in most overweight or fatty liver patients that also reduces cardiovascular risk and even mortality. So it's a part of the physician to motivate the patient for bariatric surgery if they qualify for that, if the patients qualify for that, and send them to bariatric surgery centers, because almost all other treatments are much less effective or non-sustainable compared to bariatric surgery. So in absence of a specific treatment, the key issue in public health for managing MASLD is improvement in awareness and improvement in prevention. Therapeutic lifestyle, we have well-defined criteria, but it's a matter of great joy and pride that in India, there is integration of NFLD or MASLD now in National Prevention and Control of Non-Communicable Disease Program, and where the government has come up with a beautiful plan. They have divided into 4 tier: community level workers, primary health centers, community health centers, and district hospitals. And specific job assigned to the healthcare workers working in these 4 tiers. So they have specific jobs, and there are well-defined criteria when to refer this patient to the higher tier. So strategies for NFLD in India or MASLD for India are 5-pronged: health promotion, self-testing, affordable point of care diagnosis, accessibility to affordable treatment, and rehabilitation in patient who are. Because NFLD is everywhere. NFLD is in barber shop, NFLD is in a tailor shop, NFLD is in KFC outlet, and NFLD is even at your home. Now, what preventive hepatology means for portal hypertension? We all know that non-selective beta blockers are useful to stop first variceal bleed in those who are high-risk barracks, and also to prevent rebleed in those who have already bled. This is based on several studies and meta-analyses published over the last 3 decades. And recently there is a suggestion that in this aspect, carvedilol is better than propranolol. So patients of cirrhosis with varices, the preventive strategy, and perhaps this is one of the important preventive strategy that is often overlooked, is giving them beta blocker. And recently there is a paper in 2022 that beta blocker not only prevents variceal bleed and rebleed, beta blocker does prevent decompensation, beta blocker does prevent risk of mortality in patients if you can start them in compensated stage in early stage. So there is a renewed interest in using beta blocker, and the recent Babino 7 in 2022 prefers carvedilol over propranolol. Compare this with endoscopic band ligation. Yes, they are equally effective in primary prevention, but the study, including some Indian studies, we don't have long-term data on the efficacy of endoscopic band ligation in patients who are compensated cirrhosis. So we don't know whether it offers any mortality benefit or not. So a cheap drug like beta blocker or a cheaper alternative like medication rather than banding and sophisticated gastroenterology setup can do a lot in preventing variceal bleed, rebleed, or even decompensation or mortality. Now, what preventive hepatology means for HCC surveillance? Approximately 5 to 12% of all cirrhosis develop HCC every year. So we know that they should be put on regular surveillance. MRI is the best, but it's not feasible. So almost all the guidelines support USG every 6 months. Recently, there is a trend for not to advise alpha-fetoprotein because meta-analysis has shown that neither it has any advantage over USG nor it provides any specific advantage when combined with USG. So an USG every 6 months with or without alpha-fetoprotein, if possible, is the best way to prevent HCC or to detect rather HCC at an early, treatable, rather curable stage. So screening for portal hypertension by endoscopy, HCC surveillance by ultrasonography, symptom management, liver transplantation all fall in the domain of hepatology, but physicians do have a role in altering the natural history of chronic liver disease, screening and identification or management of the liver disease. And hence the concept in preventive hepatology is to go upstream prevention. Now, what preventive hepatology means for alcohol use disorder, I will just pass on rapidly on this because just we have a discussion, beautiful discussion on alcohol. Now, risk of ALD is, we all know, is dose dependent both in women as well as in men. And nearly 10% of world population, it's actually 10.5, suffers from alcohol use disorder. DSM-5 is very difficult, so we rely on audit C. And if you are treating alcoholic liver disease, you are treating 2 diseases in a person. One is alcohol-associated liver disease. And you know there are several types: cirrhosis, alcohol-associated hepatitis, separate treatment, liver transplant, steroid, you can use this and that. But you are at the same time also treating a person who is suffering from alcohol use disorder that is adversely affecting his social, occupational, and health consequences. So you need support groups like Alcoholic Anonymous or Smart Recovery. You need inpatient rehabilitation. They need behavioral therapy, at the same time a closure loop and support to their mental health. The final is pharmacologic therapy. Dr. Pal highlighted on the role of baclofen and naltrexone. Because alcohol cessation works, so on every encounter, the job of physician would be to counsel the patient regarding the need and the value of alcohol cessation. And relapse prevention should fall ideally in the domain of the physicians whenever the patients go to physicians for any other problem. Only 2 drugs are approved. We use baclofen, I also use, but 2 drugs are approved by US FDA. They are naltrexone and acamprosate. I think acamprosate is quite commonly used by psychiatrists. And recently there was initial concern about naltrexone in liver disease, but recently there are studies that even in abnormal LFT, naltrexone can be safely given. And they are recommended by ACLF guidelines in 2019. So there is always a conflict between hepatologists and psychiatrists in treating alcohol use disorder. Hepatologist thinks it's not his problem to tackle the addiction part. At the same time, psychiatrist is not expected to know when to give steroid or when to perform liver transplantation. But rather than working as a distant islands, staying away from each other, there should be a collaboration, and this has been very beautifully highlighted by a review in Journal of Clinical Experimental Hepatology in 2023, that there should be an interdepartmental coordination and proper coordination between medical provider, psychiatrist, and therapy for the management of ALD patient. Now, what preventive hepatology means for metabolic medicine? Or more importantly, what should physician know about the interaction of diabetes and liver? They should know about the data available. They should have an idea which diabetic to screen, why, when, and how. And treatment is obviously known to most of the physicians, how to tackle diabetes, how to tackle liver disease. The prevalence of diabetes in this country is 11.7, but more alarming is that prevalence of pre-diabetes in India by Dr. V. Mohan's study is 38%, and nearly 1/3 are having metabolic associated steatotic liver disease. That not only decreases the quality of life, it increases the risk for many other diseases which fall in the domain of the physicians. And health spending on diabetes has increased recently, particularly the currently available anti-diabetic drugs, though are very useful and have pleiotropic effect, they are quite costly. And in a patient who has a liver disease as well as diabetes, there is increased risk of progression of fibrosis, liver cancer, and other advanced extrahepatic diseases. For screening, we have American Diabetic Association criteria for when to screen, how to screen, and recently they are placing more importance on hemoglobin A1C rather than fasting or 2-hour post-pharma glucose. Lower rates of screening are mostly responsible for the missed opportunities. We miss many cases of pre-diabetes. With proper screening, we can identify them. And for treatment, American Diabetic Association every year in the month of January comes with very beautiful handbook on the management of diabetes. And recently they have realized the importance of pre-diabetes, and they have also included management of pre-diabetes. The story does not stop here. We have many, many other success stories in preventive hepatology that physicians should be aware of. Metformin prevents hepatocellular carcinoma, and there is strong recommendation in the recent German guidelines about that. Coffee decreases liver-related mortality and hepatocellular cancer in MASLD, and that has been highlighted thoroughly by the recent EASL guidelines of 2022. Contrary to popular belief, statin is not contraindicated in child A or B cirrhosis. We have low quality data that statin improves mortality, and we have very good quality data that statin prevents decompensation in compensated liver disease. And recently there is a study, I think this is 2023, very beautiful meta-analysis that regular aspirin use is also associated with reduced risk of hepatocellular carcinoma. But we need more studies for them to come up in any of the existing clinical practice guidelines. Improving prevention in hepatology also revolves around awareness, because 30% are unsure about the hepatitis vaccination status. Improving prevention in hepatology also revolves around risk stratification. FIB4 index is very good for liver fibrosis, currently preferred in most clinical evaluations, also in alcoholic liver disease, as Dr. Pal showed. It's very useful. It can be downloaded. You can save it in your mobile, just 4 points, and you get a result. Less than 1.3 is low risk of fibrosis, more than 2.6 is high risk, and anything in between is intermediate risk. There are many other scores, particularly for non-alcoholic fatty liver disease. Recently, Dr. Sarnal's group has proposed for Agile 3 and Agile 4, including age, gender, and diabetes. We have specific scores for diabetes fibrosis. And recently, AGA DDW, they have presented another score that is called sepsis score, which was proposed for the patient who have a low risk of disease. That means to rule in low risk of disease. We need a clinical care pathway for the management of MASLD, because MASLD is not hepatologist. On the other hand, MASLD is also not only for the endocrinologist or diabetologist. MASLD for all of us to treat, because MASLD patient will go to each and every specialty. So we need a clinical care pathway in preventive hepatology of MASLD, where that should be easily applicable. At the same time, that should be universally followed by almost all of them, so that we can have a streamlined care. In the first level, we can do FIB-4 scanning, and in the second level, we can do a liver stiffness measurement by fibroscan. And based on those who have a low risk, they don't need therapy. Based on those who already have established fibrosis, cirrhosis, F4, pharmacotherapy is not recommended. But there is a group in whom treatment, following a clinical care pathway, an universally accepted pathway by all logists, can save a lot of life of patients. So to conclude, the development of preventive strategies and treatment in hepatology over the past decade truly is a success story. Continuous testing in primary care and awareness campaigns to motivate patients to be tested are crucial for further improvements. And I am surprised while making this presentation, I saw there are at least 3 different societies on preventive cardiology with their mouthpiece journals. So we can also do that in our hepatology. So preventive hepatology is a broad domain, and in future, preventive hepatology will expand further. Thank you very much for your kind attention.
Thank you, Dr. Banerjee, for stimulating us, all of us, to think that liver diseases are preventable. And yes, he's rightly mentioned that we are familiar more with preventive cardiology last 2-3 decades, but it's a newly evolving concept. And in fact, a group of experts in 2023, there is a proposal that a subspecialty should be created of preventive hepatology and incorporated in our curriculum. The experts, that article was published in the Journal of Family Medicine and Primary Care, 2023. I think that needs to be pushed also, so that more and more young doctors are trained to look into this preventive aspect. What is your comment on that? This curriculum, should we, as a foundation, should we push it?
We do have a curriculum for preventive, what we used to call preventive and social medicine. They have termed this now as community medicine. But I think we need to give more focus on those years of training, which we could have gained a significant experience by exposing to the preventive aspect of disease.
Because during the primary prevention stage, there are a lot of things to be done, because the liver diseases may not be specifically will present, non-specific symptoms are more, and that may be silent also at particular point of time. So how to suspect and how to screen?
Most of the chronic liver disease, because the burden of liver disease is on chronic liver disease. Acute liver diseases are itself symptomatic, so they come to clinical recognition. Most of the chronic liver diseases are asymptomatic, at least for the initial several years of development. So universal screening for a country like India with 140 crore population is not feasible. I don't think it's feasible even for Bangladesh, which is nearly 21 crore of population. So there can be specific target groups in whom we should look for liver diseases. You can say that target group to be more acceptable, non-stigmatizing, rather than saying them high-risk group. So target groups like those with and that also depends on which disease you are considering. Diabetic metabolic syndrome, there are no guidelines. I'm so surprised to know that ASLD, our liver society, till date does not recommend testing for non-alcoholic fatty liver disease in diabetes or testing of diabetes in non-alcoholic fatty liver disease. So this group of people who are predisposed to metabolic associated liver disease should be screened for that. The group of people coming from Dr. Mithun Sharma study shows, coming from lower state of the society, should be screened for alcoholic related liver disease. Those group of people who may have a high-risk behavior. If the physician encounters any person high risk of behavior, should be screened for viral hepatitis B and C. All children should be screened for infective liver diseases. I think you have to categorize depending two things. One is your special population or special group or target group, and please don't call them risk group because risk carries a stigma. So target group, at the same time, target disease. And if you can mix these two things, I think the detection rates will increase so that we can risk stratify and can treat them at an early stage.
Questions at the end of this session will be better, or now also one can. Anybody has any query? Dr. Banerjee is here.
Thank you very much. No question, in fact, no query. This is just a information or rather our observation. You have rightly shown that Hep C in India is around less than 1%. And we have also seen a few years back among the blood donors of the state, of our state, it is around 0.1% among the voluntary blood donors. So it was very less. But for the last few years, it is increasing by leaps and bounds in our state, and that is due to intravenous drug use. Now it is so much so that almost in every liver clinic, we get more than 100 patients who are all Hep C positive, and all are IDU. And another issue is that these are almost, we have seen among the, we had a study that among the drug users, it is around 20% of them are positive for HCV, 4% are positive for HIV, and co-infection is very high. That is a problem of our state because now we are having a big problem with the drug abuse. So that can be there in any other state, like Punjab earlier. So that is our observation, what we said, what we found. Thank you.
Thank you.
Is there any question? If there is no question, then we will proceed for felicitation of our speaker.
Thank you so much, sir, for your valuable words. Now, I would like to request our next speaker on the dais, Dr. Tasneem Mahmood. He would be speaking on the topic, Immunotherapy in HCC.
Very warm welcome to Dr. Tasneem Mahmood. She is from Bacon Pharmaceuticals, Bangladesh. She will be speaking on immunotherapy in HCC. Over to you, madam, for your deliberation.
Respected audience, delegates and faculties, very good afternoon all of you. I am Dr. Tasneem Mahmood from Bangladesh. I welcome you all to this session, and today's presentation topic is immunotherapy in HCC. So hepatocellular carcinoma is now the 5th common causes of cancer worldwide. A total of 841,000, that is 4.7% new hepatocellular carcinoma are estimated to have occurred in 2028, in addition of 8.2% hepatocellular carcinoma related deaths across the world. In Bangladesh, the prevalence of hepatitis B virus and hepatitis C virus is 5.4% and 0.88% respectively. Liver cancer is the 3rd commonest cancer in Bangladesh, next to lungs and stomach cancers, and hepatitis B virus is responsible for 66% of hepatocellular carcinoma in Bangladesh. So now we all know the cancer treatment, overall cancer treatment, and here I want to say, elaborate the journey of cancer treatment. That is started from surgical treatment, that is surgical treatment or cauterization of tumors as the only therapeutic option. After that, radiotherapy, and then chemotherapy, that is the development of anti-tumor drugs for the treatment of hematological solid and solid tumors. After that, the targeted therapy was invented, that is tyrosine kinase inhibitors and monoclonal antibodies. And then the checkpoint inhibitors, that is our today's topic, that is use of MAPs to stimulate the immune system against cancers. So overall, the limitations of, there are a lot of limitations in the systemic treatments, and main limitations that the liver transplantation is one of the recommended treatment modalities of hepatocellular carcinoma. However, in reality, recurrence and adverse outcomes rates remain high. In the absence of a definitive cure, many treatment options exist, each with their own advantages and disadvantages. The number of options available can be daunting for both patients and practitioners. So here is the Barcelona Clinic Liver Cancer Staging and Treatment Strategy for Hepatocellular Carcinoma. As we all know that it is the latest version of BCLC staging. That in the very early stage we suggest, according to this staging, suggestive for ablation resection. And in the intermediate stage, there is a suggestion of transplantation and transarterial chemoembolization, whereas in advanced stage, systemic treatment is suggestive. In terminal stage, best supportive care is recommended. Now we will shortly brief on the immune response of a normal person, that is the proper functioning T cell that can find and fight or attack the tumor cells. That is a normal immune response of our body. So in an abnormal situation, whereas some tumor cells can switch off the activation of T cell through PD-1 pathway. Tumor cell binds with the T cells PD-1 receptor through PD-L1 and PD-L2 ligands and inactivate the T cell. So T cell cannot be the further find and the fighting activity. So the T cell, the activity of T cell will be deactivated in this case. So what immune checkpoint inhibitors works actually? It binds with the PD-1 receptor and inhibits the bindings of PD-1 and PD-2, PD-L2 ligands with the T cell. This in turn switches on the T cells find and fight system and restores the immune response. So in this way, the immune checkpoint inhibitors restores the immune response of our body. Now I will discuss some papers on this topic, like how immunotherapy works in the hepatocellular carcinoma. So here there is a paper named Embrave 150 that was a global randomized open-label phase 3 study in which patients with unresectable hepatocellular carcinoma were randomly assigned in 2:1 ratio to receive either atezolizumab plus bevacizumab or sorafenib. And the co-primary endpoints were progression-free survival and the overall survival. And the ultimate outcome of this clinical study showed that the combination treatment with atezolizumab and bevacizumab resulted in a significant improvement in the both progression-free survival and overall survival comparing to the sorafenib. Here is another study called Efficacy and Safety of Nivolumab plus Ipilimumab in patients with advanced hepatocellular carcinoma previously treated with sorafenib, that is CheckMate 040 randomized control trial. Here 3 arms were taken. In arm A, 50 patients were given nivolumab 1 mg per kg plus ipilimumab 3 mg per kg administered every 3 weeks, followed by nivolumab 240 mg every 2 weeks. In arm B, 49 patients were given nivolumab 3 mg per kg plus ipilimumab 1 mg per kg administered every 3 weeks, followed by nivolumab 240 mg every 2 weeks. And on the other hand, in arm C, 49 patients were given nivolumab 3 mg per kg every 2 weeks plus ipilimumab 1 mg per kg every 6 weeks. So here, in the sample size was 148 total participants, and 120 were male, and the median age was 60. At this data, the cutoff, the median follow-up was 30.7 months. Investigator-assessed objective response rate was 32% in arm A, 27% in arm B, and 29% in arm C. Any grade treatment related adverse effects were reported in 46 of 49 patients in arm A, 35 of 49 patients in arm B, and 38 of 48% in arm C. There was one treatment related death, that was in arm A, grade 5 pneumonitis. So the ultimate outcome of this paper is the nivolumab plus ipilimumab had manageable safety, promising objective response rate, and durable responses. So here, another paper was found over lenvatinib combined with the nivolumab in advanced hepatocellular carcinoma, a real-world experience, whereas the study design was started from January 2016 to December 2020. Patients were all with advanced hepatocellular carcinoma, and 40 patients were given lenvatinib and nivolumab in combination, whereas 47 patients were given lenvatinib. So the ultimate outcome of this clinical study was nivolumab and lenvatinib has a great objective response rate comparing to lenvatinib, that is 45%, whereas lenvatinib gives the objective response rate, that is 23.4%. On the other hand, the progression, in case of progression-free survival, nivolumab and lenvatinib combination progression-free survival was 7.4 months, whereas lenvatinib only gives progression-free survival rate, that is 4.8 months. So overall survival rate is better in nivolumab and lenvatinib comparing to single lenvatinib. Here's another paper I want to share with you. That is a real-life experience combining atezolizumab and bevacizumab in patients with unresectable hepatocellular carcinoma in Bangladesh. And that is published in May 2022. And the method, we conducted a real-life observational study in a small number of Bangladeshi patients with unresectable hepatocellular carcinoma on the background of decompensated liver cirrhosis. And the ultimate outcome was we had only 6 patients in our study, and the patients took the drugs in diverse number of cycles. One of the patients who took 6 cycles of the drugs have been surviving for about 15 months. Atezolizumab and bevacizumab combination proved to be safe. And last but not the least, we have another paper that is the survey of nivolumab and lenvatinib for the treatment of advanced hepatocellular carcinoma. I was one of the co-author in this paper. Here the ultimate outcome is the purpose of the study was to explore the clinical efficacy and side effects of nivolumab combined with lenvatinib. And this was a retrospective observational study which was done in Department of Hepatology Lab at a specialized hospital that was conducted during the period of January 2022 to 2023, total 1 year period. The total number of patients enrolled was 48. Patients were selected by purposive method of sampling, and all the patients were suffering from advanced stage of hepatocellular carcinoma. And here is the outcome. The mean age of the patients were 55.8 plus minus 1.2 years. And regarding the gender, males were more than females. That was 58.3%. And hepatocellular and hepatitis B was the major cause for development of this disease, which is 22 patients had this morbidity. 35% patients showed partial response. Objective response rate was 40%, and disease control rate was 78%. With context to hepatitis B positive patients, 44% patients had partial response, and the disease control rate was 82%. So, current advances in immunotherapy and its combinations have altered the hepatocellular carcinoma treatment landscape, and clinical studies are continuing to pave the path forward. Immunotherapy increases the survival rate and provides a long-term cancer control in subsets of hepatocellular carcinoma patients while also minimizing side effects. And the further research into immunotherapy in combination with current treatments for hepatocellular carcinoma in the early stage and intermediate stage may assist a greater spectrum of patients. And I have a small message that is in Bangladesh, Beacon Pharmaceuticals is one of the manufacturers of nivolumab as Nivomab. Thank you so much for your patience hearing.
Thank you, ma'am, for your nice elaboration. Now the floor is open for discussion. Any questions from the floor? If there is no more question, then we can conclude this session here. We will proceed for our felicitation of our speaker, Dr. Tasneem Mahmood, ma'am.
Thank you, ma'am, for your valuable words. Now, I would like to request Dr. Anil Bhomik, sir, to kindly felicitate our chairperson.
Now we'll start with our next session, that is Future in Hepatology. This session will be chaired by Dr. N.C. Das, Musarat Mahatab and Dr. Manoj Debnath. May I humbly request our respected chairperson to kindly take their chair on the dais. In this session, our first speaker is Dr. Mamum L. Mahatab. Sir will speak on the topic stem cell therapy for the end-stage liver disease. May I humbly request Sir to kindly take the dais.
Good afternoon, everyone. Now we'll start the next session. In this session, the first speaker is Professor Dr. Mamun Al-Mahatam. He doesn't need any introduction. He himself, his introduction is the international faculty. Now, I will request Professor Dr. Mamun Al-Mahtab, please, for his deliberation. Thank you, sir.
So today I'll be talking on a topic which is rather uncommon, and there are controversies and expectations, beliefs and disbeliefs, a hell lot of things about this topic. But I have two disclaimers to start with. The papers that I'll be discussing today were all conducted by our group in Bangladesh. We had done all the studies with ethical approval from Bangabandhu Sheikh Mujib Medical University and from the IRB of the university, and our country, the Drug Administration of Bangladesh, has a guideline for stem cell studies and cell-based therapy, and the studies are conducted as per the national guideline of the country. So at the very outset, so how do we do the pre-stimulation? First of all, I want to make it clear that we did not use any stem cell that was collected from outside the subject's body. We actually use pre-stimulants, GCSF, that is granulocyte coronary stimulating factor, for stimulating stem cells from bone marrow. And this was, I think, discussed by Dr. Shondip Paul in his paper, where he briefly showed the work by Professor Sarin and his group that if we use GCSF, there is mobilization of stem cells from the bone marrow to the peripheral blood. And what Dr. Sarin and his team suggest is that what happens with such stimulation is that there is mobilization of CD34 cells and differentiation into mature hepatocytes, which helps in liver regeneration. They have also proposed that if we use GCSF, there is increased trafficking and proliferation of hematopoietic stem cells, erythrocyte precursor cells, cytokines and growth factors, and there's reduced apoptosis, as a result of which there is increase in CD34 neutrophils, monocytes, and MAPCs in blood. This also prevents sepsis, and they propose that as an outcome of all these things, there's increased regeneration, reduced fibrosis, and reduced inflammation in the liver. So at the very initial days, what we did was we did a safety study in 18 decompensated cirrhotics, where we used injection GCSF, 2 injections weekly for 6 weeks, and we observed the patients at 90 days. Overall, we found that 16 out of 18 patients were alive. We did not see any severe adverse event in any of the patients. And there was some improvement in ascites that we found, and we reported our outcome in a journal. Subsequently, we did a study in ACLF, acute chronic liver failure patients. We have little to offer, especially in a country where we don't have liver transplantation. So this is actually the replication of a work that was done by Professor Sarin and his group. Here we had 2 arms. In each group there were 16 patients of ACLF. One group received standard of care. In the other group of patients we used GCSF in the dose that we have just that I have just mentioned. That is 30 IU, 2 doses for 6 weeks. At the end of our 90-day observation period, we found that in the standard of care group, there were 50% mortality, 8 patients were surviving, whereas in the group B, where we had used GCSF, there was a better survival of 14 patients. This is not statistically significant survival benefit, but we saw some advantage. Subsequently, we did another study in another group of ACLF patients. Here in the, one group, there were 17 patients who received standard of care, and in other group, there were 22 patients who received standard of care plus GCSF in the same dose, plus erythropoietin. And we also observed these patients for 90 days, and at the end of 90 days, the observation was similar. There was better survival in the ACLF group treated with combination of G-CSF and erythropoietin, we had 8 surviving patients compared to group B, where we had 5 surviving patients who did not receive G-CSF and erythropoietin, only received standard of care that we had to offer. Here we saw more surviving patients, but again, the survival was also not statistically significant. But these 2 studies, in fact, these 3 studies encouraged us, or at least showed that, yes, the therapy that we are trying to attempt is safe, if not extremely beneficial. And based on this, in 2017, we started the first case where we adopted to a new technique. We used the apheresis platform. That is, after stimulating stem cells, we collected the stem cells using the apheresis platform. And this is how it looks like. This is the apheresis machine. You may be very familiar with this machine after especially the COVID and epidemic pandemic, when we had tried to use this machine for plasmapheresis. So this is basically used for platelet collection, apheretic platelet collection, and also is quite familiar with regions where dengue is prevalent. Anyway, this is how the collected stem cells look like after we collect them from the patient who was stimulated with G-CSF injections, and we average, on an average, collect 60 to 65 ml of stem cells. And then in the good old days, we used to apply them through the transarterial route, applying the same strategy, same technique as transarterial chemembolization. That is, the stem cells were injected through the hepatic artery. So we accessed the hepatic artery, the portal, the femoral artery, and then abdominal aorta, and then hepatic artery, and would inject stem cells into the liver to see what happens. So we in the initial around 50 odd cases, we had the stem cell count. We found that if we stimulated like this way, the average count was of CD34 cells was 7.5 into 10 to the power 5 per ml. This is an arbitrary figure. This figure is taken from bone marrow transplantation, where they take this figure as a standard stem cell count for bone marrow transplantation. We also looked at the viabilities in our initial cases, and we found using flow cytometry that most of the stem cells that we would collect in this way remained viable. So we don't practice the stem cell count and viability these days routinely. These were in the initial days of our academic exercise. And we actually did a study which we published subsequently. This is a stimulation of stem cell production with G-CSF injection, subsequently collecting the stem cells using the apheresis platform, and then injecting these stem cells into the liver of the patient through the transarterial route. We saw improvement in all the parameters compared to those who did not receive stem cell therapy, decompensated cirrhotics, on standard of care. There's improvement in bilirubin, ALT, albumin, INR, and ascites, but the most important statistically significant improvement was seen with albumin levels. And as you can see, if you remember my very first slide, when we used only G-CSF, there also we saw improvement in albumin. And this is one interesting phenomenon that we see in all our studies with the stem cell therapy, that there's some improvement in albumin, if not survival benefit. So, but as we all know, that transarterial chemembolization is a difficult technique to do. So the technique that we apply, if we apply this for delivering stem cells to our patients, it is not only expensive, it is also difficult to accomplish. So subsequently in 2018, after gathering much experience, we decided to change the route of administration. And since then, we have been stimulating stem cell production the same way using G-CSF. We have been collecting stem cells using the same technique using the apheresis platform, but the route of administration has been changed. We now directly inject the collected stem cells in the portal vein percutaneously under ultrasound guidance, and that we have been practicing since then. And we have published our data as well, where we saw similar results. So there's no benefit or over the transarterial route. Here also all the parameters improve with stem cell therapy. No survival benefit, statistically significant, but statistically significant improvement in ascites and albumin levels. And right now what we are doing is we are now trying, these are all advanced cases. The data that we have published are with ACLF, acute chronic liver failure patients, and with decompensated liver cirrhotics. But now we are trying to see whether we can delay decompensation using stem cells, and the study is ongoing. So hopefully we'll be able to present this such data in some future meeting. What I want to say is, to be very clear, that there's enormous prospect for stem cells. The research is in the very initial stages. What we're doing are also in the very initial days. The sky is the limit, and we are still, crawling on the ground. We never say that stem cell therapy is the ultimate cure for decompensated liver cirrhosis. We never say that it's a substitute to liver transplantation. Those still remain the fact that liver transplantation is the ultimate treatment for decompensated liver cirrhosis as of today. But these are studies from regions where there's no liver transplantation facility, where there's limitation of resource constraint situations, and these data show some promise. So we use these techniques in patients who refuse to undergo liver transplantation or who cannot afford liver transplantation, with the hope that they will get benefited. And as I told you, that all these studies were done with the ethical approval from the Institutional Review Board of Bangabandhu Sheikh Mujib Medical University, published in moderate to very good journals, and was done, all the studies and the treatments are carried out according to the national guideline formulated by the Drug Administration of Bangladesh, the guideline for stem cells and cell-based therapy. Thank you very much. So before I actually conclude, I think I should, although we don't have many people here, but we have many of the members of the team that does the stem cell therapy work in Bangladesh, and I'd like to introduce you to them. They have just entered. We have with us Dr. Abdul Rahim, who's an associate professor at the Department of Hepatology, Bangladesh Sheikh Mujib Medical University. We have Dr. Sheikh Mohammad Noor Alam Diu. He is also an associate professor, who would be a professor very soon in the Department of Hepatology, Bangladesh Sheikh Mujib Medical University. We have Dr. Roxana Begum. She's an assistant professor of hepatology at Shahid Sohrawardi Medical College. We have Dr. Lutful Mubin, an assistant professor of hepatology at Kurmitullah General Hospital, Dhaka, and Dr. Atikul Islam, who's a hepatic consultant at the Sheikh Russell National Gastroliver Institute. And we are missing two of our colleagues. They are the team that does the work and generate the data that I go on presenting in different meetings and getting the claps. Thank you very much.
Thank you, sir, for your wonderful session. I would request you to kindly take the chair on the dais. Our next speaker is Dr. Nusrat Chowdhury. She will speak on the topic Wilson Diseases, Bangladesh Scenario. Thank you.
Welcome, ma'am. Dr. Nusrat Chowdhury, ma'am. Please start your talk, Wilson disease in Bangladesh scenario.
Honorable Chair and respected audience, in this meeting of eminent hepatologists, I'm a vitreoretina surgeon, so I'd try to be as brief as possible because the only part of ophthalmology that is related to hepatology is when we are sent these patients, some of the cryptogenic chronic liver disease patients, for screening of KF ring or the cataract or any retinal very rare aspects of Wilson's disease. So I'll just try to be brief on this point. That is, but you see, in Department of Ophthalmology, we do get a lot of referral from Department of Hepatology in Bangabandhu Sheikh Mujib Medical University. And I wondered that how many of them actually turned out to be Wilson's disease, and how come the prevalence of KF ring was so low. And that is exactly what I just want to present to you. So we did look into it retrospectively, and we found that there was high prevalence of Wilson's disease among those cases that were referred from the hepatology department. But there was a very low prevalence of KF ring in patients with cryptogenic chronic liver disease. So at least in our department that we found, that we saw from the hepatology department. And this paper came out in the Eurasian Journal of Hepatology and Gastroenterology in 2019, and I'm just presenting the data here. So patients with chronic liver diseases are one of the major pathologies among the hospital attendees in hepatology OPDs in Bangladesh. But till date, in a country of 170 million people, there is lack of properly designed epidemiological study about the etiologies of chronic liver disease in Bangladesh. And there still remains a bulk of CLD patients who are not attributable to viruses such as hepatitis B virus or hepatitis C virus, NAL, non-alcoholic fatty liver disease, alcohol-induced or drug-induced or autoimmunity-induced liver cirrhosis. So a considerable proportion of these cases of cryptogenic liver disease patients may belong to Wilson's disease. As we all know that Wilson's disease is autosomal recessive disorder where there is disorder of hepatocyte proper transport because of impaired function of T-type adenosine triphosphate, and it is a genetic disorder. ATP7B gene located on the chromosome 13q14 is responsible for it. The end result is there is an accumulation of copper in different organs, particularly liver, brain, and eyes, where we come in, the ophthalmologists. So these are the organs that are affected, and for us, the things that we find in ophthalmology mainly are the Kaiser-Fletcher ring or KF ring, where there is copper deposition in decibit membrane of the cornea at the limbus, extending from the Schwalbe line of the angle to 5 millimeter on the corneal surface. And it starts usually from the upper quadrant, from 10 o'clock to 2 o'clock, and upper area, and then the lower area, and then it becomes a continuous circle. It is seen and looked into, examined by slit lamp in a slit beam, but when it is quite advanced, you may be able to see it with naked eyes as well, and pen touch, obviously. So what happens is that the free copper that is loosely bound to albumin enters the aqueous humor of the eye and then enters the decimate membrane. The peripheral deposition is attributed to the direction of the aqueous humor. One might wonder why it is only the peripheral cornea that is affected, because vision is not affected by KF ring. This is because the aqueous direction, the spread of aqueous, the movement of the aqueous deposits to the periphery of the cornea. Therefore, there is no visual impairment. And KF ring is seen in 95% of the patients with neurologic manifestation and is about 65% with liver dysfunction. This is one of the reasons why I got interested in it, because we saw that those patients that are referred from the neurology department inevitably had KF ring, but those that are referred from the hepatology department seem to have less number of KF ring. So that was one of the queries that we had. So, but we must understand that KF ring is not specific for Wilson's disease or anything such, because if you have calcosis, that is copper material inside the eye, or in case of primary biliary cirrhosis, you may get KF ring. So but we also must understand that KF ring is not the only manifestation. We do look for cataract, we do look for ocular motility, anything in the fundus, specifically whether there is optic disc pallor or optic neuritis, or there is any sort of strabismus, any vertical movement, saccade abnormality, any nystagmus, any horizontal smooth pursuit movement affected biocular motility. And the type of cataract in case of Wilson's disease is very specific. It's known as sunflower cataract. There is copper deposition over the anterior lens capsule and the posterior lens capsule. Actually, the lens material, the nucleus, is unaffected. It is at the anterior and posterior lens capsule that you get the sunflower cataract, and it typically looks like that. This is very rare finding. So we decided to look into the actual number of Wilson's disease in the cases that we are screening and the number of KF ring that we are getting. So it was a retrospective study. We wanted to assess the prevalence of Wilson's disease among the cryptogenic chronic liver disease cases that we are getting as referral from hepatology department, and the prevalence of KF ring among them. Our total number of population was 941, and the place of study was Department of Ophthalmology and Department of Hepatology, but also in collaboration with the Atomic Energy Center of Bangladesh Atomic Energy Commission. The inclusion criteria were all the cases of cryptogenic chronic liver disease, patients that were affirmed by biochemical imaging and other diagnostic procedure. You know better than me that cryptogenic CLDs are done by a method of exclusion. So when nothing is found, that's when they are sent to us for screening for KF ring. So they were negative for markers of HBV, hepatitis B virus, hepatitis C virus, non-alcoholic fatty liver disease. There was no history of alcohol consumption or drug abuse or related drug consumption, and they did not exhibit any autoimmune pathology. So the procedure was hepatic cirrhosis patients who reported to the OPD of Department of Hepatology, BSMMU, were diagnosed as cryptogenic CLD cases after a detailed clinical, laboratory, and histologic workup revealed no exact etiology. And then 24-hour urinary samples were sent to Atomic Energy Center to assess the level of copper in urine of these patients. And then these patients were referred to the Department of Ophthalmology, Bangabandhu Sheikh Mujib Medical University, for the assessment of presence or absence of KF ring. And the operational definitions were, definitive Wilson's disease were those cases where the 24-hour copper excretion was more than 100 microgram, and they were then regarded as definitive Wilson's disease, and strongly indicative of Wilson's disease were cases between 40 microgram and 100 microgram. So the results were, the age is important because, as you can see, most of the patients are below 30, and the largest number of cohort is below 20. So we are talking about the future of hepatology. I think the future stars of hepatology who are sitting in front of it, sitting in front of the dais, could ponder about this question, because then if you think about the public health aspect of it and community hepatology aspect of it, the burden on our society when these patients who already have cirrhosis, they will certainly, a large number of them will turn into hepatocellular carcinoma, and you know better than me all the complications. So what will happen to them? So the large portion of the cohort were very young. So this is where the future aspect of the research comes into, and that is for you to do. So there were divergent level of copper excretion in patients with definitive Wilson's disease. As you can see, 49 of them had as high as 1,000 micrograms, but most of them had around 200 or 500 micrograms in 24 hours. So out of the cohort of 941, 212 patients had more than 100 microgram in 24-hour urine sample, and was regarded as definitive Wilson's disease. And in 2,039 patients, the level of copper in urine were between 40 microgram and 100 microgram. So they were regarded as strongly indicative of Wilson's disease. Rest of the 490 patients had below 40 microgram copper in 24-hour urine, and then were discarded from further analysis for Wilson's disease. But anyway, as such, this is a very high prevalence if we look into data. So it is a very high prevalence data. But KF ring was found only in 5 of these cohorts. So out of 941 patients with cryptogenic chronic liver disease, 443 patients had an age of below 20 years, and 170 had below 10 years. So just ponder about the fate of these patients. 47% of the cryptogenic chronic liver disease has age below 47, age below, sorry for the printing mistake, below 30 years. So they are more likely to develop cirrhosis or hepatocellular carcinoma. So this is a major public health crisis for the future. So this study showed a very high prevalence of Wilson's disease in Bangladeshi population, although the limitation of this study is that it was a cross-sectional study. So we did not follow these patients up and did not look into how many of them actually turned out to be Wilson's disease. So that is also for you to do. And the prevalence of KF ring was very low in this cohort with liver disease. As I said, that we do find that the KF ring is present much less in hepatological patients than those with neurological manifestations. This highlights a major public health crisis awaiting us in our future, which demands more research and timely intervention to ensure a healthier future for our nation. Thank you very much.
Thank you, Doctor, for such an interesting talk. I think with that we can open the floor to questions, if there are any. I think we can move on to felicitating the speaker.
Thank you, ma'am, for your wonderful session. We would like to take this opportunity to felicitate our respected speaker. May I humbly request our respected chairperson to felicitate our speaker. May I have a big round of applause for our speaker. May I humbly request Dr. Gaurdas Chaudhary sir to kindly come up to the stage and felicitate our respected chairperson with his newly published book, Health Adda. Thank you. Thank you so much, sir.
I will like to request our elegant speakers to have the chair in the dais. So we had an elaborate discussion about Wilson's disease and the stem cell therapy in cirrhosis of liver. So now, if anyone have any query or any comments, Please, you are most welcome.
First, definitely to Madam. You have opened up our eyes as ophthalmologist regarding Wilson disease. Actually, we are not knowing many of the presentation of the Wilson disease, what we can get in the eye. That is a very important issue. And second is, your total number of patients was around 900 plus. All these patients are patients of Wilson disease?
There were patients of cryptogenic chronic liver disease who were sent to our department to search out whether they have KF ring, and only 5 of them actually had. So that is a limitation of the study, that we don't actually know how many of them turned out to be a Wilson's disease patient. But as you saw, that there were 212 patients who were definitive Wilson's disease diagnosed as.
Thank you, madam. Another one, small issue is that do we need any ophthalmological intervention in patients of Wilson disease, those who are having definitive Wilson disease? Any ophthalmological intervention required?
The KF ring doesn't cause any visual problem. The retina problems do not occur that much, or the saccadic movement, eye movement, or the horizontal pursuit movement. These are affected sometimes, but these are very rare. But in case of sunflower cataract, if there is visual disability, then only you can operate. Like any cataract. It's not because of the Wilson's disease. And KF ring never causes any visual problem.
Thank you,
Thank you.
Thank you very much.
Thank you very much.
To Dr. Mamun, as you have said that GMCSF or GCSF itself can be a sort of therapy for the treatment of end-stage liver disease or decompensated chronic liver disease. Then why should we go for stem cell therapy?
Actually, as Dr. Shondipal was also showing, that there is some dispute about this GCSF therapy. From Indian papers, from Chinese studies, we see that it's a very good paper, it's a very good approach, but there are publications from Europe that dispute this therapy. Our approach was that there's increase in stem cells in the circulation. If we could collect them and deliver them directly to the liver, that was the first approach to see if there was some advantage. So that's why we took the transarterial route. But then we opted for the portal venous route because we had there's some technical issues, cost issues, and also some hypothetical issues that since portal vein is the more dominant supply of blood to the liver, and since portal venous blood flow is slower, if we deliver it to the portal vein, whether we should be getting better response, things like that. We have not been able to do so, but as I was telling that these are areas, gray areas, sometimes showing promise, and much needs to be done actually if we want to do such things. And when you are discussing about preventive hepatology, I think can range from vaccination to stem cells, because at every stage, if I want to prevent hepatitis B, I have to do vaccination. And then if I have some good or useful treatment modality that can prevent decompensation, that can also be a part of preventive hepatology. So the definition needs to be finalized, but I think it's an enormous area to work with, and hopefully, we'll be getting more studies, more data in the coming days. Thank you.
One more issue. From the day of injecting a GMCSF to the completion of the therapy, that is stem cell, how much time it takes normally?
Now what we do is, initial days we were very afraid that, whether there will be overstimulation of bone marrow, pain or splenic rupture, things like that. But since we have more than 500 cases experienced these days, we now do very rapid stimulation. We do it in 3 to 4 days. 2 injections daily for 3 to 4 successive days. The blood count usually goes up, total count usually crosses 30,000, and with that happens, we now arbitrarily accept that this is adequate number of stem cells. Because if you remember when I was showing my slides, initial days we would do the stem cell count, and we found that 10 to the power 5 per ml was achievable, where it correlated more or less with a blood count, total count of 30,000 IA. And so when TC is 30,000, in 3 to 4 days time, we stop, we cut the stem cells immediately on that day and deliver it.
You are taking stem cell from the sternum, or?
We take it from the peripheral blood. We use the apheresis machine. Apheresis machine with the series, like for platelet collection, we use platelet kits. For stem cell collection, there are CD33, CD34 collection kits manufactured by the manufacturer. So we use those kits to collect the stem cells.
If you give one cycle of plasmapheresis or stem cell therapy, when you can repeat it again?
We have very little experience with that because people usually don't come back, but we have seen that the effect usually persists for between 4 to 6 months.
So during that time, we have to go for transplantation.
If that's doable, in most cases that is not doable. Actually, we chose the difficult path because see, if I was lecturing in a meeting saying that we can delay compensation for decompensation, no one would accept that. We chose the difficult cases. ACLF was our first choice because in ACLF, there is still functioning liver, viable liver tissue. So anything that may regenerate the liver is likely to respond. Then we went for decompensated liver cirrhosis because decompensation you can do nothing. Even if it's safe, then it's a treatment. So once that is achieved, that at least safe in decompensated cirrhosis, now I can move on to with papers backing me for compensated cirrhosis. And that is our ultimate aim, not to treat decompensated cirrhosis, but to treat compensated cirrhosis and delay the progression.
So there is a mortality benefit or morbidity benefit?
Both, I think. Yeah.
Both of them. What is the cost involved in this total process of one cycle?
It shouldn't be much. In Bangladesh, Dhaka, hospital and everything included, it comes to around less than 200,000 takas, around 200,000 takas in our currency.
Thank you, sir. Thank you very much.
Nice talk as usual, Mamun. Just asking, actually, I also started this procedure, and it was 15 years back. I did it, but I found actually not much benefit as your study showed. My simple question is that you injected through transarterial route and then switched off to portal venous route. So puncturing portal vein in decompensated liver cirrhosis or ACLF must be difficult. How did you manage that?
See, we have enormous experience with liver biopsies. And also, like you, we do many things. So liver abscess aspiration, things like that. So that gave us this, strength that if such a wide bundle can go in, this narrow bundle should not be doing a problem. And we don't do it in ACLF. In ACLF, we only did GCSF and erythropoietin. For decompensated, yes, we do it, but again, to reduce the technical challenges, ascites is reduced first, and then we go for it, because if there is huge ascites, it's difficult to puncture the liver. But as what we have seen is, we haven't seen a single case of internal hematoma or anything with the portal vein puncture. That is very safe, and I should thank Dr. Mubin. We had thought of it for at least 1.5 years before puncturing the portal vein, but now do it regularly, and almost 100% is done by Dr. Mubin, who is a portal vein puncture specialist, I must say.
And lastly, I don't know if I'm right or wrong. See, even if you stimulate the bone marrow by giving GSS and erythropoietin, the total number of the stem cell is still inside the blood.
Yeah.
So in one way, it is going through the liver most of the time. So why we are taking it out and injecting it?
This is absolutely a hypothetical issue, because I told you that when we shifted from just stimulation to bone to TACE and then to portal vein, we expected some advantage in every aspect. The logic was that the cells will go into the circulation through the liver at some stage, but if you can collect them in bulk and deliver to the liver, and then the idea was that if you can put in a slower circulation, it will work better. But we haven't seen, as I was showing you, any advantage between transarterial and portal venous routes. It's the same. As I was telling you, in the last slide showed that we are still crawling actually. I don't know what if someday stem cell therapy will ever be established as one of the treatment modalities, or if it does, whether people will be laughing at us looking into the literature that we are presenting today. But we are happy that in a resource-constrained setting, we tried to do something, and before coming to the scientific community, we had some paper to back our claims. And the claim is that survival benefit. It's something that may benefit the patient to some extent.
No, actually, I'm not laughing at you because...
no, I am saying about the future. Tomorrow, after 20 years, people may start, like today we laugh at the lamivudine papers. So people will be laughing at us after 20 years, but at least we started.
No, why I'm telling you this is that one of my student did thesis on this injection of GCSF plus erythropoietin in decompensated liver cirrhosis and compared with the other standard care therapy, and there was clear-cut advantage in survival. So I think it works and we should try it, but if we can do it in easier way and cheaper way,
sure.
I think this is one of the step that we can take to prevent further decompensation.
And if you ask me where I see the future of substance therapy, it's not in decompensated liver cirrhosis, because in decompensated liver cirrhosis, there's very little to stimulate. So my option would be for ACLF and compensated cirrhosis. But I was telling you, if I start presenting data on compensated cirrhotics, this will be highly controversial. People will be starting, challenging it. Why did you do it? So my approach was to prove the safety in decompensated cirrhosis and then switch to compensated cirrhosis.
Thank you.
Let's add into this discussion, because PGI was the place where these positive trials were, and the final trial was negative. And this was a very regular discussion there. So then while analyzing, we sort of, because this is one group, decompensation now has got various subtypes. Say somebody comes with the first episode of ascites versus somebody who has been decompensated for now 15 years. These two are not the same people.
Not the same, absolutely.
So there becomes a need for, because the European trials, what happens is by the time they go into a trial, they are on alcohol, most of them are alcohol predominant, it's a long-standing disease, it's not the first decompensation, some of them have got multiple. So the clubbing of all these different decompensated cirrhosis together again will bring in a lot of heterogeneity. So I think again there is a window of opportunity to redo this trial in a group with first decompensation at presentation who do not have options for transplant. This is very close to a compensated group, but they are already decompensated, so it reduces our challenges. I think we should again do this in that setting again.
And if you tell me, just to add to your observation, I don't have the data to support what I'm going to say, but my observation is people who are early decompensated benefit extremely well. And these are possibly people who go on recompensation.
If there is no question, thank you, Speaker. We conclude this session.
Thank you, sir, for this wonderful session. Now we come to the most important and interesting session of the day, that is Meet the Expert. This session will be chaired by Dr. Gauradas Choudhury, Dr. Mamum L. Mahatab, Dr. Sanjoy Banerjee, Dr. Dinesh Jyotimani and Dr. Akash Roy. May I humbly request respected panelists to take the chair on the dais. Our speaker of this session is Dr. Saptarshi Vishnu. Sir will speak on the topic Unresolved Issues in Hepatology. Thank you.
Hello. So it's going to be an interesting session, and we have a very prolific speaker in Dr. Saptarshi Bishu. I request you to start his deliberation.
Hey, microphone.
Panelists, distinguished members of the audience. Dr. Bhomik, I thank you and your team for this kind invitation and for your kind hospitality. I always love coming to Tripura. I love the beautiful city of Agartala. And today it's really a privilege to be sharing the stage with stalwart teachers and stalwart colleagues. Dr. Banerjee, I just want to correct you. I won't be doing much of the talking today since I get to ask you questions today. So when Dr. Bhomik gave me this topic, so about unresolved issues, so I was thinking that unresolved issues can be, too much of science like molecules and miRNAs and all, or it can be unresolved issues which we face every day in our chambers, in our clinics, in our OPDs, and in our wards. So I decided to go into the everyday mundane route, into our daily clinical practice, where we face small issues in hepatology, which we hear something, which we do something else, which guidelines say something is practical or not. So I decided to present a few cases, clinical cases, which mostly are from my practice only. So I'll present them to you, and to the panelists. We'll be having an informal discussion. The panelists will take up the questions as they see fit. And of course, the floor is always open to the audience. You can stop us, you can interrupt us, and ask questions anytime. So the first case is a 54-year-old gentleman who is a known cirrhotic for 3 years. He has no history of bleed, had recent weight gain due to worsening of ascites and bipedal edema. And he came to me, and the diuretic doses were adjusted on the OPD basis. 10 days later, he again comes back to the OPD. This time he has significant abdominal pain, and the abdominal distension has not decreased. In fact, it has increased. On examination, he is dehydrated, has tachycardia, has tachypnea, and abdominal examination shows that there is tense ascites and an obstructed irreducible umbilical hernia of size about 10 into 14 centimeter with a neck of size of about 2 centimeters. So as you can see, this is pretty much impossible to reduce. So he was admitted. His labs showed hemoglobin of 9.8, total counts of 16,200. Creatinine was 1.9, bilirubin was 3.2, albumin was 2.9, INR was 1.5, sodium was 132, potassium was a bit on the lower side. He was started on IV fluids, IV antibiotics, and IV paracetamol for analgesia, and an urgent referral to the surgeon was given. So I stop here and go to the esteemed panelists. The first thing is, it appears obvious that this patient is going to head for the operation theater. My question is, how do we decide that this cirrhotic patient needs an emergency surgery, this patient needs a non-emergent surgery, or we can wait? Or how do we decide that, what are the situations in which you will send the patient straight away to surgery?
It's a very relevant case actually, because we do see this once in a while in our workplace. So this gentleman has child B cirrhosis, and he has acute kidney injury. He has incarcerated umbilical hernia. So what we generally first thing is to obviously resuscitate him. This is an surgical emergency situation. Resuscitate them, give them antibiotics, get an imaging done to see what the contents are. That's very important. Whether there's a large bowel content, because that may go in for gangrene. If that's the case, definitely he will require surgical repair. So before that, obviously we should explain the risk of surgery to them. It's all about playing with the risk-benefit ratio, because if you're not going to operate on him, he's going to exsanguinate and die. Whereas if you operate on him, there's a risk of liver disease that can progress. So you have to explain the risk of liver decompensation, further decompensation. He's already decompensated. But it's not unmanageable situation. And we have not lost a patient because of umbilical hernia surgery repair. So they do get worse, and eventually they get better. So the risk of further worsening is probably here we're talking about 20% actually. So most of them actually get better after the hernia surgery because the SIRS component, the inflammation, all those things have reduced. Obviously, we need to optimize them prior to that. I would say, yeah, to answer the first question, the risk of decompensation, worsening of liver function is around 20% or even further 30%. But we need to monitor them very carefully in the intensive care unit. We'll talk about how we manage in the post-op in the further discussion, actually.
I think, as you correctly pointed out, resuscitation is the game changer here. So we need to resuscitate the patient before taking him up for surgery. Dr. Akash, would you like to comment on how you would resuscitate this patient? What would be your choice of fluids? What would be your choice of antibiotics? How would you correct the coagulation parameters?
So he definitely looks infected. He's got one organ dysfunction in form of AKI. His INR is borderline. So I would start him, and he's got a recent hospitalization with a change of diuretics. So I'm suspecting this might come along with either a spontaneous bacterial peritonitis or a secondary bacterial peritonitis. I'll straight away go and start off with carbapenem group of antibiotics, because delaying antibiotics in this group can lead to very, very worse outcomes. Secondly, he would be started on diuretics. We have to see what his point of care ultrasound is, what his volume status is. He would benefit possibly by a combination of both albumin with some crystalloids to be added, which may be a plasmalite or even normal saline that can be. So that takes care of one part. Coagulation correction, I am not very pro that. A TEG or a ROTEM would be very beneficial because this patient has advanced portal hypertension. If you unnecessarily are going to correct his coagulation parameters, we are going to increase the portal pressures more and maybe cause more complications. So INR per se would not be a very big deterrent, but the challenge starts when you bring in the surgeon to operate. Because anything which is more than even touching a 1.4, 1.5, routine surgeons would be very skeptical. So if you see this patient was somewhere in a regular transplant setup, it should be there in a transplant unit, which is not always feasible in India, where regular transplant units would have no issues in operating on these patients. So those are the things, but we can discuss this on multidisciplinary issues. I would not autocorrect this INR.
So I think Dr. Dinesh has already...
Sorry, can I just add one more point?
Please.
I've seen people immediately draining the ascites, actually. In somebody with obstructed incarcerate hernia, you should not drain the ascites because it will just close the neck of the hernial orifice. So that will actually be more counterproductive. That's something should have a take-home message.
Yeah, this is very important, and this is something that we should all be remembering in our daily practice.
It might actually transform into emergency need for surgery if you are draining that fluid immediately and post to gangrene.
I think for preoperative optimization, sometimes surgeons are, very hell-bound on correcting coagulation parameters and draining the fluid. And most of the time, this pressure is from the surgeon's side to perform all these procedures. Now, in this patient, another thing, during surgery, because though they are volume overloaded and they have plenty of fluid in the extracellular space, there is a state of systemic arterial vasodilation, so effective circulating volume is low. So managing fluid, both par and post-operative, is also important. And there comes the roles of anesthetist. I think you have kept a separate point for the role of anesthetist.
So as Dr. Akash mentioned that usually, yes sir.
Dr. Akash, what should be the dose of carbapenem? I mean, standard dosing, or do you have to reduce because his create is 1.9?
Yes, it would be a renal modified dosage.
One thing, I think this patient had strangulated hernia. If it was not strangulated, then what would you do? Because the challenge for us is, I have just lost a patient last week, a similar case. The ascites was reduced in another center. It became strangulated, it came. We could do nothing. And even with reducible hernias, they come back with ascites because in a resource-constrained setting, you cannot manage them ideally. So huge abdomen, umbilical hernias. I have been practicing hepatology since 2006 in my long career, which I can say that I have one. I have seen only one patient undergoing surgery because surgeon agreed. I have approached the top surgeons of the country.
They will never operate on a patient like this. They have 1001 logics, too much ascites, liver is too bad, low albumin, coagulopathy, we cannot do it. Number one challenge is the patient's relatives. They will not agree. If they agree, the surgeon will not agree. So that's the big challenge for people like us working there. But the issue is that for managing conservatively, where there's no surgery to offer, when it's reducible hernia, what I do is I reduce the ascitic fluid, whether I'm doing the right thing or not.
So when these patients comes to the emergency department, both hepatologists and surgeons goes and see them. The first thing the surgeons do is to try to see you can reduce the hernia. Because if you reduce the hernia, you solve the problem then and there. Actually, they don't need surgery. You can put a binder. Absolutely. After that, and that's the easier way.
And another thing is not only they won't agree. They will surgeons and anesthetists. They have a tendency to. I do apologize to any surgeons or anesthetists here, but they will usually prescribe a lot of FFPs or platelets to sort of correct the INR. So I think the panel will agree that INR just does not get corrected just because you're putting in 4 or 6 units of arbitrary units, n number of units of FFP. In fact, it is going to probably make the situation worse with transfusion-related lung injury, and a whole set of different set of cytokine storm is going to start because of that.
Since it's sort of an informal discussion to just stimulate more, I think there's a time has arisen that what Sir is also saying, we need to have a consensus on operating on these people early. If you don't have a transplant option, which is the truth with 80 to 90% of our population, you are just waiting for this to happen. And I think there is now good quality data that if your MELDs are not very high and your other parameters are not very high, you might well get away with doing this early than keeping it for late. I don't think there is India-centric data, but I think this is more of a challenge for us where transplants are limited, rather than at a center where you've got full access to transplants abroad, and we are not going for those surgeries to see what the actual outcomes is, and depending on data which fully comes from outside. So this, if you ask me, he could have been operated yesterday than when he presented today.
And to add to the confusion, a patient comes to me with compensated cirrhosis, have multiple small stones in the gallbladder, wants to know whether I can undergo surgery or not.
Yes, that's what I was coming to, that this is not only about an obstructed hernia. The patient can have an appendicitis, the patient can be asymptomatic with gallstones. So what do we do with that? So in a cirrhotic patient with ascites. So we do get patients with ascites, CLD, ascites, and multiple GB calculi. So do we wait for the pancreatitis to occur? Do we wait for the cholangitis to occur? Or do we straight away optimize the patient and go for elective surgery?
Again, many would say no chance for operation, wait for transplant. I think that's what a general rule is, unless there's a frank cholecystitis. But of late, I've had at least 6 such patients who have got operated. One had decompensation perioperatively, otherwise had very good post-operative course. So I think this is more of our, it's a block in our vision, which we need to go out of it and explore more. And we should forget about those things that if you have this advanced cirrhosis, you're doomed for life, nothing can happen to you, no surgeries, no other interventions. So we need to get off this thought block that's there. I don't know what the data will ultimately come out of randomized trials, but we at least need to proceed.
If we can move for the last question for this case, how do we ensure a smooth post-op recovery for this patient? Dr. Dinesh?
Yeah, I mean, this is obviously a teamwork. So how do we recover this patient? The main problem would be after surgery. One, what you need to know is whether any bowel segment have been removed or not. Because if the bowel segment have been resected, you have to keep the patient nil by mouth until the surgeon says, yes, go ahead and feed them nasogastrically or oral enteral feeding. So in that case, you have to switch to briefly TPN mode like that. So that is number one. So you need to know whether bowel segment has been resected or not. The second thing is, when you need to allow the wound to heal. Okay. So for that, you need to keep the ascitic drain for longer time. remember, these patients will continue to drain the ascites because it's a liver disease that's causing the ascites. So therefore, they will continue to drain the ascites. So pulling off the drain, abdominal drain, actually causes more reaccumulation, and then that can actually cause wound dehiscence and other issues. And also, so the nutrition and keeping the drain in, and gently add your beta blocker and your diuretic slowly once the creatinine turns to normal, and also replace them whenever the drain comes with 50% of the drain replacement, so that you're not overloading them. At the same time, you're just slowly correcting it. So it's a week process, or even 2 weeks it may take. Some patients just go home with the drain, like a colo bag, like that. So it has to drain. It should not accumulate rapidly. So that's one of the key issues in managing these patients post-operatively. At the same time, you should not over-diurese them to aggravate the kidney injury. So it's a very, very careful line that you have to follow in this situation, along with antibiotics and other measures.
And how will you monitor LFT in the post-op period? What would be your protocol?
See, when they are in the hospital, at least daily or twice a day, every alternate days like that. But once they go out, once they're in the outpatients, you can see them at least twice a week, mainly not even for the LFTs, but for the drain volume, the creatinine. If they drain too much, they end up in acute kidney injury. If you over-diurese them, they end up in acute kidney injury, and then you have to admit them. All these things are problematic. So usually what happens is they'll have two drains, the left and the right drain. So generally the surgeons recommend to remove the left drain first, and then the right drain. So slow, it's a very, very slow process. That's what I'm saying. Obviously improve the mobility, and of course monitor the LFTs. Very rarely they get worse, actually, if you do this protocol, actually.
Akash?
I think one, in addition, these are all the most important challenges Dinesh has already mentioned. One other particular is analgesia, post-operative analgesia. They've got a pain control. Again, there's a big reluctance to use paracetamol. So you don't want to even use paracetamol of 500 milligram. Again, there is no issues with using up to 2 grams of paracetamol in patients with cirrhosis. You're not going to do anything to that. Plus, the other issue that sometimes crops up is if you use analgesia and sedatives beyond paracetamol, there we perhaps need to be a little careful. You need to avoid constipation. You can't use too much of opioids because constipation, A, delays the overall recovery process. B, again, would precipitate to encephalopathy. PCA, patient-controlled analgesia, is possibly a good option in, according to the current ERAS protocols. And those need to be instituted so that we can ensure a quick release from the hospital.
Thank you, panelists, for this. I think we have got a...
I think, Saptarshi, in the post-operative period, the most challenging job is, and the question is when to remove the drain. Because once you remove the drain, there is a chance of seepage through the drain side. And that again invites complication and repeat procedures, maybe suture, all these things. That is an interesting part. So is there any role of post-operative albumin to overcome that?
As for general patients, means perioperative, post-operative albumin. So usually we see their albumin, if their levels are low, just like even a non-operative patients, building up their albumin not only helps to wound healing and all that is beneficial, but it also helps to mobilize the ascites faster. You would have to bring in diuretics early in these, otherwise they are not going to settle. Once the immediate post-operative period is over, is reaching around day 3, day 4, if it's not an infected ascites, it's time to bring in low-dose diuretics. Otherwise, we'll keep on that. Will, as Dinesh sir was saying, that this is not going to be a thing which is going to sort it out in 2-3 days. You have to be prepared that this is going to be a slow process, and albumin infusions would help to mobilize the ascites faster. But it takes time. It takes a lot of time to finally let those drains go and finally go home.
And another thing which Dr. Dinesh mentioned was the use of colo bags. So normally we don't use colo bags, but in these patients, I think it will be beneficial that once the drains are removed, because drains can be painful, and if the colo bags are left in place, they will be beneficial because they will cause less soakage, less number of bandages to be changed, and less cutaneous irritation. So I think colo bags, teaching the patient how to apply the colo bag at home is also part of the post-op recovery. So after this, we'll move on to the next clinical case. This is also about a cirrhotic patient, a 62-year-old female who is a known diabetic for 20 years, had upper GI bleed, that is the index decompensation of cirrhosis, about 2 years ago, was managed in the ICU where EVL was done. The bleed was poorly tolerated. The patient had an episode of encephalopathy after the bleed, but she recovered with conservative management in the ICU. So she was well with, on the OPD basis, she was treated with medications for the next 1.5 years, after which she was developed ascites and was started on diuretics. So presently she is, ascites is increasing and decreasing, and the diuretic doses are being titrated accordingly. Currently she complains of pruritus, insomnia, and bleeding per vaginum. Her physician referred her to gynecologist who started her on some hormonal therapy. Her labs show hemoglobin of 9.3, TLC is 6,400, platelets are 1.8 lakhs. Bilirubin is creeping a little bit on the higher side, 3.2. ALT, AST are 46 and 53. Albumin is 3.2. INR is 1.5. Sodium, potassium, creatinine are mostly preserved. USG shows mild ascites. There is no HCC or PVT. So by all accounts, this is just another run-of-the-mill cirrhotic patient, right? We all see these patients in our OPD. But what struck me and why I took her clinical history for today's presentation is the number of medicines which she was getting, the number of medicines in her prescription went from one page, then there was something written PTO, and then it was continued on the other side. Like, you know, we write so much in the exams and hoping to get good marks. So it was like this in her prescription. All that could be done to make her better have been done to make her better. Like, she's getting 15 drug formulations, and I calculated she's taking 19 tablets or capsules per day, along with 2 sachets and 1 vial of syrup, lactulose, which she's taking thrice a day. So this is the amount of effort that she has to put into taking her medications. I calculated it by asking our pharmacist to give me a rundown of a dummy bill if the patient is to buy these prescriptions from the pharmacy. And it was calculated the patient is having a daily cost of around rupees 860 every day. And the monthly cost, as you can see, if you multiply it by 30, it comes around to 26,000. So my question to the panel is, how will you rationalize this prescription? If you like, you can use it like a scoring card of downright harmful to extremely useful. So these are the medicines that the patient is getting. Glimepiride, metformin for sugar, spironolactone, furosemide for ascites, carvedilol for prophylaxis, rifaximin, lactulose, and L-ornithine L-aspartate sachet for as prophylaxis against encephalopathy. She has a low hemoglobin. She's getting ferrous iron preparation. Calcium multivitamin is there. UDCA is there for, I don't know, for the bilirubin or for maybe the pruritus. Levocetirizine is also there for the pruritus. Zolpidem is there for insomnia. And norethistron was started by the gynecologist for her bleeding per vaginum. I think this is going to take a little time for us.
So it's not unusual, and I think a pharmacist is actually quite cheap. This might actually more than that amount. It would go up to more than 40,000 rupees.
And fortunately,
this is after 12% discount.
Unfortunately, she is getting glimepiride and metformin, which are cheaper drugs. Most of the patients nowadays
they go to dapagliflozin and
newer drugs which are quite costly.
So let's start from the core drugs maybe. So she has ascites, I think furosemide, spironolactone combination. I don't know what was her previous state of ascites, but again, if you can switch on to a monotherapy, either combination of isolated spironolactone, and if it controls it, again saves some cost. So that's number one. Carvedilol, she has varices. So for prevention of further decompensation, current data with Predesky and all, okay, the carvedilol is rational. I am not sure why she's on rifaximin. She had only one GI bleed precipitated HE. That is
2 years. That was 2 years ago.
That was 2 years ago. So rifaximin goes off this list. There is no indication of any rifaximin. Rifaximin is only for those who develop either intolerant to lactulose or who develop overt HE on lactulose. So it goes out. even lactulose, her last HE was 2 years back. So there is a subgroup now where if your liver disease is well compensated, but I think her bilirubin is around 3.
3.2.
So, okay, so I think we'll have to, because, and she's not sarcopenic or anything.
No, she's not sarcopenic.
Non-sarcopenic.
Not grossly sarcopenic.
So there is a subgroup, may not apply to this case. So subgroup in which, if the patient is not very sarcopenic, functions are very stable, you can even, and has one single precipitated HE, you can think of taking them off lactulose also. It doesn't always mean that one started on lactulose means lifelong lactulose. LOLA, there's no role. Absolutely no role. Ferrous ascorbate, we don't know what is the cause of her anemia. She has a bleeding PV, but whether it is iron deficient, not iron deficient, we're not sure. We should work that up first. Calcium.
And Akash, if I can summarize this for the audience. So what you mentioned, you just took the bull by the proverbial horns, that what we do is we write it by like rote memory. HE, there's some mention of HE, and we start writing these 3 medicines like that. So this is something, this practice, we should not be following it blindly. Rifaximin has got a particular, should be given only for particular patients, as Dr. Akash mentioned. So hepatic encephalopathy does not have a like one-size-fits-all therapy. Like the patient with encephalopathy comes and you roll out 3 medicines. I think this, we should move away from this practice. And as Dr. Akash mentioned, that L-ornithine L-aspartate really doesn't have any role, so we really should be underlining that. And as you mentioned, that a patient with cirrhosis with anemia, we should not start immediately with iron supplementation. We should at least make some efforts to finding out what is the cause of anemia. Of course, in this patient, the patient had some bleeding PV that might have contributed to some iron deficiency anemia. But at least before starting oral iron, we should check the iron status first, iron parameters first.
So if you ask me, I'll go with Akash that I'll combine spironolactone fusamide, 1 tablet. Carvedal, I'm not sure whether I'll add or not because the patient has ascites. So child policy, I'll probably go for propranolol. Rifaximin doesn't stand a chance. Lactulose, I would perhaps as prescribed, but I'll specifically mention that only if she has constipation. It's not a regular thing that should be taking. Lola will not be there. If I find or assess that she has, subclinical encephalopathy, can't remember exactly, then I may prescribe probiotics, but not neither of these. Ferrous ascorbate, calcium, multivitamins are not prescribed. I'm a great fan of Woodka, but not in this case. I prescribe UDCA when I see some raised ALT for some reason. That's a wonder drug, I think. ALT, due to any reason, you want to bring it down quickly, that is UDCA, but not for bilirubin, not in this case, of course not. And the sedative, I would only write that if she has serious problems, then I try to explain to her that she should not be taking it, but in cases where she has to reduce dose maybe. That's what my advice would be.
Can I add a little bit more to what they both said? Usually when patients have decompensated cirrhosis, when they have ascites, generally they don't require so many anti-diabetic drugs. So generally because glycogen is stored in the liver, they may not require diabetic drugs as well, because if you notice their HbA1c become normal, a lot of patients comes and tells us, I'm no longer diabetic. That's a very common statement. So even you can take off that and then monitor the blood sugar. If it goes high, then we can always add like that. So
but conjunction, is this an ideal? Suppose a patient, a cirrhotic patient, his sugars are still high. Is this an ideal combination OHA for a cirrhotic patient?
See, cirrhotic patients with high sugar, ultimately they end up in insulin, if you ask me. But metformin is not a bad choice. It's actually still a decent choice. But obviously, you need to look out for any long-term complications like that. If they become septic, the lactate may go up like that. Well, otherwise, I'm okay with that. But yeah, as both of them said, like you can club the diuretics. Carvedilol, yes. Rifaximin, no. Lactulose, SOS. If they become, develop constipated. Other, iron supplements, calcium and all. Calcium, yes, it depends, if they have evidence of bone weakness, things like that, you can add. Multivitamin, Yes, but UDCA no, cetirizine no, zolpidem no, norethistron I'm not sure actually whether what is the reason for the PB bleed.
Bleeding.
That's right. What's the reason?
Some thickened endometrium was seen in the.
Yeah. So I'm not sure about that. What do you think?
And with this bilirubin, I'll be very, very wary of giving a norethistron. You're calling for
how long? See, sometimes they may just give for 4 or 5 days and stop it off.
Yeah, this was continued for over a month. So I think because even normal patients.
What was the duration of diabetes?
20 years, sir.
20 years. So sulfonylureas usually don't work beyond 5 years. They're very good drug for 5 years. And if you give in decompensated disease because the patient develop ascites, there is a higher risk of hypoglycemia. I think we should consider replacing the first drug, glimepiride, with either linagliptin or vildagliptin. Linag is costly. Vilda is relatively cheap. Metformin, I think we can keep unless you are seriously considering of switching over altogether to insulin at this stage. Zolpidem, I think the most rational part of this prescription is perhaps zolpidem because at least the patient was not prescribed a benzodiazepine. But I have serious doubt about this sleep-inducing property or potency of zolpidem, which is a very low potency drug. And norethistron, if is given, I think it should be given for a very short period of time because controlling the vaginal bleeding symptoms is also important. At the same time, addressing the insomnia, which significantly affects the quality of life, is also important.
I'm not sure whether we have zolpidem in Bangladesh. Do we have it? I think we don't. In that case, what will be the sedative of choice me for such a patient? Because patients keep on forcing. I go for midazolam, but am I right or wrong?
So I'll just add into this. One thing we have, I think, missed out on this is that, see, she's getting these medicines because she's not sleeping. She's not sleeping possibly because she's itching. So you need to address the itching first because this is a very important complication for many patients with cirrhosis. We don't pay attention to these quality of life parameters. So we need to address why is she itching. She was on UDCA. I don't know whether she has PBC or not. If she has PBC cirrhosis, she definitely mandates UDCA. So we need to find out. They have got multiple causes of itching, dry skins, some develop eczemas. So we need to involve our dermatology colleagues. Sometimes they come up with...
It can be a peripheral neuropathy also.
It can be a peripheral neuropathy. So we need to find and address why she's itching and address both the itching and the sleep together.
If Akash, it is an idiopathic pruritus, if you don't find, so what would be your choice on ideal antipruritic?
Not to forget, even iron supplements, iron tablets can cause itching.
Can cause itching.
Antidiabetics can cause itching by themselves. So in this regard, only problem is with safety. I would rather opt for something like naltrexone, which has two modalities of action, A, to control the itching, plus a mild sedative action, which might help her with her sleep also. But she's already child B. The naltrexone safety data is in child A.
Yeah, that's right. Yeah. So if the itching is because of liver disease, probably you'd be better off adding cholestyramine rather than, naltrexone is probably a little bit on the, little risky in this scenario. So I would go with cholestyramine if this is because of liver disease. If it's not, then we need to evaluate. Yeah.
And what would you think of adding rifampicin or sartralin to this for this patient? For the controlling
no, but sertraline, again, it's a child's B. I would be very careful with that, yeah.
Child B becomes a problem with most of these drugs. But again, the pharmacokinetic data is not very strong. Again, one thing is that she's been on this norethistron for, I don't know, the rising bilirubin, why it is high, because this 3 bilirubin is not a conventional stable cirrhotic bilirubin. Either she's got some pathology which is going on, or this is drugs which is causing the liver disease to worsen.
But usually, Akash, with norethistron, it's mostly a cholestatic hepatitis. It's a more enzymes rise to about 700, 800.
If your liver is already cirrhotic, you might not have that enzyme elevation and maybe only bilirubin increments. So we need to find out on those parts, but we really need to rationalize this prescription.
And if there was no pruritus, if the patient is complaining only of insomnia, what should we do? I think we can ask our audience also. So what do you do in your practice, sir? For cirrhotic patients who are complaining of...
Just I want to know about the role of this natural hormone which induces sleep or helps us in sleeping, melatonin.
Yeah,
the melatonin spray is available.
That's
so that will be safer, I think, that physiological, increasing the level of melatonin.
I think melatonin is a good option. I think this may be one of the things which would add into this. I think the where we are really lacking in good quality data is when we forget these very important parts. We are all focused on ascites, bleed, hepatic encephalopathy, but these day-to-day challenges of a patient with cirrhosis is something which is very strange. You'll hardly find good quality randomized trials in these patients. Hardly. There was one naltrexone trial, I think, from ILBS, which got, there's a lot of controversy with it.
Yeah, and to add to the confusion, I have got an anecdotal data of my own. I thought that it would be rational to give melatonin, so I added melatonin. The patient landed in HE after 1 week. So after that, I'm really scared. So really, we don't have, because I don't have any data to back me up, right? So if I give melatonin and the patient lands up in HE, goes into the ventilator, where do I stand? So this thought is always in the back of my mind. Just one last question from this clinical case.
I'll just add in, I think, one point, because I think we were discussing anti-diabetics. He's already decompensated child B, so I think the evidence is only right now with metformin. Even gliptins don't have it. Vildagliptin actually has a hepatotoxicity insert profile in it, so I'll avoid Vilda. Lina is possibly okay, and glimepiride off. I think there is ripaclinide. Ripaclinide is not available, I think, out here. Okay, but is it available in India? Okay. So I have never used it. So never used it.
Ripaclinide is very safe. It has no hepatotoxicity.
Linagliptin, right?
Lina
is no hepatitis.
Ripaclinide, what you say.
Okay.
But it decreases hemoglobin A1C just by 0.5%. It's very low potency. Yes.
Thank you for nice case. I have a question regarding this case. This patient has presented with PV bleeding as well. So how will we address PV bleeding of this patient, and how should we manage this PV bleeding? Thank you.
And I'll add two questions. What is the safest sedative for her and antihistamine for her? In a situation where we have only one company manufacturing oxazepam in Bangladesh, very poor supply, is in that scenario midazolam is the safest or not? What is the safest antihistamine, and how to manage the bleeding?
See, for pruritus, you can still use topical aloe vera and all those things. Never to forget, traditional coconut oil. So you can't find evidence for all those, but it's a general measure that we always encourage, because a lot of cirrhotics have dry skin, so that should be addressed as well. With regards to PV bleed, we need to really know why she's bleeding actually. Most of them, when they go to gynecologists, they end up prescribing tranexamic acid. So that's again 2-3 days course, so you should be very careful with those drugs at this stage of liver disease. So we really need to know, is this a transient thing, or is it going to be hormonal change, or is this something else she's growing in the uterus? So we need to know really actually.
So we'll move on to the last question for this case. As I mentioned at the beginning, I put this case just to bring to the forefront that prescribing a safe prescription in cirrhotic patient is really a challenge. We sometimes prescribe it in a hurry. We just make a list of prescriptions or just write continue all. But I think each and every medicine we write for a cirrhotic patient should carry a weight of our thoughts and our deliberations behind it. To the panelists, my last question is, in general, what would you do to decrease the daily medical expense of cirrhotic patients? Because they're usually under a lot of financial burden, repeated hospitalizations, albumin costs are going up every day. So what small things would you do to, like as you said, say in preventive hepatology, so what would you do to decrease the daily medical expenses for cirrhotic patients?
I think yesterday I had raised this point where we don't focus at all is caregiver education. Patient caregivers are the first point who are looking after them every day. They need to be educated that this is a chronic disease. There will be ups and downs. How do you recognize these symptoms so that you don't come to an hospital in an advanced emergency? There are subtle signs of hepatic encephalopathy, of worsening renal functions, which caregivers have to, and you have to also look for other things. These tend to fall. They have forgetfulness. They'll never remember these medicines. So caregiver medication or caregiver education, with a lot of time, which consumes a lot of time, is a big underdone area in our daily counseling. So that's one thing which can prevent known complications or sudden complications. If you take that along, that can reduce the overall costs of that care. Because we know one hospitalization with cirrhosis with a complication, it disrupts that entire balance.
I would say focus on nutrition. That's
Yes,
very, very
absolutely, sir.
important.
Absolutely, sir.
Focus on physical activity, because most of our Indian population or even Bangladeshi, they just become bed-bound. You know, they won't walk outside. It's very important to keep yourself physically active for your muscle, to maintain muscle mass, and also adherence to medications. So these three things, I would say, definitely, I reiterate every time patients come to the outpatients, and it goes a long way.
And I also think we should get them vaccinated against pneumonia and influenza. This is something we sometimes miss in our daily rush, but I think vaccinating them against at least pneumonia and influenza will prevent some hospitalizations. Thank you so much. Let us move on to the third case. A 48-year-old male is an accountant by profession. He presented with dyspepsia and bloating, no addictions. He was started on PPI and other general medicines. On examination, he had a weight of 102 kilogram. BMI was 33.3. Waist circumference was 95 centimeter. Blood pressure was 140 by 92. Abdominal examination, liver was palpable, 1 centimeter. Labs hemoglobin was 14.1, platelet was 2.83. Cholesterol was 243, triglyceride was 339. LDL was 181. Fasting blood glucose was 190. PPBG, sorry, I forgot, it got omitted here. It was around 270. HbA1c was 8.9%. Bilirubin was 1.5. ALT, AST was 197 and 102. Albumin was 4.4. Viral autoimmune markers were negative. Ceruloplasmin was 26. Liver stiffness was 13.6. CAP value was 315. Liver biopsy had been done for the raised liver enzymes, showed macrovesicular steatosis, lobular inflammation, hepatocyte ballooning, and perivenular and perisinusoidal fibrosis, as you can see here. Dr. Chaudhary is here, so I'll start the first question. Please, sir, please do.
It's nice to be a student facing an examiner for a change after 40 years. So go ahead. You're the examiner today.
So what would be in this patient is a middle-aged male who is obese, who is newly diagnosed diabetic and dyslipidemic, who has got non-alcoholic steatohepatitis with some amount of fibrosis. So if he comes to you for treatment, what would be your primary pharmacotherapy target? Will you target his sugar? Will you target his lipids, the liver fat, the liver enzymes, or will you go after the liver fibrosis at the beginning?
Okay, so some of you might have been here in the morning, some have not. See, this is a perfect example of where you have to have a biopsychosocial approach and a comprehensive approach. You can't say I will tackle one first and then the other. They're all interrelated, okay? So in my day-to-day practice, see, one is of course pharmacotherapy. More important than that, I'll first talk to him to understand his motivation levels. What background does he come from? Does he understand that he is grossly overweight? Is he depressed? Why has he not been looking after his weight? Is he into some indulgences? How much is he willing to change? Okay. So first and foremost, I think, is that, and looking at his psychosocial factors. Obviously, there is going to be a combination of lifestyle issues. There will be diet, so a good dietitian. There will be somebody who would encourage and motivate. You know, what we write is exercise 60 minutes a day. Nobody follows it, you know that. So unless we are more specific as to what exactly he can start doing from tomorrow, is he likely to be a gym goer? Is he likely to get back to squash or a badminton? Or, you know, what else can he actually think of doing? He's not that old, you know. And then how willing is he to follow a diet? And then, of course, with regard to the medications, it's very clear. He will require maybe some medications for sugar, some medication for his liver fat. Now, which one, we can go into endless debate about it, but the safest option would be to start with at least a vitamin E. If suppose, if you ask me, I am really a little fond of saroglitazar at this stage. If the person is very keen to lose weight and has been trying but he hasn't, I wouldn't actually mind, and depending on his resources, of going to the next step of semaglutide, okay, the GLP-1s, okay. With regard to the rest of it, I think that much of it, I think in 1 month or so, if he is willing to follow a lifestyle, many things will come down. His cholesterol triglyceride will partly get, at least the triglyceride with saroglitazar. If suppose he's very keen on his cholesterol being managed, suddenly a statin could be added, but I'm not keen on adding too many medicines. With regard to the medicines, I heard the discussion with glimepiride just a while ago with the previous case. It's okay, but by and large, the two safest medicines which help in liver disorder and in diabetes are SGLT2 inhibitors and the GLP-1s and insulin. Last case, of course, I thought that, because he has been in encephalopathy on and off, I came in late, so whether there has been a discussion around insulin. Huh? Because that I thought was a good option if the question only is motivating, because then his muscle mass would grow, as he was talking about, he will feel better, and overall the response is far better. You need to be less restrictive on diet. And of all the medicines which you listed in the last patient, sorry to come back, the most expensive one was actually Lola.
Yes, sir.
And Lola on a long term, I know some patients do require it, but it's enormously expensive, especially if you give the sachet. And if you give the tablet, it doesn't work. So I would much rather bank on rifaximin and lactulose rather than Lola.
And I checked, it was costing around 500 rupees per day.
Yeah, it's huge, huge. So that's what I would do here. With regard to the FibroScan value, I have a difference of opinion with you. You use the word fibrosis. I have burnt my fingers many times, and I think it basically tells you liver stiffness. And I've seen a lot of patients who have been able to bring down their LSM score. One of them brought it down from 19 to 9 just by weight reduction. Doesn't happen in everybody. Here, of course, you managed to do a liver biopsy. I was wondering why. Because, the rest of my management would not have required a liver biopsy because it was pretty obvious. But nevertheless, since you have it, LSM means only liver stiffness, maybe fibrosis. But even if there is fibrosis, it's partly reversible. So I would look at it in a very positive way in a young person and go forward. Any other questions which you want me to specifically address?
No, sir. This was the first question, sir. So what do you think, this as gastroenterologists or hepatologists, should we manage the diabetes ourselves or should we rope in the endocrinology colleagues?
I would send him to a diabetologist whom I trust. Because I'll tell you what happens I have two types of practice, one in Lucknow, one in Fortis. In Fortis, the diabetologist knows my preferences of drugs. So it's a bit easy. In Lucknow, if it is any unknown diabetologist, he may not be aware of the fact that in liver disease, you need to avoid certain drugs, especially sulfonylureas and to some extent metformin. Metformin, there can be a debate. But that's the issue. But if the person is on the same wavelength as me, it makes it much easier. There was a hot debate this time in our NAFLD conclave, and there is a lot of patients or doctors now thinking that, at least they should be willing to be able to prescribe SGLT2 inhibitors and GLP-1s. I do in a while, once in a while. And for your information, SGLT2 is now a part of the prescription of cardiologists for cardiac failure. So it's no big deal.
For nephrologists also.
Yeah, and because the main issue is that these two group of medicines do not produce hypoglycemia. You see, the earlier fear was only about causing hypoglycemia. So those would be my perspectives. But in Fortis, because these are very paying patients, they want everything to be done by specialists, so I would get them rotated through all the respective departments and pay money to each consultant, just for their safe, comfort zone. But I would be able to happily manage it myself. Yes, sir, you wanted to ask something.
When you were sitting by the side of me, I wanted to raise this question. Because we are the general practitioner practicing medicine. We do come across with multi-speciality prescriptions. But we find that referring to the diabetologist. He has written a prescription. You have gone to the nephrologist. He has written some medicines. And to the physicians, so-called cardiologist, he is writing some prescription. So when the multi-speciality is coming on treating a patient, this is a burning question is coming to our mind, is what to do. When you go to the cardiologist, he doesn't look into the hepatologist prescription. When you go to the general physician, that is the burden come on us. Out of sympathy or out of gratitude, we go. I ask the patient to bring all types of prescriptions. And amazingly, I have seen that cardiologist has prescribed the medicine, nephrologist also, in the other name the prescription has come. So there is a repetition of the medicines. And how to approach to this problem?
Very simple. You know, the first section of my book, Health Adda, it carries a chapter on the physician's role. Please read it. There are 2 chapters. My first question to you is, who owns the patient? Is it the family physician, that is, you for instance, or is it the cardiologist or nephrologist? See, these are multiple specialists who have been referred to for opinion. But the person who is going to hold his hand and be with him and monitor him is the physician. See, why often people go to a specialist is usually for a second opinion. Sometimes the specialist makes the mistake of kind of making the patient hang on. But I actually encourage them to go back to the physician, because ultimately you're the one who's going to balance all of them. If the patient dies, he will blame you. If he is happy, he will be happy with you. So you have to take the onus and responsibility. We are only there to advise you. Unless it's a very challenging, technically very advanced situation where, say, a liver transplant fellow is doing a transplant, obviously he has to take ownership.
No, nobody should be blamed about it, because the people are so conscious now. If they have some little problem with the kidney, they ask us, why don't you send me to the nephrologist? Why don't you send me to the cardiologist? Why you don't send me to the gastroenterologist or hepatologist? We are bound to do this, otherwise he might claim certain bad things on us.
I would certainly send if I were in your shoes. But your role is to act as the filter, the final filter.
Right.
So that is where you have to actually tell him that, look, in my view, these 2 are contradictory, these 2 are repetitive, and in order to reduce the load of medicines, as he very rightly talked about, I think that these would be the ones, and these 5, which I am omitting, can be managed by lifestyle issues. Say salt restriction, diabetes, weight loss, and so on and so forth. That's what I would do.
So in this regard, my approach is probably correct. I ask them to bring all the prescriptions, then it takes time for me, though even I think it is a great relief for the patient. Thank you.
Time is the main issue. Our main issue is that we are constrained for time. Otherwise, as a responsible doctor, our primary responsibility is a good patient's outcome. But somehow in this web of time constraint, we tend to miss it. I'll just add one thing on this fibroscan, because I think there are lots of students and others. I'll be a little wary about this fibroscan given his BMI of 33. Fibroscan and these BMIs tend to be falsely high. And what Sir just says that rather the reflection or the message to them, okay, you've got a scan which measures your stiffness. It appears your liver is a little stiff. Let us see how it moves. Many one of them actually have not even close to 12, 13. They would have actually 6. If you do an MR elastography, it turns out to be normal. Then they get more confused it is what's happening. So give them some time. They lose weight. Only by losing the weight, we don't know whether the fibroscan value changed or the fibrosis changed, but whatever changed, the values tend to go down, and then they become happy. They should see the positive outlook on their face. So I think putting it as...
It's not only the fibrosis, some amount of inflammation will also contribute to it. And I think the message for all of us, as Akash and Sir just said, that fibroscan is not the speaker of truth all times. It should be taken with a pinch of salt, with a pinch of caution. And it is not even like a static thing. It's a dynamic parameter. We should see it how it moves over time, and before we label a patient so and so on his forehead.
So one other important issue is here. He has NASH, he has perisinusoidal fibrosis. for NASH to cause cirrhosis, liver failure, it has another 20 years probably if he's not working on it. But we need to talk to them about cardiovascular risk. So often missed in most places actually. So we need to emphasize that he's not going to die of liver disease, but he may die of heart attack. So I think that we need to bring in at some point. All this lifestyle changes, drugs will change that perspective.
I think you just pointed out what this tunnel of super specialty does to us. It makes our view into a tunnel view. So we see only the liver, we miss the heart, we miss the kidneys, we miss the brain.
I think basic things like ACVD.
Do you think this bariatric surgery can address most of the issues here?
As bariatric surgeons say, the most important thing is not only doing the bariatric surgery, but with the motivation, how willing they are to move forward with the lifestyle modifications. Otherwise, just doing an expensive, you don't even need a bariatric surgery. Nowadays you can do endobariatrics. But a costly procedure, a complicated procedure, a rare procedure you do. But if you don't adhere to the lifestyle, if you don't adhere to the diet, there's a high failure rate of bariatric procedures. More than 50-60% end up in failure because the patient is not motivated. Probably because we have not assessed the patient at the very beginning, as Professor Chaudhary was saying, that we need to assess the patient, how willing they are to adhere to these procedures.
I'll just make 2 comments for physicians here. You know, you must take down the numbers of your successful patients who are going to campaign for you. So I have generally a list of about 5 patients who have lost tremendous amount of weight and brought their scores down. Okay, and I asked their permission that, do you mind if I put somebody in touch with you, you can motivate them. You know, interestingly, if a patient has been through the whole journey, and one of them, he lost weight from 120, brought it down to 76, and his liver became perfectly normal. I had told the fellow that, you know, do you mind telling other people how you did it? Just tell how you did it. And that's much more motivating than what the doctor can do. So that is one thing I would recommend all of you to do. So keep your success stories and their phone numbers ready with you. That's very important. And the second is with regard to bariatrics. There are 2 issues. Bariatric surgery was actually very useful. In fact, if you look at the data of reversal of liver fat with any therapy, it was basically bariatric surgery. The problem is now there are other ways of managing weight. So a lot of my international patients don't want the surgery, but they want a gastric balloon. Which is not that great, but you know, it's at least offers reversibility, which is pretty good, but it's expensive. And now with this Ribelsus and Wegovy all over the place, your Ozempic, so now a lot of people who can afford, they're actually going in for it. And within 3 months, they would be losing at least about 6 to 8 kgs minimum. The problem is only the cost. And in all of them, ultimately what you're doing is you're restricting eating anyway.
I think we may be going into an era where bariatrics is going to be restricted to GLP non-responders. So because with we don't have tirzanol yet, those, you got a SUVA trial which came out, those are unbelievable results, which is at par with bariatrics. Just wanted to add thing as we were discussing. I think we miss out on simple things like an ASCVD risk. We miss out on things like an EGFR, because it's not only the liver disease, it's going to have his cardiac, his renal health, his cardiac health. So, but we hardly, again, that constraint of time comes in. We don't, like we were considering statins for him. There are many who are on statins from many sources where statins had no indications. And they have been on statins, ecospirin is one more. They have been on that for ages and ages. But we don't take out the time to recalculate their ASCVD risk, see how their EGFRs are progressing, and adjust those things.
Just 2 comments. One is on the FibroScan. What is the role of CAP? To me, it's very important in motivating a patient. Sometimes CAP goes up, patients think that they are not compliant. Sometimes comes down, they think it's encouraging. So that is my way of using the CAP value of FibroScan. Another thing is what was just discussed, whether we should routinely look for ischemic heart disease, risk of stroke, like a duplex ultrasound of the carotid vessels, and EGFR in such patients or not.
Dr. Chaudhary, what is your protocol for how do you introduce saroglitazar? How long do you use it? And how do you decide whether enough, if you have used saroglitazar for enough time, let's stop it now? So how do you decide on these things?
So saroglitazar, the two things I must tell you is that I found it to be very safe. Because many of them, they have been taking it for 1.5 to 2 years. It's a PPAR, alpha gamma agonist. So it's pretty good. Does it have a dramatic effect? The answer is it's not dramatic. It's slow. But within almost about 6 weeks to 3 months, you find that the liver enzymes and the triglycerides have started settling. So that's very encouraging to the patient. At least she feels things are getting better. You can't give it short term because it corrects metabolism. So for those of you who are not aware, so the same salt was initially used only for diabetic dyslipidemia. Now it has come to fatty liver management, initially diabetic fatty liver, and now for the MASLD group. Overall, I find it safe. The only two issues about saroglitazar, studies have not shown that it reverses fibrosis. So if there is significant fibrosis which is not getting reversed by weight reduction and other methods, then obviously you have to think of something different, if at all you can have something different. So that's where the limitation comes. And we were obviously all of us were hopeful about obeticholic acid, which somehow didn't quite come through. The recognition didn't come from FDA. I'm somehow surprised from Mamun's prescription that in Bangladesh it's still very popular. Every person who comes from Bangladesh is taking OCA. And when I hesitatingly actually started a few on OCA, I actually found the results to be good. But the fact of the matter is I don't know why it failed the FDA regulatory test. So it's still available in our country. Once in a while we do use it. So that's where we are. I think that there's no point in discussing resmetirom at this point in time because it's just been launched. Extremely expensive. So I think we'll have to wait and watch and see when it comes to the Indian market.
If we target liver fibrosis in a fatty liver patient, other than lifestyle modification, patients often like to have a drug. So, although there's nothing US FDA approved except one, and that also I think was, to my understanding, was given a fast track approval. I don't know if there's enough data or not. There's a resmetirom. I think it's a bit hasty decision. I'm not the right one to judge, but again, what will be the drug that I may not be malpracticing?
You should understand, FDA is all not clean.
If when I see Mamun, your patients coming to me with who is taking OCA, I don't stop it. I only say that, look, in India, I find it a little difficult to start OCA, although my diabetologist, one of them, Anup Mishra, is very fond of it. But the problem is that I'm at least in a position where people can point fingers. So I have to be a bit on the right side of, so to say, guidelines. So that's where my challenge comes in.
What I do, sir, is when a patient has diabetes and wants a drug, OCA is a drug for me, and I think that reduces fibrosis most. Now, if someone has a high TG level and has fatty liver, I'll go for saroglitazar. Now, if someone is very obese, so semaglutide, tirzepatide are my options. So that is how I do my prescriptions.
So with obeticholic acid, how often have you seen pruritus? I've seen
many, and I tell my patients routinely that if you have itching, stop it.
Stop it, yeah.
I've seen one patient.
Many patients.
Many patients. We have seen many patients. And if you compare vitamin E, saroglitazar and obeticholic acid, what is my personal experience that fibrosis bringing down, perhaps obeticholic acid is the best drug. But somehow this is not approved. Indian INSL guidelines does not suggest it. They suggest these three drugs. But it's very good to bring down fibrosis.
Yeah. But obeticholic acid, when I use it also, I use it in a much smaller dose than what is recommended. I mean, I use what you might call a homeopathic dose, but the fact of the matter is it works. And I think I just need enough, because that Western data, it's a pretty heavy dose here. And pruritus and other problems are going to be much more. With regard to the other side effect of OCA, that is, the increase in the lipid part, that is actually not so much of a problem because, you can always co-prescribe a lipid lowering agent. But main issue is pruritus, so far as I'm concerned.
So do you ever combine saroglitazar with vitamin E?
Yes, I do. In fact, you know what? See, this is something which I think our physician community needs to understand. Whenever they're trying a medicine for FDA approval, they have to try only that medicine. They can't combine it with a drug. But practical sense after a while tells you that, if you have two of them and they don't seem to contradict each other, there is no harm in trying it. So many of them I would start with vitamin E. If they're not getting better, instead of stopping vitamin E and adding saroglitazide, I would just add saroglitazide. And I have no model qualms on that.
Now I think we have some data. I think this year there's a IGMC Shimla randomized trial, biopsy proven, which has shown saro plus vitamin E data. I'll just add in on one thing is that we are not going to biopsy patients. So we're not going to biopsy. So there is some suggestion. I think if you see this time's EASL Congress or Dr. Sanyal's yesterday's presentation, we started including even F1s in trials. That is where we are going because we have to move on to surrogate markers. What we don't know is how much of that LSM change or fibroscan change is significant. The suggestion for 30% MRE of 0.75. But we have to further go into this, and more we see patients, because it is ultimately going to happen that if your fibroscan changed by this amount, and in the long run the patient never had any event or development of further worsening, that gives you the best evidence that forget about what the biopsy said. This amount, if it comes down, and follow up if he has never developed a complication or even worsening, that sorts out the story. And this can be generated from, there's no better place than India to generate these data, but we just have to be more systematic in the way we collect those data.
Dr. Mamun, do you use saroglitazide in Bangladesh? Yes. What is your experience with saroglitazide?
I will agree with Professor Chaudhary that it works slowly. To me, obeticholic acid is the most risky and the most and the best drug because it has the most dramatic effect. But itching is a big problem. I have to add to that. I have tried both oral and injectable semaglutide. I don't think the oral form works too well and becomes too expensive. Tirzepatide I have started using. I was very against injections. I thought that was a diabetologist thing to do. Why I should be prescribing injectables, but now with tirzepatide, with no oral option, I have started that. So we have, except resmetirom, we have everything in Bangladesh. Resmetirom is coming next month. I think as of now, obeticholic is the best. Saroglitazide is not, that effective one.
Thank you, panelists, for this wonderful and stimulating discussion. We do have yet another case. Dr. Bhomik, do we have time? Sure. So this guy is a 26-year-old male. He's a phlebotomist by profession. He had jaundice for 10 days, progressive, painless, pruritus was present. He had multiple episodes of occupational exposure in the form of needle stick injury, but he never followed up either on his own testing or with regard to the patient's virological status, and consequently, he never took any post-exposure prophylaxis. On physical examination, he was having icterus, there was no organomegaly, and there was no stigmata of CLD. Investigations, bilirubin was 18.6, ALT and AST was 251 and 263, albumin was 3.7, hepatitis A and E IgMs were negative, HBsAg was positive. Further workup on HBsAg, it showed that E antigen was negative, anti-HB was positive, anti-HBc IgM was negative, and hepatitis B DNA was 2,410. Ultrasound showed liver margin smooth, gallbladder wall thickened, and there was some small periportal lymph nodes. I included this case because this is a very common scenario that we all face. I'm sure you must be facing it in Tripura also, that this is a common clinical occurrence. So I'll go straight into the matter. I'll ask the panelists, how do we reliably differentiate Hep B-related acute viral hepatitis from chronic Hep B flare? Akash, will you?
So difficult entities to determine. First is your clinical scenario. What is this patient getting recurrently exposed? Does he have a frequent recent exposure? Does he have history of chronic disease? How long have he had hepatitis B from before? those clinical parameters, your physical examination signs of whether there is any evidence of chronicity or not. And then comes often talked about laboratory values, which you showed some of those values, which is one of is your IgM, which if it is positive, specifically with the signal cutoff that is mentioned, it is more in favor of an acute viral hepatitis B. Second, if your DNA levels are very high, that is more than 5 logs, or in some 6 log, then it is more favor in form of a reactivation of chronic hepatitis B. E antigen has also been shown that obviously if E antigen negativity or positivity, if it is more positive, it favors that. It might be an AVHP. The one study shows that if you have a lower albumin levels, which again indicate towards chronicity, that may be also one of the indicators. And then again, you have got telltale signs of fibrosis, which is very difficult. But the problem is, these never come together. Just like in your case, it has not come together. Your IgM is negative, and your BDNAs are just 2040. So this is the common scenario. And you have a bilirubin, which is 8. So these are good for differentiating, but till date, except you do a biopsy, and if you see fibrosis, which is due to hepatitis B and not due to NASH or any other etiology, fibroscans will not help. Your bilirubin is above 18, your enzymes are very high. So if it is negative also, it just tells you that there is no fibroscan fibrosis. You might still have a chronic disease. So this is where the dilemmas are, but those are the points. First, your clinical presentation, next your laboratory values, and then your overall picture.
Okay, so we don't have a single magic marker which will reliably differentiate this.
I hope it's a true case.
Yes, sir. It
So I'll tell you what are the odd points. Very difficult case. You see, if it's acute hepatitis, viral, whatever be the cause, having pruritus in the first 10 days is very unusual. It comes much later, after the second week. So that's a bit unusual, number one. If pruritus comes so early, and the hepatitis B is there, but I wouldn't ignore the fact that it could actually be a red herring also. And therefore, dig a little deeper into any other infections or any drug-induced liver injury, particularly if he has been taking some herbals. So that's the second point. Third issue is that it's easier to decide how to treat him than to how to get to the diagnosis. So I would obviously give him an antiviral to be on the safe side. Tenofovir, alphenamide would be my choice, but anyway, ordinary tenofovir would be fine. And a bile acid excreting agent like ursodeoxycholic acid, which I am sure he being a medical fellow would also know the value of, and he'll be happy to take it. With regard to fibroscan, this is exactly the situation where I would never ask for a fibroscan. And do you know what happened? There was a person who came like this to, in fact, Fortis, and I was not there. Some of my colleagues, young colleagues had seen. They got a fibroscan done, acute hepatitis. And his value came as 67. And he, for 2 weeks, was distraught. He wrote his will and all that. He was told he has got liver cirrhosis. And after 6 to 8 weeks, he came back to me and he says, how long do you think I'll live? And his jaundice had regressed. So I said, you get another fibroscan repeated. And that time it had come down from 67 to 9. So I said, wait another 2 months, it will come down to 7. So he thinks I am God. Actually, I wasn't God. It was the stupidity of the doctors to get a fibroscan done during the jaundice. You mentioned it, and I think he mentioned it. During acute inflammation of the liver, the scan report, the LSM report is going to be high. Don't interpret it as fibrosis. Just like, for instance, if a person has got a right heart failure and he has got congestive hepatomegaly, his reports are going to be high. That does not necessarily mean that he has got liver cirrhosis. And I think that we have started over-diagnosing liver cirrhosis based on an elevated LSM value, which is to our detriment, actually. This is my view.
I think I'll go for history of herbs here. I'll still go for a fibroscan. I'll ignore the LSM value, but I'll evaluate the CAP value to see whether the patient has underlying fatty liver or not, whether that contributed to his deterioration.
See, the first question is this acute or chronic? in Asian continent, it's almost always chronic flare rather than an acute. You know, it's very rarely we see in a proper acute hepatitis B infection. So it's better to assume it's chronic. Plus, if you look at the other parameters for chronic is E antigen negative, E antibody positive. So that is something it's going to favor chronic hepatitis B. And as sir mentioned, he needs treatment. So
if his DNA was, instead of 2,400, if it was like 1,100, would you still have started him on tenofovir?
See, the question is,
or
what is causing the
the
bilirubin of
cutoff of
18.6? Why he is acutely jaundice? Is this on top of some other infection or drug-induced liver injury? So we need to ascertain the DNA level to the level of jaundice, although, and follow the previous pattern. So they may have done a DNA level, you know, maybe undetectable, or may have been higher and lower. So you need to know what pattern we are seeing, actually.
I mean, to be specific to that question, if his enzymes were in the range of 400, 500, and his IgM anti-HBC was positive, I may not have started an antiviral. I mean, that's the question I think that you are asking to the audience. If it is a well-proven acute hepatitis B, you have every reason to wait for a while because he might turn negative anyway. But here, you know, the value of IgM anti-HBC, the negative predictive value is pretty high. I mean, in the sense, you know, if it is negative, to my mind, it really almost excludes an acute hepatitis.
Absolutely.
Would you agree?
Absolutely.
Absolutely.
That's, yeah.
Even if it is an acute, or I would be very careful about what his INR is. I don't say an INR out here, because even if you have acute viral hepatitis, with that 18 bilirubin, if his INR crosses 1.5, no matter whether it's acute or chronic, you have to treat the patient. It's a part of the guidelines. You have to. So INR would be something very, very important. There is again a thought process where even with a normal INR, if the bilirubin is more than 10, and if it is a protracted course, means if it is going more than 4 weeks, even with acute, you would be wanting to treat this patient. Those are two exceptions. Encephalopathy and all of these are different.
Yeah, these, of course.
But
just to
with a low count, I would still treat. See, your question pertains to the fact that if you're doing a usual hepatitis B camp, you know, and you get an asymptomatic person who has come with a value of about whatever, less than 2,000 and enzymes just borderline elevated, then it's fine. But you know, he has got 10 days jaundice. So whatever it is, you can't ignore the role or contributory role, if not the main etiologic role of hepatitis B.
And the patient and the family
would
on their face that you have a 20 bilirubin and I will not treat you for hepatitis B. It's up.
This is it's perfect disaster.
I'll go with sir. I'll consider bilirubin more than the DNA level here, but I'll also consider two more things. Suppose the patient has immune suppressive condition. He's a CKD patient or uncontrolled diabetic. If I have a benefit of suspicion that he has acute hepatitis B, I'll probably still go for antiviral, and tenofovir alafenamide will be my choice.
And if this was more in favor of acute hepatitis B, and we still start antiviral therapy, would we check after 6 months whether he has cleared with HBsAg and anti-HBs titers?
Checking after 3 months, 6 months is your prerogative. Do as many, whatever you can, mindful of the cost. The question only is that do we have to put that label of whether it's acute or chronic, or is it enough to say hepatitis B at this stage? I would say hepatitis B at this stage because, you know, I'm not very sure. Let's put it this way.
Probably for prognostication long term, that's going to be relevant to which way we are thinking.
I will prognosticate after 2 weeks or 3 months when he comes.
I think this hepatology as a field, we have sometimes overcomplicated things. Look at where chronic Hep B normally is going. Normally it's going now possibly the correct way, no matter how much we debate about it. This is also a very similar thing, which based upon very underpowered, no studies at all, which hardly have very good evidence, these guidelines were made. And we have stuck to them like gospels. But we have never re-explored them because it's not a very common entity overall. So clinical sense, overall picture, they would all mandate treatment.
One thing, we have seen in HIV cases, that number of times they have changed the guideline. Sometimes CD4 was 300, sometimes it was 250, sometimes 500. Now it is test and treat. I believe someday we will also treat HBV when DNA is positive and start the treatment. And probably there should be the guideline in future. What I can.
That's common sense. In fact, I am very happy you said that, Pradeep. Encourage your students to do it. Absolutely. Sorry, he is here. You know, the last time I was in a panel discussion in Calcutta, there were 6 people on the dais, and he presented a case, and all of them had come prepared with at least 3 or 4 guidelines which they had read in great detail. And everybody was talking about the guidelines. My question, of course, I'm a very timid fellow when I go to Calcutta. My question would have been, what did you do for the patient? At least have the guts to commit and do something. That nobody was talking about. They were all talking about, you remember the case which you were presenting? So I fully agree with you. There's no harm in giving the antiviral here. And it's probably safer legally and in every other way to have done something. You have not done any harm, but you have probably done some good. Absolutely.
To give to the surgeons, if count is more than 200. So here also we can give considering that guideline also.
Absolutely, sir. And I urge everybody should go through the recent WHO guidelines for hepatitis B. If you understand it in details, it exactly means that if you have detectable hepatitis B DNA, you should treat them. That's it. That's what the basic substance of the current WHO guidelines
is. If you are starting with the antiviral, sir, in this particular case, if you start with the antiviral, which has been a good proposal, so how long it has to be continued? It's same thing like as that of chronic Hep B.
6 months. See, if it is acute, right, or there is a component of acute, or there is a reactivation in it which the body is trying to get rid of hepatitis B, what he was referring to, 6 months or 1 year down the line, he might actually turn HBsAg negative. And quite a few of them are success stories which we thought were chronic hepatitis B spontaneously seroconverted. No, I mean, they actually had their own inflammatory reactivations where the body cleared it. And during that flare, you can have this jump in bilirubin.
So once the HBsAg is cleared, you need to look for anti-HBs antibodies. So that's very important. If not, you need to vaccinate them or just wait and see. If they don't develop, vaccinate them. Most of them will develop.
Then, Jyotimani, one more thing. If we look at anti-HBs and if I do an anti-HBC total, I think both will be positive. Anti-HBs will be something like less than 10, 15. So then should I vaccinate? And say this case becomes negative, seroconversion. Anti-HBs 15 or 20. And or then 5, say. But anti-HB total positive at the same time. So should I vaccinate?
Less than 10 years. If it is less than 10, you can vaccinate.
In the presence of anti-total, I will vaccinate. Yes. Okay.
I think that brings us to the end of this session, and it has been a really wonderful and informative session. I think all of you will agree with me that when it comes to our panelists, they really have carried the session, and on behalf of all the audience, I thank them.
Can I, before you close on your behalf, request 2 other people for comments? Exceptionally bright people, but I'm trying my best for the last 1 year to get them to be a little outspoken, okay? So one of them is this fellow. So you have to give your views. You have kept rather quiet. And the other one I met just yesterday, and that is Sudhanshu, very bright boy. Sudhanshu, tumi ho na? Yeah. And you know, I asked him one question during that postgraduate meeting, and he came out with such a sensible, straight answer without mincing words. I mean, he's the type, he's keeping quiet. They should share their experience. So first you and then Sudhanshu. Sudhanshu, aja.
My comment on this case.
This or any of the cases?
No, previous 3 cases I commented, but I think hepatitis B is a little bit tough for me because I am basically a gastroenterologist and not hepatologist. Still, I think this is a case of chronic hepatitis B, which is acute flare. Because, see, IgM anti-HBC positive, it causes confusion, differentiating. But IgM, what sir said, IgM anti-HBC negative with such a low value, I think it's more in favor of chronic hepatitis. Chronic hepatitis deserves treatment, chronic hepatitis B, so this patient should be treated. And what you suggested, whether we should check HbSAg after 6 months, that whether this was acute hepatitis B, that is also very logical, because otherwise E negative chronic hepatitis B will need a treatment for a long period of time.
I think this is a case of acute and chronic hepatitis, and I should treat, because not every time we get the right result from the lab, because there may be some error. So the first thing that comes to my mind is I should treat the patient. The guidelines are there to guide us, is not forcing us. So we should not be carried out by the guideline. So regarding this patient, I will straightforward start treating him. No ifs and no buts. Whether it may be 1000 IU of SBB DNA or even 2000, in this case I would treat, because this is definitely a case of acute and chronic SBB. There must have been reactivation, but maybe that anti-SBC IgM was negative by default. There must have been some lab error.
I'll just make a brief comment about the session. Usually in big meetings, when you're placed here, we are very cautious about what we are saying, because the audience will come up and judge whether it was the guideline or the latest publication. So I thank Professor Dr. Pradeep Bhowmik, because it was a great learning experience for me. No one was judging me, and I could ask what I was feeling like, what I didn't know like. Thank you very much.
Yeah, thanks. But I'll propose a clap or a round of applause for Sudhanshu. A big round of applause. You see, he said one thing which I think that all of you should remember. Guidelines are guidelines. They are not diktats and they are not laws. So they are supposed to guide you if they help you in taking decisions. But they are not the ones on which you should completely bank your decisions or lack of decisions. I mean, you have to be the person at the bedside. You agree with that?
Absolutely.
So, closing remarks to you.
And one of the comment from my side, I think this is the way of presentation to the audience. They get much more interest with little interaction from their side. And presentation of these type of things, people are not attracted. What we could feel for last many years, this is the 7th conference we are having. So you must be appreciating that way of presentation. I think we people will be enjoying and feeling fruitful for us to capture it with a little participation. So you must think of this.
Thank you, sir. With permission from Dr. Bhowmik, we will close this session and probably close for the day too. Thank you, sir.
I would like to request our respected panelists to please felicitate our speaker with a memento. I would like to request Dr. Gurdas Chaudhary to please felicitate our other 4 panelists with his book.
Tomorrow, many of you will not be here. So we would like to felicitate our guests from Bangladesh, those who have come just today. And we had a plan to felicitate them tomorrow, but we will do it today itself because it's a big gathering. So I would like to name Dr. Abdul Rahim. Dr. Abdul Rahim, please. Dr. Sheikh Mohammed Noor Alam. Please. Ojidda, please come up. Divakar, please. Dr. Musarraf Mehtab, sorry. Dr. Musarraf Mehtab. Come. Mamun bhai, aap ki okay introduction kar dete na. She is daughter of Dr. Mamun. That is her. Mr. Mahmoodul Haq Wallab. Russell Aldin. Mr. Russell. None other than Mohammad Halaluddin, the true team leader and having great team spirit. Tanveer the great. Tanveer kudai. अच्छा तुम ये खेती कैसी लगी? Dr. Atikul Islam. Dr. Atikul Islam. Dr. Mobin, please. Mr. Binoy Bonik. Now I request Dr. Gordas Chaudhary, please hand over the books, those who have not received. Roxana. Ruxana Begum. I'm sorry. Sir, to lamba line ne kariye dito. Arko baki nito. Brother, you please hand over the books to our. So I request Dr. Gordas Chaudhary to please hand over the books to our doctors who are enquiring since yesterday. সবাই একটু উপরে চলে এলে we can have a big group photograph. সবাই একটু উপরে চলে এসো। এই সবাই চলে সবাই স্বপন আয় না কাম কাম
Hello. Check. Hello. Hello.
Hello. Hello.
We thank all of our wonderful dignitaries, audience, and delegates. We would like to announce that the cultural program shall begin in 10 minutes.
Hello. Hello. Check. Hello. Hello. Check. Hello. 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 Check. Hello. 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 Check. Hello.